Hello, dear friends. Very warm welcome to all of you at our conceptual brainstorming integrated session of anatomy. Myself, Dr. Shrikant Verma, faculty of anatomy at Cerebellum Academy. Yes, in this session, we are going to talk regarding the UPSC CMS 2023 anatomy MCQ. Yes, starting one by one. The first question: the inferior rectal artery is branch of 1, 2, 3, 4 options we are given. Try to catch this point with the three-dimensional orientation. The rectum anal canal, they are located within the pelvic cavity. You can see the abdominal aorta, which is dividing into the common iliac artery, then external and internal iliac artery. So internal iliac artery will supply to the different pelvic viscera. Now catch this image. Sir, this is our rectum. It is getting the arterial supply with the help of the superior rectal artery, which is direct branch of inferior mesenteric artery. Now this is our middle rectal artery, which is branch from our internal iliac artery anterior division part. Correct, sir. But in question, it had been asked the inferior rectal artery. Sir, inferior rectal artery is a branch from the internal pudendal artery, and this internal pudendal artery is a branch from the anterior division of internal iliac artery. So remember, the inferior rectal artery is the branch of the internal pudendal artery. This is the best answer. Now come to the next question. Which of the following statement with regard to the Meckel's diverticulum are correct? So this is the integration of anatomy with the patho, with the medicine, with the surgery. Yes, as well as you can say the radiology part. So try to catch the first point. It represents the persistent remnant of the vitellointestinal duct. Yes, it is true statement. Next, it is a pseudo diverticulum. No, sir. It is involving all the three layers. So it is example of true diverticulum. It is false. Next, it is most commonly found on anti-mesenteric border of ileum. Yes, it is just opposite to the attachment of the mesentery peritoneum. So it is correct. Next, heterotopic mucosa is present in 20% patient. Yes, in your literature, it is written that it is variable from 15 to 50% of the people. So your fourth statement is also correct. So your answer is 1, 3 and 4, which is given in C. Now come to the next. This is the rule of 2, which you will see in your medicine surgery part. The Meckel's diverticula, 2% incidence. The male-female ratio is 2:1. The two fit proximal to the ileocecal junction. Meckel's diverticula, it is 2 inches in length, and there is our 2% developed complication. Yes, and also remember the two types of the heterotopic mucosa: gastric mucosa as well as pancreatic mucosa. And what is the our incidence? Heterotopic mucosa present, that is 15 to 50% cases. Now after this, we are coming to the next important topic. Next question: which of the following set of the muscle collectively form the muscle levator ani that forms the pelvic floor? So here is the one three-dimensional orientation. You can see the right and left hip bone, and this is our sacrum coccyx part. So we are looking the pelvic floor part. Yes, can you observe? This is our rectum, also you can say anal canal, and here is the our muscle. This is our puborectalis, also you can say the puboanalis. Yes, this is our next pubic bone to the our coccyx bone. That's why it is pubococcygeus. And next is our yes ilium bone towards the coccyx bone. So this is the our yes iliococcygeus. These all the three muscles, they contract and they are responsible for the elevation of the anal canal. That's why this group of three muscles is known as levator ani. Just break the name and get the idea. Levator ani muscle. Now catch in the option. Sir, options are our ischiococccygeus. No, sir, not the ischium. Then pubococcygeus, correct, sir, pubic bone to the coccyx, and the puboanalis, also you can say puborectalis, and next is our iliococcygeus. Means levator ani is equal to, you can say puboanalis or puborectalis plus pubococcygeus plus our iliococcygeus muscle. So this is the group of the muscle. So answer is second, third and fourth. So you can see the second, third, fourth is given in option B. You can go with our Gray's Anatomy 42nd edition, page number 1245, where it is given levator ani means pubococcygeus plus iliococcygeus plus puboanalis, which is also known as the puborectalis. Also you can see the diagrammatic presentation from the Gray's Anatomy recent edition. At the center there is our anal canal, also you can say the rectum. So the first set of the muscle which is coming, which is taking origin from the pubic bone towards the rectum, sir, this is the puborectalis or puboanalis. You can see this particular group of muscle is coming from the pubic bone and going towards the coccyx, yes, pubococcyx, yes. And here you can observe the another set which is coming from the ilium bone and running towards the coccyx. So this is the iliococcyx, yes. So these three different sets of the muscle combinedly known as levator ani, because they are responsible for the elevation of the rectum and anal canal. Now come to the next question. Blood supply to the uterus comes from which of the following arteries? So remember, uterus is supplied by the uterine artery, but also it is showing the anastomosis at the upper side with the ovarian artery, as well as at the lower side with the vaginal artery. So answer is 1, 2, 3. So it is given in option A. So A is your correct answer. Now see the Grey's Anatomy 42nd edition. You can observe here, sir, this is our uterine artery. Yes, it is running along the lateral border and it is showing the anastomosis with the ovarian artery. Also this uterine artery is coming towards the vagina. It is anastomosing with the vaginal artery. So remember, the uterine artery is the best answer, but also participated by the ovarian artery, also the vaginal artery is contributing. So the single best answer among this all the options is our A, 1, 2 and 3. Now Gray's edition 42nd page number 1317, it is also saying that although there are anastomosis with the ovarian and vaginal artery, the dominance of the uterine artery. So it is clear cut saying uterine artery is the main artery, but also it is supplied by the anastomosis between ovarian and vaginal artery. So these are our anatomy question. At the last few motivating lines for all of you. The best way to predict the future is to create it. All the best. God bless you all.
Hello everyone, I'm Dr. Pooja, Physiology faculty at Cerebellum, and today I'm here to discuss the physiology questions which came in the UPSC 2023 CMS exam. So let's start with the first question. It asks that the ratio for the type 1 to type 3 collagen during maturation of collagen in remodeling phase is. Now understand, you should know what is the normal ratio. Normally what happens is type 1 is present maximally in the bone, but almost at all the places, because at all the places we do have basement membrane. Collagen 2, cartilaginous 3, it is only found in the uterus, bowel and vessels. So understand, overall ratio of the collagen 1:3 is more, and what it is saying that increased collagen production and breakdown continues to 6 months to 1 year after injury. The initial type 3 collagen is replaced by type 1 until the type 1:3 ratio becomes 4:1. So this is the Burnham-Levy saying, and that's why the answer over here is going to be 4:1. Let's move on to the next question. With reference to human body requirement for proteins, they are essential because they are 1, a key supply source for energy. Now understand, the key supply of the source of energy is carbohydrate and not the proteins. We are mainly dependent on the carbohydrate, and that's why generally we do have the cravings of the carbohydrate whenever we feel hypoglycemic. And after that, if the carbohydrates are not available, we break down the fat, and if that is also not available, as it happens in the starving conditions, it is going to be protein. That means we save it for the last. Why? Because they are the building blocks of our body. If we start breaking down the proteins, definitely it is going to be a drastic condition which we do not want. So this cannot be true. And if you know that, the answer is sorted over here. Required for maintenance of osmotic pressure within the intravascular compartment. That's true. We call it as colloid osmotic pressure, or also known as oncotic pressure. Now, if the oncotic pressure, let's say the proteins are less, the oncotic pressure hold on to the water. If the oncotic pressure is less because of the less protein amount, what is going to happen? The fluid will start leaking outside, and just outside the vessels we have interstitial space, and if the fluid start accumulating into the interstitial space, that is going to lead to something known as edema, right, which we do not want, and that's why the protein is required. Critical for upkeep of cell-mediated immune response, yes. Your immune globulins, what are they? Your proteins, right? So that is also true, vital for the synthesis of certain hormones. Yes, there are two types of main hormones, lipid soluble and water soluble. The water soluble, they are generally formed from the amino acid. Not only that, the various enzyme receptors, channels, proteins are important for all of them or their synthesis, right? So first is not correct, or rest three are correct. So 2, 3 and 4 is going to be the answer over here. Let's move on to the next question. Which one of the following distinguishes axonal degeneration from segmental demyelination in the electrophysiological studies? Just see this chart over here. I made it very, very simplified. Except this over here, that is sensory or motor amplitude. What you can notice over here is almost everything is normal over here. Even the conduction block and temporal dispersion is not present in the axonal degeneration. So what you can see over here, this is going to be prolonged over here, and the significant changes can be seen, and the conduction block and temporal dispersion is present in the cases of demyelination and not in the axonal degeneration. Now, what is temporal dispersion? We do the proximal versus distal compound muscle action potential. We see how much lag is there. If the duration of the proximal compound muscle action potential is increased by 20%, we call it as a temporal dispersion, right? So everything is going to be present in the demyelination, that means more severe condition. As that, you can remember this. Let's read out the option now. Distal latency is normal in the axonal degeneration and prolonged in the segmental demyelination. So that is true. Conduction velocity is slow in the axonal degeneration and normal in the segmental. That is not correct. Everything is more impaired in the segmental demyelination. Even the conduction block is present in the axonal. No, it is not present in the axonal. It is present in the segmental one. Temporal dispersion is prominent in the axonal degeneration. Not at all. It is absent in the axonal degeneration. So answer over here is going to be 1. Let's move on to the next question. Iodine has complex effect on thyroid function, very high concentration. That means when you give very high concentration of iodine, inhibit thyroid hormone synthesis and release. Now, what they are asking, whenever you give high amount of iodine, what has happened? There is decreased amount of T3 and T4 production. And this is known as off. That means someone turned off the thyroid switch. So we, by that we remember that it is Wolff-Chaikoff effect. There is one more effect, very, very important, Jod-Basedow effect. Jod, in Hindi, Jod means to add up. That means exact reversal is going to happen whenever you increase or you give lot many iodine. The negative feedback is not working, and that's why suddenly the T3, T4 level shoots up. So that is known as Jod-Basedow. So you can remember Jod means adding up, right? So see over here, simplified way, excess of iodine, when you give that, that is going to inhibit the organification, and Jod-Basedow exact opposite, that it is going to stimulate this organification. Let's move on to the next question. The volume of air remaining in the lung after normal expiration. Everyone knows this, right? You should know wherever you are going, whichever exam you are giving, you should know this, right? Normal resting breathing, forceful inspiration, forceful expiration, and then again normal breathing. Now, this is known as tidal volume. Whatever extra we are taking, that is IRV. We are not going to include the TV into that. TV is excluded. Same in the expiration, it is called as ERV, that is expiratory reserve volume. And no matter how forcefully you exhale, there is some amount of air which is going to be remaining in the alveoli, that is known as residual volume, right? But if the patient is expiring normally, that means even the ERV will be there inside the lung, and this is known as the functional residual capacity. We all know whenever we are going to add up 2 or more volumes, it becomes capacity. Okay, there is one more capacity which is vital capacity, which is given in the option, that is this one, IRV plus TV plus ERV. That is the vital capacity, whichever comes out, the maximal amount of air comes out during the spirometry, that is going to be the vital capacity, because RV never comes out. Okay, if you combine all of them, that is going to be TLC, that is total lung capacity, right? So obviously the answer over here is going to be FRC, right? So let's move on to the next question. Which of the following statements are true about PR interval? Now, what is PR interval? It is from the beginning of the P wave to the beginning of QRS complex. So here are some points. That is PR interval. If I draw the ECG wave, suppose this is a P wave, then comes the QRS complex. Usually we cannot see Q, right? So this is the T wave. So P wave, QRS complex, and T wave. Now understand, P wave denotes atrial depolarization, QRS ventricular depolarization, and T wave is ventricular repolarization. Everybody know this, right? But they're asking about this interval. This interval is specific for the AV node. We have to see how much time it takes from the atrial depolarization to the ventricular depolarization, right? So it is the time between the atrial depolarization to ventricular depolarization, and not the atrial depolarization alone, right? Normally it is 0.12 to 0.2 seconds, right? That is 3 to 5 small squares. And if it is more than 0.2, that is going to be first degree heart block. It denotes atrial depolarization? No. It is true that the normal duration is it should be point over here. Prolongation denotes impaired AV nodal conduction. That is also true. Short PR intervals occurs in WPW syndrome. That is also true. Why? Because there is a delta wave which is coming, right? Rather PQR, it looks as if there is early Q occurs, right? There is elevation of baseline, and that's why the PR interval shortens up, right? So 2, 3, and 4 is correct over here. Let's move on to the next question. Which one of the following hormone is responsible for gallbladder contraction? We talk about two things, choleretics and cholagogues, right? So choleretics, I'm writing like this, and cholagogue. Now, what do you mean by choleretics and cholagogue? The choleretics, which increases the secretion of the bile, and cholagogues cause the gallbladder contraction. So they are asking about the cholagogues, and that is none other than CCKPZ or cholecystokinin, right? So that is all about the physiology discussion. I hope you got the concepts. Thank you very much.
Hello everyone, this is Dr. Govind Rai Garg, and we will discuss now UPSC Combined Medical Services Pharmacology question, the exam which was held on in July 2023. Okay, coming to first question, which statements are correct for the treatment of chronic hepatitis B with pegylated interferon? So what is correct about interferon? First option, pegylated interferon is poorly tolerated as compared to nucleoside analogs. This is absolutely correct, because pegylated interferons have lot of side effects. They cause infusion related reactions and many more problems. Many people are not able to tolerate. On the other hand, nucleoside analogs like tenofovir or other drugs which are available, they are much more safer. Resistant to treatment with pegylated interferon is common than nucleoside analog. This is totally wrong. In fact, interferons are important because usually resistance do not develop to them. Okay? So if other treatments fail, we will go to pegylated interferon. Pegylated interferon is not useful in cirrhosis. This is again a correct statement. Usually we avoid these in patients of cirrhosis. And pegylated interferon administered every 48 weeks. Yes, it is again correct. Every week for 48 weeks is the treatment duration. So that is also correct. So if you see the options 1, 3 and 4 are correct. So answer is A. Okay. So you need to see in this type of questions, which is multiple type options type of questions, you can see that most of the options contain 3. We will discuss in further. When the options are 3 in all the 4, then you usually need to find out which is the wrong option. So we'll come to that. So here the answer will be A, 1, 3 and 4. Okay. Moving to next question. Which drug helps to maintain abstinence by reducing craving? So that is the standard question. We all know which drugs reduce craving of alcohol. Yes, none of the above. None of the above. None of the above can reduce the craving. So N means naltrexone. O is ondansetron, T is topiramate, and A is acamprosate. So these are the drugs which decrease craving in alcoholics. So among the options, the answer is acamprosate. Okay. Now the next question, this is easy one. BCR ABL oncoprotein exhibit constitutive activity of which enzyme? So this is very easy. We know that when there is translocation 922, on one chromosome there is presence of a gene called as ABL. On second there is presence of a gene called as BCR. So when there is translocation, both of them come on one chromosome known as Philadelphia chromosome. So in Philadelphia chromosome there is ABL BCR fusion. So this fusion will lead to formation of ABL BCR oncoprotein, and this oncoprotein, it will activate a tyrosine kinase, and this tyrosine kinase lead to chronic myeloid leukemia, CMS. So if we inhibit this tyrosine kinase, we can treat CMS, and the drug of choice for this is imatinib. So imatinib is a drug of choice for chronic myeloid leukemia. So coming to the question, which enzyme is activated? So simple answer is tyrosine kinase. Okay. Moving to next question, which is again related to this. Imatinib, dasatinib, nilotinib, ponatinib. So remember, any drug whose name end with nib, it is a tyrosine kinase inhibitor. Drugs ending with nib are tyrosine kinase inhibitors. So answer is tyrosine kinase inhibitors. And nibs, they are used for many type of cancers, but particularly these 4 nibs which are given in the options, they are used for chronic myeloid leukemia. They inhibit tyrosine kinase activated by ABL BCR fusion. Okay. Moving to next question, which is the drug of choice for schistosomiasis? We know schistosoma is a platyhelminthes, and remember the drug of choice for all platyhelminthes, that means all the flukes and all the tapeworms. The drug of choice for all of them is praziquantel. We have one exception in both of them. The schistosoma is a fluke, so drug of choice for schistosoma is praziquantel. So that is the answer. Exception in the flukes is liver fluke, which is called as Fasciola hepatica. Drug of choice for fasciola is triclabendazole. And tapeworm exception is dog tapeworm. The drug of choice for dog tapeworm, that means Echinococcus granulosus, is albendazole. So except these two, for all other the drug of choice is praziquantel. So for schistosoma it is praziquantel. Okay. Moving to next question. Which insulin has longest duration? So longest duration you just need to remember. So datamir, glargine, D-gludac, all three are long acting insulins, and the longest acting is D-gludac. Longest acting insulin is D-gludac. Okay. Now, which statement is true regarding SGLT2 inhibitors? So SGLT2 inhibitors examples like, yes, the drugs ending with gliflozins like canagliflozin, dapagliflozin like drugs. So we'll see the options. They are used in type 1, type 2 and pancreatogenic form of diabetes. Absolutely wrong option. Remember, they are used only for type 2 diabetes. We do not use them for type 1 diabetes. Only drug which is used in type 1 diabetes is insulin, and another drug approved is pramlintide. Okay. Then they cause increase in blood pressure. Again, it is wrong. Remember, they are diuretics. They are causing loss of glucose in the urine, so water follows. So diuresis will result in decrease in blood pressure. So rather, they are preferred in hypertensives. They do not increase, they decrease blood pressure. Their glucose lowering effect is dependent on insulin secretion. No, it's wrong. They are independent of insulin secretion. They are not insulin secretagogues. They directly help in excreting the glucose in the urine. Clear? So this is dependent on insulin is wrong. Euglycemic diabetic ketoacidosis may occur. Yes, this is the right thing. Remember, we discussed in our videos also, SGLT2 inhibitors, they will control the blood sugar, but they are not releasing insulin. So that means if a person has type 1 diabetes and we give these drugs, then blood sugar will remain normal, person will be euglycemic, but still there will be ketoacidosis because insulin is not there. So that is known as euglycemic diabetic ketoacidosis. Okay. So the correct answer is last one, other three are wrong. Okay. Moving to next question, which anti-diabetic drug may cause weight gain? So before going to this question, see the options. Options are 1, 2 and 3, 1, 2 and 4, 1, 3 and 4, 2, 3 and 4. That means in all the 4 options, there are 3 statements. Okay. So only one is missing. So you can make it all which may cause weight gain. So you may say except. So first we will need to find out which do not cause weight gain. Clear? So if we see that glimepiride is a sulfonylurea is cause weight gain. Pioglitazone is a glitazone. Glitazone cause sodium and water retention that lead to weight gain. Insulin is an anabolic hormone. It cause weight gain. Clear? So by ruling out, the answer is sitagliptin. Sitagliptin do not cause weight gain. It is a weight neutral. Neither it increase weight nor it decrease weight. Clear? So sitagliptin is not. So that option will be answer in which 4 is not there. So that means 1, 2 and 3 are correct. So answer will be this 1, 2 and 3. Okay. Moving to next question. Which of the following drug is useful, this is misspelling, in the treatment of listeria? Listeria monocytogenes. Remember the drug of choice for listeria is ampicillin, and usually it is given in combination with gentamicin. So ampicillin gentamicin combination is a drug of choice. And if this is not effective, or suppose we have allergy to ampicillin, then we use trimethoprim sulfamethoxazole combination. That means co-trimoxazole. So that is the treatment of listeria monocytogenes, and rarely we can use vancomycin, but normally not required. So you need to remember drug of choice is Ampigenta, and if we cannot give that, it is co-trimoxazole. So now coming to question, which are useful? Okay, so gentamicin is useful, ampicillin is useful, sulfamethoxazole is useful. Remember, ceftriaxone is not effective. That's why in listeria meningitis, whenever we are suspecting, apart from ceftriaxone, which is used for other conditions, other organisms, we add ampicillin to cover listeria. Okay, so answer will be 2, 3 and 4. So 2, 3 and 4 are effective. Okay. Now next question is, which drug is recommended for weight loss? So another question on weight loss in obese patients. Remember, for weight loss, only drug which is approved among the anti-diabetic is liraglutide group of drugs. So these are nothing but GLP-1 analogs. They cause weight loss. And you can see from the options the other drugs. Glimepiride is sulfonylurea. It causes weight gain. Sitagliptin is weight neutral. We discussed earlier also. And insulin causes weight gain because it is an anabolic hormone. So by ruling out also, you can mark the answer as liraglutide. Okay. Now next question. 4 options are given. Then which can be used for thyrotoxicosis crisis? Now this is very easy question. If you see, the crisis means hyperthyroidism. Thyrotoxicosis, hyperthyroidism. So in hyperthyroidism, obviously we will not give thyroid hormones because already they are in excess. So liothyronine, which is a T3, it cannot be used in hyperthyroidism. So any option which contains T3, that means option 4, that cannot be the answer. So we can rule out this option. 2, 3 and 4 cannot be the answer. Okay. Now which is used, they have asked. Propranolol is a beta blocker. It will control the symptoms of hyperthyroidism. Sodium iodate, it inhibits the release of thyroid hormones, can be used. Propyl thiouracil is antithyroid drug, obviously it can be used. So answer, we can use R 1, 2 and 3. So that is the answer. So if you know that liothyronine is not used, you should mark the answer. Okay. Now next question, same question. Which drug may be included in treatment of myxedema, comma? So opposite. So that means which is used in hypothyroidism. Myxedema is hypothyroidism. So in hypothyroidism, we use T3 or T4. So if we see liothyronine is T3, levothyroxine is T4. So obviously we will not use anti-thyroid drugs. Anti-carbimazole is antithyroid, sodium iodate is antithyroid, we cannot use. So answer will be 1 and 2. So this is the answer. Easy question. So moving to next question. Which of the following are adverse effects of loop and thiazides? So and we know the adverse effect of loop and thiazides. So they cause loss of all the ions in the urine. All the ions means sodium, potassium, magnesium, hydrogen, all will be lost. So there will be hyponatremia, hypokalemia, hypomagnesemia, and when protons are lost, it will lead to metabolic alkalosis. So that is the common side effect of both of them. And further, they are causing loss of water. So that can lead to hypovolemia. So these are the important side effects. So if we see the options, again see the question, the final question, options are 1 2 3, 1 2 4, 1 3 4, 2 3 4. So that means only one we need to find out which is wrong. So all are side effect except which is not a side effect. So it is easy, answer is metabolic acidosis. Remember, it is causing alkalosis. So hypovolemia, hyponatremia, hypokalemia it causes. So acidosis is not caused, alkalosis is caused. So that will be the answer in which one is not present. So that means 2, 3 and 4 is the answer. Okay. Moving to next question. All are effective in preventing uric acid nephropathy in patient receiving chemotherapy. So basically, which drug decrease uric acid? Okay. So if we see again the options 1 2 3, 1 2 4, three options are there. So we need to find out one drug which is not used. So it's very easy. The answer will be acetazolamide. Remember, acetazolamide is a carbonic anhydrase inhibitor. It will cause alkalinization of the urine, and in alkaline urine, uric acid get precipitated. So it will be avoided rather. So it will alkalinize the urine and precipitate uric acid in the kidney. So if we see probenecid, it is a uricose uric agent. Forced saline diuresis may remove the uric acid, and rasburicase is a uricase enzyme, it metabolize uric acid. So all these three can be used, 4 cannot be used. So answer will be 1, 2 and 3. Okay. Now next question is very easy. Primaquine destroy the hypnozoites at which place? So where hypnozoites are present? Remember, this is the blood, this is the liver. So in the blood there is RBC. So in the RBC we have the primary stage. We can say in the RBC there are substances which are causing the active disease. It is causing responsible for symptoms. Okay. So in the RBC there is presence of Shy-Jones. Whereas in the liver there is presence of hypnozoites. Hypnozoites are responsible for relapse of malaria. So primaquine kill these so that relapse do not occur. That's why primaquine is drug of choice for radical cure of Plasmodium vivax malaria. So answer is simple, it is a liver stage. Okay. Moving to next question. This is just to rectify urinary alkalinization as a method of enhancing excretion for poisoning. We know acidic drugs, weakly acidic drugs like aspirin or phenobarbital. These are acidic drugs. Their excretion can be made by making the urine alkaline. Now question asked is, what do you mean by alkaline urine? Normal pH of the urine is nearly 6. In case of urinary alkalinization, we make it between 7.5 to 8. Okay. So we want to keep it, we do not want to make it too much basic. So it is between 7.5 to 8. So answer will be this, urine pH 7.5 to 8. Okay. Moving to next question. Which drug is associated with calciphylaxis? So first question is, what is calciphylaxis? Calciphylaxis, what happens, it's a life-threatening disease, usually seen in a patient with chronic kidney disease. So what happens, calci, as the name says, there will be calcifications of the blood vessels, particularly blood vessels supplying the fat tissue. There is calcification, and along with that there is thrombosis, and that lead to death of that area, necrosis of that area, particularly in the skin over the area containing fat like stomach, thighs. There will be necrosis of the skin. Okay, so it is also known as calcified uremic arteriolitis, arteriolopathy we can say. So basically the most important vessels affected are arterioles. Now why it happens, it is assumed that vitamin K normally involved in activation of an enzyme known as matrix glial protein. So this protein, it is involved in preventing the deposition of calcium in the blood vessels. So when we give warfarin like drugs, warfarin will inhibit vitamin K. So this protein will not be activated, and when this is not activated, it will result in calcification in the blood vessels. Plus we know warfarin initially can cause thrombosis, so this lead to thrombosis which can result in calciphylaxis. Okay, so the answer to this question, which drug causes, is warfarin. Okay, so non-calcium based phosphate binders are protective, but calcium based binders are damaging. They can also precipitate, but the answer to this question will be warfarin. Okay, now moving to last question. Which insulin has cloudy preparation? So cloudy preparation, that means insulin is not clear. So before giving, we need to shake it and then we need to give. Okay, so that is lente insulin. Lente insulin is made of 70% ultra lente and 30% semi lente. This combination is called as lente, and this is a cloudy preparation. We need to shake it and then we need to administer. Whereas other three, glargine, detameric, d-gludac, are very long acting insulins. And similarly, there are very short acting insulins like Lispro, Aspart, and Glulysin. So all of these, they are clear solutions. They are clear. They are not cloudy. Whereas cloudy is lente, and another one which is cloudy is NPH insulin. Okay. So these are the important points regarding the pharmacology questions asked in the UPSC exam. Okay. Thank you very much.
Hi friends, we are going to be having a discussion about the questions from the subject of pathology which are asked in the UPSC CMS 2022 examination. Now, before I start the discussion, just a gentle reminder of the fact that this is one of the most prestigious exams that is conducted throughout the country. If you see the syllabus of the exam, it is going to be containing medicine and allied subjects, surgery and allied subjects, obstetrics and gynecology, we have pediatrics, and we are having a very important topic of, or the chapter or the subject of the public health or the preventive and social medicine. Out of the questions which were asked in the exam, 200 questions in total, about 30 plus questions could be solved only from the subject of pathology. Why do I talk about this? Is only just as a gentle reminder to remind you of the fact that no matter what is the likely pattern shift which is going to take place in the exam subsequently, the subjects of your second professional, particularly pathology and pharmacology, are going to remain the backbone as ever. In other words, what I intend to tell you is that if you have a good grasp over these subjects, even from a total of 200 subjects, you can easily crack almost like 60 to 70 questions. 60 to 70 questions means 35% of the paper is stat within your reach if you are able to ace just these two subjects, pathology and pharmacology. Just to give you examples, we'll start the discussion on the questions so that it is more clear to you what I'm talking about as the relevance of these subjects. Talking about the first question, which of the following statements regarding inflammatory bowel disease is correct? Now read the questions statement carefully one by one. Rectum is always involved in a patient having Crohn's disease. We need to remember rectum is in fact spared in a patient having Crohn's disease. Fistula formation of ulcerative colitis is incorrect again because fistula tracts formation are associated with fragile bowel, which is more characteristically seen with transmural inflammation, which is associated with Crohn's disease. Stricture formation is common in ulcerative colitis. Again, incorrect statement for the simple fact stricture formation is more common in case of Crohn's disease. But when I talk about perianal disease is common in Crohn's, this is absolutely correct because perianal presence of fistula formation is something which is very, very characteristic of Crohn's disease. So option 4 or option D over here is going to be the best option. Looking at the next question, Schiller-Duval body is characteristic histological feature of which of the following cancers? Again, an example of a question which is so very standard when you talk about the Schiller-Duval body, also known by the name of the glomerular body. That's a characteristic feature of a patient suffering from the endodermal sinus tumor. Recall from our discussion in the main videos that the endodermal sinus tumor is going to be having alpha fetoprotein and alpha 1 antitrypsin as the tumor markers, right? That is what we need to be familiar with so far as this question is concerned. Talking about the next question, which is the following are blood values of iron deficiency anemia. Serum iron is less than 30 microgram per deciliter. This happens to be true because if you are talking about a normal individual, the range is somewhere between 60 to 170 micrograms per deciliter. So obviously 30 value is going to be less than normal. If I'm talking about total iron binding capacity is less than 400 micrograms per deciliter, this is in fact going to be important for you to understand that this is incorrect for the simple reason that total iron binding capacity in a patient having iron deficiency anemia is going to be increased. If I just have to talk about the normal values, you would be aware of the fact that around 250 to 450 micrograms per deciliter is a normal value of the total iron binding capacity. If I talk about option C, third option, percentage transfusion saturation is 10 or less. This is again going to be true because as we talked about physiologically it is anywhere around 33%. So I would say in the range of around 30 to 40%. If I'm talking about the serum ferritin is below 30 micrograms per deciliter, you need to remember the fact that this is again going to be true because serum ferritin values is going to be reduced in a patient who is going to be having iron deficiency anemia. In fact, it is one of the earliest indicators out of the given 4 parameters that we talked about in context of iron profile. Now, with that background, it's easy for understand that the options 1, 3 and 4 are correct, and therefore the important answer for the question happened to be option C over here. Talking about the next question, which of the following is correct regarding blood substitutes. Now, when you talk about blood substitutes, please understand the fact that they are example of substances which are going to be administered to an individual in the absence of availability of blood. Option A, they are examples of biomimetics. This is absolutely true. Any substance which is going to be given as an alternative to the biological system or a substance is going to be given the name of a biomimetic. They are extensively used in war injuries. In fact, is going to be an incorrect thing for the simple fact that we had a lot of enthusiasm in the development of the blood substitutes, but what we found out was that they were either responsible for causing too many adverse effects or they were not responsible for reducing the rate of mortality, so they are not extensively used. If I talk about option C over here, the third is they are made up of perfluorocarbon emulsions. This is true. In fact, what the take home message over here is that these are examples of emulsions, which means that they are not readily water soluble, so they are extremely small in size, and then they have to be available in the form of an emulsion so that they do not cause any kind of a trouble in the body. If I'm talking about option 4, they are hemoglobin based. This is again going to be true. In fact, I want you to remember that such kind of blood substitutes are going to be given the name of HbOC, which means hemoglobin based oxygen carriers. So when we are talking about the options over here, we understand the fact that option 1, option 3 and option 4 are correct, and therefore the answer for the question happens to be option C over here. That is what we need to be familiar with so far as the blood substitutes are concerned. Talking about the next question, if on amniocentesis the alpha fetoprotein levels are found to be elevated in the amniotic fluid, this defect is like in the fetus is likely to be associated with. So when you talk about elevated values of alpha fetoprotein, you read that in pathology, you read that in obstetrics and gynecology as well, friends. We have discussed about this particular discussion in the topic of the female genital tract as well as in genetics. Elevated alpha fetoprotein is very much suggestive of neural tip defects including anencephaly, and therefore that would be a straightforward question. The answer happens to be option 2 over here. When you talk about the next question with reference to the occupational cancers, consider the following statements. Skin cancer is a common occupational hazard in workers employed in nickel and chromium work is incorrect. Yes, I understand the fact that people working in nickel and chromium factories are at high risk for development of lung cancers. If I talk about option B, cancer of the bladder is an occupational hazard in workers employed in dye stuffs and dyeing industry, this is absolutely true. Leukemia can occur on long-term exposure to benzol. In fact, we need to be familiar with what is benzol. Benzol is a combination of benzene plus toluene, and yes, this is something which is present as a substance in the exhaust fumes of automobiles. So it is a known risk factor for development of blood cancers or leukemias. This is absolutely correct. If I'm talking about option 4, that lung cancer is typically found in workers employed in electrical cable industries, no, because electrical cables are going to be having an association with something like the polyvinyl chloride or the insulation, and that is something that you would be associating with something like a hepatic angiosarcomas. So over here, option 2 and option 3 are definitely known to be correct, and therefore my answer of choice over here is going to be something like option B. Just so that you can remember and recall what has been given in our textbook as well. As what I said over here, when we are talking about something like benzene exposure associated with high risk of development of acute myeloid leukemia, that is a potential question for the exam. Whenever we are going to be talking about people working in the chromium or the nickel compounds, they are at high risk of development of, as you can very well see clearly over here, that's lung cancer. Anytime the patient is going to be having an exposure to something like the vinyl chloride, there is an increased risk of development of hepatic angiosarcoma. That is what we need to have an idea over here. So whenever we're going to be talking about such questions, we have to be cautious of the fact exactly what is the aim of the examiner. He just is testing your basics. Never ever goof up on them. Just keep on revising all the data that we have talked about in the main videos. Talking about the next question, Zollinger-Ellison syndrome is characterized by which of the following? Yes, it is an example of a condition where the patients are going to be having a hypersecretion of gastrin. Is it going to be associated with fulminant gastric ulcers? It is absolutely true. So patients are at high risk for development of peptic ulcer disease, that is going to be affecting the stomach as well as the duodenum. So gastric ulcers are going to be frequent. Recurrent ulcerations despite treatment is again going to be true, that the patients are being given drugs like proton pump inhibitors, but in spite of that, patients are going to be having a development of recurrent ulcerations. Non-beta islet cell tumor of pancreas is again going to be true. In fact, that is what a lot of you can understand and recall, is what is going to be associated with the term gastrinomas. So that is what we need to have an idea. Now, recurrent episodes of dysentery is incorrect. I understand the fact the patients can be having a development of malabsorption, and that malabsorption could be resulting in the development of something like diarrhea. But please be familiar with the fact that you are not supposed to confuse diarrhea with dysentery, and therefore options 1st, 2nd and 3rd are correct, and therefore the answer of choice over here happens to be option A. Now, just for the purpose of recall, how exactly would you manage a patient having a gastrinoma? You would try to go in for something like a surgical excision of the affected area. In case for some reason surgery is not possible, please understand the pharmacology link. Then the patients are being treated with the help of anti-cancer drugs, and amongst the most important anti-cancer drugs, you would be giving these patients a drug like doxorubicin, or you would be giving a drug like streptozocin. So that is what is to be remembered so far as the Zollinger-Ellison syndrome is concerned. Talking about the next question, which of the following statements are correct with regards to familial adenomatous polyposis? It is associated with mutation of the APC gene. This is true. Present on the short arm of chromosome 5. Chromosome 5 is correct, but then not present on the short arm, it is present on the long arm. If I am talking about it is inherited as an autosomal recessive condition, definitely incorrect, because this is an example of an autosomal dominant condition. Associated with 100% lifetime risk for development of colorectal carcinoma happens to be a true statement. When we are talking about congenital hypertrophy of the retinal pigment epithelium is present in half of the cases of familial adenomatous polyposis, this is again going to be true. Now, the issue was that when you had look at the options given in the question paper, we had actually out of these four, option third and option fourth which were to be correct. But then when the options were seen in the examination, people had a confusion because yes, option 3 and option 4 are correct. So either the answer has to be from C or option D. That is agreed. Now, the point is that from where has the examiner taken this particular data, and after a lot of research I found that it has been taken from the textbook of surgery, because Bailey and Love is the only textbook which makes a mention of the fact, in fact incorrectly, that this is a condition in which is the APC gene is going to be associated with its location on the short arm of chromosome 5. So presumably the examiner had set the paper from that period textbook and therefore has given this as a wrong question, and therefore presuming this to be a question from the surgery book, we would go for the answer as option 1, 3 and 4, and therefore amongst the given options, the best answer over here happens to be option C. Factually speaking, however, if you have to look at the answer, it would have been only option 3 and option 4 over here. Talking about the next question, who amongst the following has a second phase characterized by progressive massive fibrosis? So we understand the fact that patients who are going to be working in the coal mines, they are initially asymptomatic, subsequently they become minimally symptomatic with the presence of coal macules and coal nodules, and there would come a stage after many years of exposure when the patients are going to be having a progressive fibrosis of their lungs irrespective of the exposure of the coal dust. So over here, when we are talking about the progressive massive fibrosis, it is going to be seen as a complication of a patient who has earlier suffered from a condition like anthracosis or an exposure to something like coal dust. So that is what we need to have an idea. That is what is the answer of the question over here. Talking about the next question, functional pituitary adenoma most commonly arises from which of the following cells? Two types of questions which the examiners love to ask you from pituitary adenomas. One, the definition of a micro and a macroadenoma. So microadenoma is less than 1 centimeter, macroadenoma more than 1 centimeter. Secondly, pituitary tumors can either be functional tumors or they can be non-functional tumors. The most important tumor is going to be associated with secretion of prolactin, and whenever we think in terms of prolactin secreting tumor, the obvious answer happens to be option B over here. That would be something like a lactotroph. Talking about the next question, low serum thyroglobulin levels are going to be seen in. We just need to remind ourselves of the basic concept. Thyroglobulin is going to be attaching itself with iodine, and that is going to be responsible for the formation of T3 and T4. This reaction is going to be facilitated by the presence of something like the thyroid stimulating hormone. Now, if you understand that fact, we just need to be familiar with any condition where you have a hyperfunctional thyroid. That is likely to be associated with elevated levels of T3 and T4, and that is what is going to be associated with usually the presence of a consumption of something like thyroglobulin and iodine. So we need to be familiar with the fact that when you're talking about a condition like, let's see the options, thyrotoxicosis factitia. Thyrotoxicosis factitia is an example of a condition in which the patients are going to be having an intake of certain kind of hormones or supplements which are going to be containing thyroid hormones. So when there is a hormone supplementation, say for example somebody goes to a gym and they claim to cause some kind of a weight loss, and the person takes this kind of a so-called supplement powder that is responsible for causing a secretion of the thyroid hormones, and these are responsible for, by the feedback inhibitory mechanism, they are responsible for causing a decrease in the concentration or the decrease in the release of something like TSH. Now when there is going to be a decrease in the TSH, this is what is going to be associated with a decrease in the formation of something like a thyroglobulin level. So this happens to be the answer over here. Now explaining the other options, if I talk about subacute thyroiditis, subacute thyroiditis is going to be characterized by a damage to the thyroid follicular cells. When there is a damage to the thyroid follicular cells, the thyroglobulin is actually going to be released from the thyroid, and that's going to be associated with an increase in the value of the serum thyroglobulin. Any patient who is going to be having the presence of a functional thyroid, Graves' disease, the gland is more active. It is so active that it is responsible for causing more synthesis of thyroglobulin, and therefore the levels over here are going to get elevated. Similarly, a patient who is going to be having a toxic multinodular goiter, that means that there is a presence of toxic, means it's a hyperfunctional gland that is going to be producing more amount of T3, T4, and therefore too much of production of thyroglobulin as well, which is going to be secreted from the gland. So options 2, 3 and 4 would be associated with high serum thyroglobulin levels, whereas thyrotoxicosis factitia is an example of the only condition in the given option where the thyroglobulin levels are going to get reduced. Talking about the next question, tall, thin adolescent boy is found to have gynecomastia and small testes. His blood testosterone levels is undetectable and the serum FSH and LH levels are elevated. Almost the kind of a question which I presume has been taken straight from the discussion that we had in the specific cytogenetic disorders in the topic of genetics. Now, when we talk about the presence of low testosterone levels, presence of a very small size testicular tissue, that is going to be associated with absence of feedback, and that is going to be responsible for causing an increase in the FSH and LH. Also, we understand the fact that because the testosterone is less, FSH, LH is going to be more, that is associated with more formation of estrogen. That would explain the development of something like gynecomastia. Tall, thin adolescent boy having these manifestations, I hope the diagnosis is absolutely clear to majority of you. That's Klinefelter syndrome. And if the diagnosis happens to be clear to you, that is Klinefelter syndrome, we just need to be familiar with what exactly is going to be the karyotype expected in such patients, that is 47XXY. Understandably, 46XY is something that is going to be a normal thing. When you talk about 45XO, that is Turner syndrome. When you talk about trisomy 21, that happens to be Down syndrome. So the answer over here for the question is absolutely clear. That's option 3rd. Talking about the next question, consider the following statements regarding inflammatory bowel disease. In fact, we got a question in the exam, hepatitis and inflammatory bowel disease, two of the, I think, for some reason, the love topics of the examiners for this particular exam. Ulcerative colitis involves terminal ileum and rarely causes proctitis is a false statement, because ulcerative colitis, as explained in the video, actually begins from the rectum and then it goes in a retrograde fashion, causing pancolitis. Cobblestone mucosa of the bowel is seen in Crohn's disease is something which is going to be true. That is what we need to be familiar with over here. When we are talking about skip lesions are a characteristic of ulcerative colitis but never seen in a patient suffering from Crohn's disease, this is something which is going to be incorrect, because skip lesions are a finding of a patient suffering from Crohn's disease and not in case of ulcerative colitis. Ulcerative colitis is more commonly seen in case of smokers than in non-smokers. It is in fact incorrect for the simple reason that smoking is going to be protective for ulcerative colitis. So out of the 4 options given, only the second option was correct, and therefore the answer for the question happened to be option D over here. Again, an example of a question which is a reminder to the fact that when you are watching the main videos, please develop your concepts thoroughly, because such are the questions which are likely to be given to you in the subsequent pattern of examination as well. Talking about the next question, which of the following diseases affects predominantly large arteries? When you talk about the large vessel vasculitis, we have just 2 important examples, temporal arteritis and Takayasu arteritis. Now looking at the options over here, temporal arteritis is also known by the other important name of giant cell arteritis, which is going to be there for the answer of choice over here. If you look at option 1, that is granulomatosis with polyangiitis, that's a name given to Wegener's, which is an example of a small vessel vasculitis. Polyarteritis nodosa is an example of a condition affecting medium-sized vessels, and eosinophilic granulomatosis with polyangiitis is Churg-Strauss syndrome, again an example of a small vessel vasculitic disorder. With regards to the next question, with regards to transfusion therapy, cryoprecipitate is a rich source of which of the following? So cryoprecipitate is rich in case of fibrinogen, that's agreed. Is it a rich source of clotting factor 8? The answer is yes. Is it a rich source of clotting factor 9? The answer is no. Von Willebrand factor? The answer is yes. So options 1, 2 and 4 are correct, and therefore the answer of choice over here happens to be option B, that is cryoprecipitate rich in von Willebrand factor, fibrinogen as well as factor 8. In fact, when we talk about the component of the blood that is rich in clotting factor number 9, that happens to be something like fresh frozen plasma. Talking about the next question, which of the following correctly describes the mode of inheritance of hemophilia B? So hemophilia B, which is also given the name of Christmas disease, as we talked about in the section on hematology, it's an example of an X-linked recessive condition. The answer of choice over here happens to be option 4. Talking about the next one, which of the following conditions is characteristically may present with a triad of hemolysis, pancytopenia and venous thrombosis? That's going to be straightforwardly answered by you as paroxysmal nocturnal hemoglobinuria, the condition in which we are going to be having a PIGA gene defect, in which the cause of mortality in the patient happens to be the development of hepatic vein thrombosis or Budd-Chiari syndrome. Talking about the next one, which of the following is associated with low MCV in the red blood cells? So that means microcytic anemia. When you talk about microcytic anemia, in the given options, thalassemia happens to be the answer of choice. Vitamin B12 and folic acid, of course, is going to be associated with MCV value, which is going to be more than 100. When you talk about sickle cell anemia, it's an altered shape, and therefore it is going to be an example of a normocytic anemia. Answer of choice over here happens to be option 1, thalassemia. Talking about the next one, which of the following is correct with regards to alpha-1 antitrypsin deficiency? Prolonged jaundice in the neonatal period can be true because the patients are going to be having the involvement of the lungs, which is going to be associated with high risk of development of emphysema, and the patients are going to be having micronodular cirrhosis. In fact, when we are talking about this condition, this is an autosomal recessive condition characterized by damage to primarily these two organs. So, prolonged jaundice in neonatal period can be seen in this condition. Pulmonary adulthood emphysema can be seen, of course. Paniculitis is seen rarely. In fact, this is also going to be true because paniculitis is presence of lesions under the skin, and it is not a manifestation of alpha-1 antitrypsin deficiency in general. Autosomal dominant disorder, no, it is an example of an autosomal recessive disorder. So options 1, 2, 3 are correct, and therefore we need to understand the answer over here happens to be option A. Talking about the next one, which of the following is a manifestation of vascular phenomena in modified Dukes criteria. Now, when we talk about modified Dukes criteria, we have the major criteria and the minor criteria. In the major criteria, you have got echocardiography findings as well as a positive blood culture. In the minor criteria, you have presence of fever, you have embolic phenomena, you have vascular phenomena, and you are going to be having the manifestations in each one of them. Now, when the question specifically talks about the vascular phenomena, and therefore the answer for the given question happens to be something like the Janeway lesions. Talking about the ocular nodes, the presence of Roth spots and the presence of glomerulonephritis, they are not examples of vascular phenomena for the simple fact that they are going to be examples of immunological manifestations in case of infective endocarditis. In fact, if you just look at the modified Dukes criteria, this is a minor criteria where the patients are going to be having a predisposition for development of this condition. That can be because of some of the pre-existing conditions or because of intravenous drug abuse. Presence of fever can be a minor criteria. Vascular phenomena in the form of development of arterial thrombi, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhages, conjunctival hemorrhage, and Janeway lesions. And when we talk about immunological phenomena, glomerulonephritis, ocular nodes, Roth spots, and rheumatoid factor. Microbiologically, there can be an evidence of a positive blood culture but not meeting the major criteria. So what's exactly meeting the major criteria means? That's going to be an example of a typical microorganism for infective endocarditis from two separate blood cultures, and the organisms can be something like Viridum streptococcus or Streptococcus galolyticus or Hayes group of organisms or Staph aureus or community acquired enterococci in the absence of primary focus or persistently positive blood culture, which is going to be having its own definition. Of course, there can be a criteria something like the echocardiographic evidence as well. So the point is, the other options which were given in the exam were not examples of vascular phenomena. As I discussed, they were examples of immunological phenomena, and therefore the answer of choice for the given question happens to be something like the Janeway lesions over here. Next question, which Helicobacter pylori infection is associated with development of which one of the following lymphoid malignancies? We had a discussion that when we are talking about Burkitt's lymphoma associated with Epstein-Barr virus, Hodgkin's again is caused because of Epstein-Barr virus, adult T-cell leukemia is caused because of human T-cell leukemia virus, and as and when we are making a mention of something like the mucosa associated lymphoid tissue malignancy, that's having a definitive association with H. pylori infection. Talking about the next question, which one of the following are risk factors for acquisition of hepatitis C infection? Hepatitis C is going to be an important cause of development of acute as well as chronic hepatitis. This is an example of a condition or a virus which is going to be transmitted through the parental route of transmission as well as through a blood transfusion as well as through vertical transmission. So therefore, fecal transmission has not been reported. Intravenous drug abuse can be a cause, vertical transmission can be a cause, and sharing of toothbrush and razors, which can be possibly responsible for causing a development of minor cuts. Therefore, contamination of the razor by the virus and then subsequent transmission, if there is going to be a common usage, can be true. So options 2, 3 and 4, which means that in the given options we need to be familiar with option D over here. These are the modes by which hepatitis C transmission can take place. The serological marker detected during the window period of hepatitis B infection. Now, when we talk about window period, what exactly is the meaning of the term window period? When there is going to be a decrease in the titer of the surface antigen and the protective antibody, that is the anti-HBs antibody, has not appeared. So if you just go by the appearance of the different types of antigens and antibody which are given beautifully in our books, this is the window period. As you can understand, the hepatitis B surface antigen is going to be reduced, undetectable, Anti-HBs has not appeared, and this period is given the name of window period. Now, this is the time in the window period when you're going to be having the presence of an antibody, and that is an antibody produced against a core antigen. During the window period, what type of antibody would you be having? You would be having the presence of a primary immune response antibody, and therefore the answer for the question becomes absolutely easy for you to understand. It's an anti-HBC antibody, and it's an example of a primary immune response antibody. Therefore, the answer happens to be anti-HBC IgM in the given options. Therefore, the answer happens to be absolutely straight one. So far as such a topic is concerned, we need to definitely have an idea regarding the table pertaining to the different findings in association with different phases of hepatitis infections. At the time of acute infection, patients are having surface antigen positivity as well as positive for IgM anti-HBC, and during the high infectivity stage, even the HBe antigen. Whenever we are talking about the window period, which was a given question in the UPSC exam this year, we are having the presence of undetectable levels of surface antigen, but IgM antibody against the core antigen is going to be present, which can be seen. Of course, this can or may at times be associated with the presence of anti-HBe as well, which is going to be denotive of low infectivity. So, presence of HBe means high infectivity, anti-HBe presence means low infectivity. As and when we are making a mention of something like chronic infection would be associated with surface antigen being present for a long duration of time, and the patients are going to be having the presence of HBe antigen. That's what I was making a mention of. Chronic infection would also be suggestive of the fact that the nature of the anti-HBC over here happens to be IgG. When we are talking about chronic infection with low infectivity, surface antigen is going to be present. That's understandable. We are going to be having IgG, suggestive of chronic infection, and instead of HBe antigen, you are going to be having anti-HBe antibody. So this one is going to be present. So that's a small but important differentiation that you need to remember between chronic infection of high infectivity vis-a-vis chronic infection of low infectivity from the perspective of exam. Any individual who has taken a vaccine, including you as a healthcare worker or you as a medical student who is watching this video, you people have been immunized, and the vaccine is going to be based upon the presence of the surface antigen. So immunized people are going to be having protective antibody against surface antigen. That means they are having the presence of anti-HBs. This is what we need to remember from the perspective of additional information from this question. Talking about the next one, in serological investigation of hepatitis B infection, presence of hepatitis B E antigen is an indicator of, as I just now explained you, E means infectivity, and therefore that is something which is going to be associated with active replication of the virus in the liver, very much suggestive of a patient being highly infectious, and therefore as a healthcare professional, be very cautious when you take care of such individuals in your wards or in your hospitals. Simultaneous infection with hepatitis B and hepatitis D virus is followed by full recovery and associated with the appearance of. When you have a simultaneous infection of hepatitis B as well as hepatitis D, this is what is going to be given the other important name of a co-infection. Now the question says the patient is going to be having the presence of a full recovery. So as and when the patient is going to be have a full recovery, he is obviously going to be having the presence of protective antibody, and that protective antibody is going to be anti-HDV antibody. When there is a recovery, we expect to find the presence of what type of a antibody over here? This is going to be IgM antibody, and because there is a recovery, so high titer of the protective antibody is to be expected. Now look at the options one by one from all these statements. Anti-HDV antibody agreed, IgM agreed, but is it going to be having low titers? Incorrect. Anti-HDV true, IgA antibody no. Anti-HDV antibody agreed, IgM antibody agreed, high titers. This in fact is going to be the answer of choice. Anti-HDV antibody IgG type no, because you are going to be having a patient who is going to be having a full recovery just now from a recent infection, and therefore the answer of choice happens to be option C over here for the given question. Looking at the next question, consider the following pairs: urinary segments that are going to be seen in a patient who is going to be having acute kidney injury, and the diagnosis which is likely to be seen with them. If you look at the RBC cast, are they going to be seen in a patient having malignant hypertension? That is absolutely true. If you are talking about something like WBC cast, can they be seen in a patient having pyelonephritis? This is again going to be absolutely true. When we are talking about pigmented casts are going to be seen in a patient who is going to be having acute tubular necrosis, and that can also be seen in a patient who is going to be having myoglobinuria or a patient having hemoglobinuria. So that is not going to be associated with vasculitis. That is what we need to keep in mind. Granular cast, is it going to be seen in a patient having myoglobinuria? Not correct. In fact, I just want you to have a look at this kind of a table from the perspective of what they ask you in the exam. RBC cast, is it going to be seen in a patient having glomerulonephritis, which is known to you? It can also be seen in a patient having vasculitis, can also be seen in case of patients who are going to be having thrombotic microangiopathy affecting vessels, and can be seen in a patient having malignant hypertension, which was given as option in the exam question. If you are talking about something like WBC cast definitely can be seen in a patient having pyelonephritis, which is known to you. From the perspective of a subsequent INI CET or a higher up question, remember, can also be seen in a patient who is going to be having allograft rejection, and can be seen in a patient who is going to be having a development of interstitial nephritis. If I am making a mention of a patient who is going to be having the presence of a pigmented cast, pigmented cast simply means presence of renal tubular epithelial cell cast, that can be seen in a patient who is going to be having acute tubular necrosis, might as well be associated with tubulointerstitial nephritis, can be seen in a patient who is going to be having the presence of certain substances in the urine like myoglobin and hemoglobin, so myoglobinuria and hemoglobinuria, and can be seen as a component of acute cellular allograft rejection. When we make a mention of granular cast, can be seen in a patient having acute tubular necrosis, vasculitis, glomerulonephritis and tubulointerstitial nephritis. That is what we need to have an idea over here. So please remember the fact that out of the given options, yes, the option pertaining to RBC cast was true, the option pertaining to the WBC cast was true, but in the exam they just did a crisscross in the sense that in pigmented cast it should have been present in a patient who is going to be having myoglobinuria or hemoglobinuria, whereas they gave you as vasculitis, and vasculitis would be having the presence of a granular cast, or vasculitis could be having the presence of the RB cast. So out of the 4 options given, only 2 pairs were matched correctly. That is what we need to have an idea. Please be familiar with the fact for a subsequent question in the exam, you also need to have an idea about eosinophiluria. Eosinophiluria can be seen in a patient having interstitial nephritis, can also be seen in a patient having atheroembolic disease, can be seen in a patient who is going to be having inflammation of the bladder or the kidney pelvis per se, so cystitis as well as pyelonephritis, and can be seen in a patient who can be having glomerulonephritis as well. Crystalluria can be seen in case of patients who are going to be having presence of too much of presence of crystals, and that can also be precipitating the development of something like nephrolithiasis. So the crystals can be something like either uric acid or calcium oxalate or certain types of drugs or toxins like acyclovir or indinavir and stuff. That is what you need to have an idea so far as the different types of urinary sediments are concerned which are going to be considered as abnormal. So in the given question, the answer happens to be only and only 2 pairs, which are the first 2 pairs which have been given over here. Which of the following is the primary underlying mechanism for hemolysis in patient having paroxysmal nocturnal hemoglobinuria? So surprisingly, a lot of hematology, and in fact 2 questions from PNH itself. What we are having in PNH is the patients are going to be having a PIGA gene defect, and therefore GPI linked proteins like C8 binding protein, CD55 and CD59 are not expressed properly, and therefore such cells, RBCs, WBCs and platelets are going to become highly susceptible to damage caused by complement. So option C, complement mediated destruction of CD5, 59 negative RBCs is what we need to remember over here. Talking about the next one, which of the following is a clonal hematopoietic stem cell disorder in which phenotypically normal red cells, granulocytes and platelets accumulate in the absence of a recognizable physiological stimulus. When we are talking about the presence of a proliferation of a hematopoietic stem cell, that means we are making a mention of something like a myeloproliferative disorder. And whenever we are making a mention of the myeloproliferative disorder, which is going to be causing a proliferation of all the 3 cell lines in the given option, it cannot be mastocytosis, it cannot be essential thrombocytosis, it cannot be primary myelofibrosis. The answer of choice happens to be polycythemia vera. In fact, a lot of you would be able to recall a question that when we are talking about polycythemia vera, 1, the patients are going to be having by the feedback inhibition the low levels of serum erythropoietin. Fact number 2, these patients are going to be having the presence of JAK mutations as a characteristic finding. Fact number 3, these patients are going to be having an association, which means the patients are going to be having complaint of development of aquagenic proctitis. Remember, taking a hot shower bath and the patient is going to be having complaint of itching on the body. That is what you need to remember so far as polycythemia vera is concerned. Talking about the next question, ischemia reperfusion injury is characterized by, when you are talking about this kind of a condition, the patients are going to be having the presence of ischemia induced hypoxia, and subsequently when there is going to be a reperfusion, that is going to be bringing in lot of blood along with the white blood cells and the free radicals. That is what is going to be responsible for causing a local inflammation, and therefore the answer of choice over here happens to be option A, that is hypoxia and activation of inflammation. Just winding up the discussion by talking about the question which was asked in the exam, the most common benign tumor of the liver. So we understand the fact that the commonest benign tumor of the liver happens to be something like a hemangioma, and when we are talking about this hemangioma, this is nothing but a cavernous hemangioma. Remember the importance, biopsy is going to be contraindicated or to be avoided in such patients because of high risk of development of hemorrhage. We also need to be familiar with the other important options when you are talking about something like a hepatic adenoma. This is something that you see in case of young patients, especially young females who are going to be having either history of OCP intake or young boys who are going to be having an intake of anabolic steroids. When you're talking about focal nodular hyperplasia, an example of a condition that is going to be the second most common benign lesion tumor that we are having in the liver. Also an example of a condition which is characterized by the presence of, yes, central stellate scar. The moment we are thinking in terms of angiomyolipoma is something that is typically an example of a tumor which is going to be seen in the kidneys usually, and that is going to be having three components: angio, that is blood vessels; myo, that is muscles; and lipo, that is a lipid component. So not a difficult question, the easy question, but as we have understood in our discussion that out of the majority of the questions you are asked in the exam, a sizable chunk could have been cracked provided you are very well versed with the concepts of the topic of pathology. I hope you are going to be having a good time in remembering the concepts that we have shared in the videos, and I would be more than happy to see smiling faces once the results are declared. As always, do take good care of health. Best wishes.
Hello everyone. In this session, I'm going to discuss the microbiology MCQs discussion of UPSC CMS 2023 exam. So we will quickly see the question from the microbiology as well as their solution. So let's see, the first question is in front of you. Let me read the question and discuss the solution. So which of the following statement regarding gas gangrene is correct? So the question is regarding gas gangrene. Which of the following statement regarding gas gangrene is correct? So the four options are: it is caused by Clostridium perfringens in the two option, and it is caused by Clostridium tetani in the remaining two option. So one thing is sure, that gas gangrene is caused by a bacteria that is one of the Clostridium perfringens. It is also known as Clostridium welchi, Clostridium perfringens and welchi. So of course we have to rule out these two options. The answer will be from first and second, not from third and fourth. Now we have to decide this Clostridium perfringens, is it a gram negative anaerobic non-spore forming bacteria, or is it a gram positive anaerobic spore forming bacteria? So you know everything is opposite. Here gram negative, here gram positive, here aerobic, here anaerobic, here non-spore forming, here spore forming. So of course the correct answer is 2, because of the three reasons. Because we know that this Clostridium perfringens is gram positive bacilli. It's strict anaerobe. It cannot survive in presence of oxygen. If you give oxygen, it will die. And it's a spore forming bacilli. So correct answer is definitely B. Right? This is the way you have to approach. First rule out the two options. Now from the two options you have to see and you have to correlate. So correct answer is 2. You can see here the correct answer is 2. So let me give you a little bit detail regarding the Clostridium perfringens, which is causing the gas gangrene. So here you can see there is a patient. Imagine this patient was driving and he got a road traffic accident. In the road traffic accident, he fell down over the soil and he got injuries over the thigh, you can see. Now this area, the injured area, is contaminated with the soil. So the spores of the Clostridium perfringens, which are present in the soil, they enter inside the wound and contaminate the wound. Now after entering inside the wound, they got the favorable environment. So the spores will germinate. So the bacteria will come out. Now bacteria will ferment the sugar. Which sugar? Glucose. Glucose is present in all human beings now. So the bacteria Clostridium perfringens will ferment the glucose. It will ferment the glucose and convert the glucose into two things: acid and gas. Because Clostridium perfringens is a gas forming bacteria, so it will ferment the glucose into acid and gas inside this tissue. Now this acid will cause the necrosis. You can see the black colored necrosis, and the gas will collect in the form of the crepitus. Crepitus is small bubbles. So this is known as gas because the gas forming crepitus bubbles are there. Gas gangrene. Gangrene is the necrosis. So gangrene is caused by acid and gas is filled by the gas. So it is due to the fermentation of the sugar, that is glucose. So this is the pathogenesis. How does Clostridium perfringens causes the gas gangrene? Now this is a classification of bacteria in front of you, the basic classification. Based on gram staining and the shape of the bacteria, we divide the bacteria in 4 categories. Gram positive cocci, gram negative cocci, gram positive bacilli, gram negative bacilli. Now I am interested in this category, gram positive bacilli. Okay, there are 6 bacteria in this category. The mnemonic is A, B, C, D, L, M. A stands for actinomycetes, B for bacillus, C for clostridium, D for diphtheria, L for listeria, M for mycobacteria. So C for clostridium. So I mean to say it's a gram positive bacilli. One of the option was gram negative, na? No, it's not gram negative. It's gram positive bacilli. Now only 4 bacteria in this world produce spores. None other of them. So which bacteria produce spores? We have a mnemonic for that. The mnemonic is BSc chemistry. B stands for Bacillus anthrax. S stands for Sporosarcina. C for Clostridia, and one more C is Coxiella. Okay, so Clostridia is a spore forming bacteria that I want to prove. Okay, and how many bacteria are obligate anaerobes? Obligate matlab strict anaerobes. If you give them oxygen, they will die. because they're very peculiar. They do not require, they grow only in absence of oxygen. So there are 3 bacteria which are obligate anaerobic. The mnemonic is can't breathe air, CBA. C stands for Clostridia, B for bacteroids, A for actinomycetes. So I mean to say, you please notice that Clostridia is an aerobic, obligate anaerobic bacteria. It's a spore-forming bacteria, and its Clostridia is a gram-positive bacteria. So you can see all the 3 things are fitting. Now have a look on your question. You can easily get it. It's the Clostridium perfringens, which is a gram-positive bacteria, and it is coming in A, B, C, D, L, M. It is anaerobic because it is coming in can't breathe air, and it is spore-forming because it is coming in BSc chemistry. You can correlate now. The correct answer is 2. So coming on the next question, gas gangrene resulting in crepitus in the tissue and a sweet smelling brown exudate or edema. It is caused by which infection? So the same question is repeated in a different language, right? Again, the question is on gas gangrene only. So they are asking which bacteria causes gas gangrene? Is it anaerobic bacterioid species? Is it Clostridium perfringens? Is it gas-forming Klebsiella species? Or is it synergistic bacteria? So of course, we have just now seen that gas gangrene is caused by Clostridium perfringens. So the correct answer here is Clostridium perfringens. Got it? Clostridium perfringens is the correct answer here. Coming on the next question, which of the following statement is correct regarding UTI, urinary tract infection? So there are four statements. We have to say which is right, which is wrong. Let me read them one by one. Urine is an excellent culture media for the bacteria. Yes, this statement is correct, that urine is an excellent culture media for the bacteria. Atrophic urethritis in postmenopausal women is a risk factor. This statement is also correct. Yes, atrophic urethritis is a risk factor in postmenopausal women. And antibiotics are recommended in all cases of asymptomatic bacteriuria. No. In case of asymptomatic bacteriuria, we don't give any treatment unless until there are some specific conditions. Certain strains of the E. coli have propensity to invade the UTI. Yes, there are certain strains which have the P fimbriae on them. They can invade the UTI tract, right? So the statement is also correct. So according to me, 1, 2 and 4. 1, 2 and 4 are correct, but the 3 is wrong. This statement is wrong, that antibiotic is required in all asymptomatic cases of the bacteriuria. So let's have an overview of the UTI, right? The correct answer here is 1, 2, 4. These statements are correct. 3 is wrong. So all the options having 3, just rule it out. Okay, so you know what is urinary tract infection. Urinary tract infection is the infection which starts from the renal cortex till urethra. So any infection starting from the renal cortex till the urethra, it is known as urinary tract infection. It is divided into 2 portions, upper urinary tract infection and lower urinary tract infection. In the upper, the kidneys and ureters are involved. In the lower, the urinary bladder and urethra is involved. So you can see the classification of upper and lower. Now, UTI is more common in females as compared to male. There are 4 reasons for that. What are the 4 reasons? You can see the urinary tract of the male and the female in front of you. Now compare the urethra. See the urethra in the male and see the urethra in the female. So in the female, urethra is very short. That's why bacteria can easily enter via ascending route. This is the first reason why females may UTI is more common as compared to male. The first reason. Second, this urethral opening is in close propensity of the anal opening in females as compared to it is far away in males. So anal opening and the urethral opening, the distance between them, it's less in female, so that, you know, in anal opening in the colon, the E. coli is a commensal. So here, there are high chance it can contaminate the urethral opening, right? It can contaminate the urethral opening. So short urethra, close proximity of the urethral opening, urethral meatus to the anal opening, so that there are chances that endogenous E. coli bacteria can contaminate the urinary tract. In males, prostate is present. In males, here a prostate gland is present. Prostatic secretion inhibit the bacterial growth. In females, prostate is not there. So absence of prostatic secretion is again a risk factor. And the 4th risk factor is atrophic urethritis. In old females, there is menopause. After 45 to 50 years, there is menopause. There is deficiency of estrogen. Deficiency of estrogen leads to atrophic urethritis that increases the chances of UTI. Got it? Most common organism which causes UTI is E. coli only, 70% of the cases. Whether it is nosocomial, it is community acquired, it is upper UTI, lower UTI, neonate UTI, adult UTI. In all UTI, the most common cause is E. coli, right? Now, according to the cause, we divide the UTI. Like we see the colony forming unit in the urine and decide the type of the UTI. So if the colony forming unit are more than 10 to the power 5, it straightforward indicates infection and it requires treatment. If it is between 10 to the power 4 to 10 to the power 5 colony forming units, it is plus or minus both. I mean, it is dicey. It should be correlated clinically. It's doubtful significance. And if it is less than 10 to the power 4, now we will consider it's a common cell bacteria only which is causing contamination of the urine while voiding. Got my point? So it is of no significance and it is known as asymptomatic bacteriuria. This one, and here no treatment is required. That's all about it. Coming on the next question. The next question is in front of you. Which of the following statement is correct regarding brucellosis? So the next question is based on the brucellosis. Read the three statement. The fever may develop in an undulating pattern that persists for a week. Yes, this statement is correct. Undulating fever comes, that is known as Malta or Mediterranean fever. Associated with musculoskeletal symptoms. Yes. The patient have joint pain, arthralgia, the symptoms are common. And brucella is a facultative intracellular parasite. Yes, it resists intracellular phagocytic killing. So it's the intracellular facultative parasite. So all the three statements are correct. I will go with D. Right. So correct answer here is D. Let's have a look on the brucella. So as soon as brucella is a zoonotic disease, it enters in the human from animals. So from the initial site of inoculation, this is brucella. See in the diagram, this is brucella. It is phagocyzed by the phagocytes. Phagocytes will phagocytose it. The macrophage, dendritic cell, neutrophils. So, but inside the phagocyte, it resists killing. It resists intracellular killing because it is a facultative intracellular parasite. So this option is correct. Now from here, it will come in the blood. It will come in the blood. From the blood, it will cause bacteremia and go to the reticuloendothelial system, like lymph node, liver, spleen, bone marrow, and finally it forms granulomas in all the organs, right? There is a typical triad in brucella. Never forget. The first thing, the patient have undulating fever. See, the fever is there, then a remission period is there. Then again a fever is there, then remission period is there. This is typically known as undulating fever, Mediterranean fever, Malta fever. The second is arthritis, arthralgia, the musculoskeletal symptoms, one of our option. And the third is hepatosplenomegaly. So these are the triad of brucella. Coming on the next question, the Duffy antigen system serves as a receptor for which of the following protozoal parasite? Is it Giardia lamblia, Plasmodium vivax, Entamoeba histolytica, or Balantidium coli? So of course the Duffy antigen acts as a receptor for Plasmodium vivax. It's a protozoa, the malarial parasites, the Plasmodium vivax. So what is Duffy? What is Duffy glycoprotein? It's a receptor for the chemicals that are secreted during inflammation. During inflammation, certain cytokines are secreted, and for those cytokines, the receptor is the Duffy antigen. But it also a receptor of the Plasmodium vivax that enters inside the RBC. You can see this is the RBC. On the surface of the RBC, this is Duffy antigen. This is Duffy antigen. So here you can see this is Plasmodium vivax. Plasmodium vivax, it is entering inside the RBC using this antigen. So for Plasmodium vivax, it is also an antigen. So can I say in the humans, in the RBCs of those humans in which Duffy antigen is absent, Plasmodium vivax cannot enter inside their RBC, and they are resistant for Plasmodium vivax? Yes. So the persons who lack Duffy antigen on their RBC, they are resistant to Plasmodium vivax. They will not have malaria due to Plasmodium vivax any time in their life. So such humans which are negative for Duffy antigen, they are resistant to Plasmodium vivax infection due to this reason, because Plasmodium vivax enter in RBC and causes malaria because of the receptor that is Duffy antigen. So if Duffy antigen is absent, they cannot enter. So coming on the next question is in front of you. Which of the following viruses can be transmitted via transfusion of the infected blood? The options are hepatitis B, hepatitis C, HIV, human immunodeficiency virus, and parvovirus B19. So all these four viruses can be transmitted via blood transfusion. So via blood transfusion, name the viruses. You should know the name of all viruses. So before transmitting the blood from the donor to the recipient, we check all these viruses, because these are the viruses which can be transmitted via blood. It is HIV, all the hepatitis viruses, all the hepatitis, I mean B, C, D, B and C. Okay, West Nile virus, cytomegalovirus, HTLV, human T cell lymphotrophic virus, HTLV, and parvovirus B19. So in our option, all the four options are from this only. Coming on the next question, the most common causative agent of spontaneous bacterial peritonitis. Is it E. coli? Is it Enterococcus? Is it Staphylococcus staph aureus or Streptococcus viridans? So what is spontaneous bacterial peritonitis and what is the most common organism causing it? The correct answer is E. coli. Spontaneous bacterial peritonitis is the infection. It's the abnormal accumulation of fluid in the abdomen. Abnormal accumulation of the fluid in the abdomen like a ascites, but there is no reason for that. We can't identify what is the reason. What is the reason? In majority of the case, 90% of the cases, the organism which is causing spontaneous bacterial peritonitis is E. coli. right? So we have a clue that the source of infection may be GIT because E. coli is present as a commensal in GIT. So it can contaminate and come and it can cause the ascites, and the cause is exactly not known. It is known as spontaneous bacterial peritonitis. Coming on the next question in front of you, consider the following statement with regard to strongyloides. We will read the fourth statement. It parasitizes the mucosa of upper part of the small intestine. Yes. It involves duodenum and jejunum. Larva currens is a fast transient rash across the abdomen and the buttocks. Yes, it causes larva currens. That is a rash along the abdomen and the buttocks. Ivermectin is not effective treatment. This statement is wrong because ivermectin is the drug of choice in strongyloids. Ivermectin and albendazole are the drug of choice. So this statement is wrong because they are saying it's not a treatment. And systemic strongyloides occurs in immunocompetent state. No, this statement is also wrong because systemic strongyloides occurs in immunocompromised state like HIV. More common in HIV, not in healthy persons. So third and fourth statement are wrong. Only first and second are correct. Only first is. So I will go with this option. Only first and second. Have a look on strongyloids. Everything about strongyloids. In strongyloids, we find only female worms in the intestine of the human. Males are absent, right? It's a mystery how the female get pregnant, gravid without the male partner. So such a female which can lay fertile eggs without male partner is known as parthenogenic worm. So such females is known as parthenogenic worm. That is, female is able to produce the fertile eggs without meeting the males, without doing sexual intercourse with the males. It's a mystery how does it occurs. Mode of transmission is penetration through the skin. Actually, the L3 larva is present in the soil. So if someone is walking with barefoot, without slipper, without shoes on the dampened soil, the L3 larva may enter inside, penetrating the skin, the L3 larva, and goes inside. So the infective form is L3 larva, that is filariform larva. It is present in the dampened soil and man is the only host. There is no secondary host, right? You can imagine this diagram. This is the dampened soil. This is the L3 larva present. It will penetrate. Someone is walking barefoot. It will penetrate inside. It will go in the subcutaneous tissue and go in the veins. From the veins, all veins drain in the right side of the heart. So this L3 larva go in the right side of the heart, right auricle, right ventricle, pulmonary vein, and from there it will go to the lung. L3 larva convert into L4 larva in the lung. From the lung it start crawling. It start crawling to the bronchi, trachea, larynx, pharynx. From the pharynx it will take a U-turn. It will take a U-turn and go to the GIT. It will go to the esophagus, stomach, and upper intestine. In the upper intestine, it converts into adult form. Finally, it forms the adult form. So in the intestine, so basically it is causing two diseases. The disease in the lung is caused by larva and the disease in the intestine is caused by the adult form. So that is the complete life cycle. And adult means there is male, there is female. There is no male, I mean. The female get gravid without male and the eggs are laid in the feces. This is the complete life cycle you can see, right? So what are the disease due to the larva? What are the disease due to the adult form? Larva will cause rash. Larva will cause cutaneous larva migricans. That is a rash, especially on the thigh, on the abdomen, right? And pulmonary symptoms are there. So in the lung symptoms are there. Larva is causing symptoms in the lung. It is causing a rash throughout. And the adult form is causing the infection in the intestine. Like epigastric pain is there. Epigastric pain, diarrhea is there, vomiting is there. Sometimes when the heavy larva load is there, it will enter in the blood in immunocompromised people like HIV, like the patient on steroid, not in healthy people, and it will cause the hyperinfection syndrome. So that's all about it. The drug of choice is ivermectin and albendazole. Now have a look on your 4 option. You can easily make it out. Coming on the next question, consider the following statements with regard to cutaneous larva migrans. Cutaneous larva migrans. It is one of the commonest linear lesions seen in travelers. Yes, it's common. It is associated with visit on a beach. Yes, because in the beach, in the soil of the beach, the feces of the cat and dogs are common. And here, the larva is present in the feces of the dogs and the cat. Okay, it is non-pruritic. It is wrong. It is severely itching. There is severe itching is there. Pruritus is there. Tract moves across the skin at a rate of 2 to 3 centimeters per day. So this statement is also correct. 3 is wrong. So correct is 1, 2, 4, but not 3. So have a look on all the things that is cutaneous larva migrans. Okay, so it is known as creeping eruption or cutaneous larva migrans. So actually the dog or animal parasite larva, animal parasite, it is dog or cat, not human. Animal parasite, for example, dog parasite, cat parasite, their larva present here in the soil, L3 larva, that enters like strongyloids only, it is entering inside. So it will go in the veins, L3 larva. From the veins, it will go to the heart. From heart, it will go to the lungs. From lungs, it will go to the GIT. From the GIT, it will again absorb and come in the veins. So it will keep on rotating in the body like this. It is cutaneous larva migrants. Okay, no, this is not cutaneous. This is visceral larva migrants. It is moving from viscera to viscera. But in cutaneous larva migrants, we start from the animal parasite only. There is an animal parasite. The larva of that, it cannot penetrate the subcutaneous tissue. See here, I have drawn the subcutaneous tissue, not this one. So this parasite, since it is an animal parasite, not human parasite, so it cannot penetrate the subcutaneous tissue. It will remain in the skin only. In the skin only, it will form a tunnel, a tortuous tunnel, and enter throughout the body, causing a disease known as cutaneous larva migrans. And if it is moving from viscera to viscera without maturing, it is visceral larva migrans. Both of them occurs in animal parasites. Like these all are animal parasites. These are the parasites in the dog and the cattle and the cats, not humans. So this is visceral larva, cutaneous larva migrans. Coming on the next question, consider the following statement with regard to giardiasis. So let's start giardiasis. Stool examination for the cyst in 2 to 3 days interval for the diagnosis? Yes. Every 2 to 3 day interval, we should examine the stools, because it is not necessary on the first examination only you will get the cyst and the trophozoite. Colonoscopy aspirate gives the highest diagnostic yield? No. Giardia resides in duodenum, the upper small tract, upper small intestine, not in colon. So this statement is absolutely wrong. Infection occurs by ingestion of contaminated water? Yes. It occurs by oral route, ingestion of contaminated water and food. Giardia is a flagellated trophozoite form? Yes. So 2 is not correct, but 1, 3, 4 are correct. So we will go with this. We will see everything regarding the giardia. Giardia have 2 forms, the trophozoite, the cyst. Okay, the trophozoite form, you can see the trophozoite form, the typical shape of the trophozoite, you can see it here. It's badminton racket or tennis racket shape or teardrop shape. It is having four pairs of the flagella. Please count it. Pair number 1, pair number 2, pair number 3, pair number 4. 4 pairs of flagella are there, and it is bilaterally symmetrical. 2 nucleus are there, 2 parabasal discs are there. Okay. So this is complete trophozoite. The trophozoite is a flagellated form. 4 pairs of flagella is there. This statement is correct. Now regarding the life cycle, let me draw the life cycle for you. Imagine this is a child. It especially occurs in the children. It enters the human body. Via contaminated food and water. So contaminated food and water, the cyst is the infective form, not trophozoite. So cyst will go inside. The cyst accestation occurs in the duodenum. The accestation of the cyst occurs in the duodenum. From one cyst, 4 trophozoite will be formed. So from one cyst, the trophozoites are formed. These trophozoites are non-invasive. Mind my words, they are non-invasive. So what did they do? They just destroy the villi. Can you see? This is a villi. So they simply destroy the villi in the intestine. What is the function of villi? The absorption. Now since the villi is destroyed, there is no absorption and the disease is known as malabsorption. That's why if you want to do the diagnosis, you have to take it out the duodenal aspirate. You have to take the duodenal aspirate via a diagnostic technique known as enterotester string test. So duodenal aspirate is diagnostic. You can see, not colonoscopy aspirate, duodenal aspirate, right? And infection occurs by contaminated food and water, and stool examination is required every 2 to 3 days. So that is all about giardia. Coming on the next question, type 2 necrotizing fasciitis is caused by Group A Streptococcus, Vibrio vulnificus, Clostridium septicum, or Staph aureus. So correct answer is Group A Streptococcus. Let me explain you everything about the necrotizing fasciitis. Necrotizing fasciitis is a bacterial infection of fascia and the tissue. So basically bacteria multiply. The bacteria enter in the fascia and the tissue. It will multiply. It will secrete toxin. The toxin will cause thrombosis of the blood vessel. Now, since the fascia and the tissue is not getting the blood because of obstruction of the blood vessel, there is destruction or necrosis of the fascia and the tissue leading to necrotizing fasciitis. It is of 3 types, type 1, 2, 3. Currently, the question is on type 2. Type 1 is polymicrobial. Multiple bacteria causes it. Type 2 is specific due to group A Streptococcus. Beta hemolytic group A Streptococcus, that is Streptococcus pyogenes. And type 3 is gas gangrene. We have already discussed gas gangrene due to Clostridium perfringens. Got my point? So currently the question is on type 2. You can see they are asking type 2. So group A Streptococcus, that is Streptococcus perfringens is the Streptococcus pyogenes is the answer. Okay. Coming on the next question, which of the following opportunistic systemic mycosis is characterized by rapid development of severe tissue necrosis and as a complication associated with COVID-19 in India. So is it histoplasmosis, mucormycosis, coccidiomycosis, or sporotrichosis? The two clues are given to you in the question. The first clue, it's a complication occurring in COVID-19, and it causes severe tissue necrosis, and it's a systemic fungus. It's a systemic fungus. So please rule out the option. Histoplasmosis is subcutaneous one. It's systemic, you can say, okay. But which of them is causing as a complication of COVID-19? So sporotrichosis is also not there. Again, it's subcutaneous. The remaining three you can say. So correct answer is mucormycosis. Mucormycosis is a broad aseptate hyaline hyphae branching. You can see here the hyphae. The hyphae is broad, you can see, and the angle at which it is dividing is very wide. It's 90. It's 90, more than wide, है ना? And it's broad aseptate. You can see there is no septa. There is no septa in contrast to aspergillus, which are septate, which are narrow angle branching. This is wide angle. This is mucormycosis. In mucormycosis, we have rhizopus and we have mucor. Okay, in zygomycosis. So mucor will cause orbital cellulitis that appears as a complication of COVID-19 patients in India because it occurs in immunocompromised patient. Now in COVID, what happens? In most of the patient in COVID, the treatment was steroid. On steroid, the patient become immunocompromised, and in immunocompromised condition, this fungus is very common, and it causes orbital cellulitis involving brain sometimes also, right? So coming on the last question, the question is in front of you. Which of the following fungal infection is caused by dermal inoculation of the fungal agent, usually after a thorn? What is the biggest clue given to you? The biggest clue given is a thorn prick. After the thorn prick, which fungal infection enters in human body? Is it mycetoma, aspergillus, mucormycosis, or sporotrichosis? The correct answer is sporotrichosis, which peculiarly enter human body after thorn prick, especially rose thorn. You know, rose plant have many thorns in that. So especially it occurs in rose gardeners. The name of the fungus is Sporothrix shanchi, and the disease is sporotrichosis, in which the fungus enters in the lymphatics and causes a linear lesion, multiple series of a linear lesion. You can see this is the typical presentation because it enters inside the lymphatics, right? Histopathologically, a star-shaped body is seen. The star-shaped body, appreciate the star-shaped body. This star-shaped body, it is known as asteroid body, also known as cigar body, right? So that's all about it. Thank you.
Hello friends, myself Dr. Atul Gupta. I will be discussing forensic medicine and toxicology MCQs with you. The key feature of this exam has been that almost all the questions from forensic has been from toxicology, and this is the consistent pattern we have seen that toxicology questions are very commonly asked almost in all the exams, whether it is NEET PG, INI CT, or your FMG exams, and we anticipate the same in upcoming next also. So let us start with the first question. The first question is that exposure to gases is a common hazard in industries. The gases can be classified as simple asphyxiants and anesthetic gases. Which of the following are asphyxiating gases? So here I think it's an easy question. We know that carbon monoxide is an asphyxiant gas, cyanide gas is an asphyxiant gas. So the answers become A. Answer is A. Okay. So here the asphyxiant gases we should be knowing can be divided into two categories. One is the simple asphyxiants, which are the inert gases which simply replace the oxygen. And second is the chemical asphyxiants, which are further subdivided into irritant gases and systemic asphyxiants. Irritant gases inflame the respiratory tract mucosa. Systemic asphyxiants have some systemic action like replacing the hemoglobin from oxygen, acting as the cellular respiratory enzyme levels. So both carbon monoxide and cyanide are actually the systemic asphyxiants. Now coming to the second question, which regard to the lead poisoning, consider the following statements. Number one, copropporphyrin in urine is a useful screening test. Yes, because we know that lead inhibits heme production. So various metabolites get formed, of which copropporphyrin is one of them. It gets accumulated. So copropporphyrin increased levels is definitely an indicator to lead poisoning. Second point, hand washing before eating is an important measure of personal hygiene. Yes, because lead is an environmental toxin. Chronic toxicity is much more important, and the reason of chronic toxicity is because of the lead paints and all the lead batteries. So hand washing can certainly be helpful. Use of D-penicillamine has been reported to be effective in management. D-penicillamine is actually not the first line of treatment, it is the second line of treatment. D-penicillamine is more commonly used for copper poisoning, but yes, D-penicillamine can also be used for lead poisoning. Basically, for lead poisoning, what we use is we use one of the either BAL, DMSA or DMPS, and then we use calcium EDTA. Calcium EDTA is not used alone because it does not crosses the blood-brain barrier, which can increase the effect of lead encephalopathy. So the nutshell is D-penicillamine is mainly used for copper, but it can be used for lead poisoning also. So here the best answer becomes all three. Which of the following statement is correct regarding scorpion stings? Scorpion injects venom from a stinger on their tail. Yes, and on the tail there is a stinger from which the poison is injected. Most stings are painful but relatively harmless. That this point is also true because actually the scorpion venom is more toxic, but very small amount get injected. That is the reason most of the scorpion bites, though very painful, are relatively harmless. Anticholinergics can be used if antivenom is available. See, the main treatment of scorpion skin is one is the scorpion venom. Actually, the main treatment for scorpion bite is the anti-scorpion venom, which is available in India against the red scorpion, and the prazosin. Prazosin acts as a vasodilator, but anticholinergics can also be used to reverse, especially the bradycardia. There are many cholinergic effects seen in the scorpion stings, of which bradycardia is one of the important effects, and to reverse the cholinergic effects, anticholinergics are used. So here also the answer will be 1, 2, and 3. Exchange transfusion as a method of to enhance excretion of poison is indicated in. Now, exchange transfusion can be done in few poisons, of which the most important indication remains methemoglobinemia. For methemoglobinemia, also the first choice is methylene blue. Methylene blue. But in case the patient is unresponsive to methylene blue, then in that case exchange transfusion can be done, and it is commonly used when there is G6PD deficiency. It can help to replace the abnormal hemoglobin from the normal hemoglobin. In case of child with acute poisoning by ingestion, activated charcoal may be used. See, activated charcoal can be used for most of the poisons. Where it cannot be used, we should be knowing this. It cannot be used in any heavy metals. It cannot be used in alcohols. It cannot be used in corrosives and organophosphates. So remember this, that activated charcoal is not to be used in HACO. Heavy metals, alcohols, corrosives, and organophosphates. Now here iron and lithium are heavy metals. In corrosives it is not to be used. So the answer becomes anti-epileptic ingestion. Regarding the following statements with regard to a leopard snake bite, which is the true? Regardless of the anatomical site of the bite, walking of the victim should be discouraged. Yes, because if the victim walks, there will be increased systemic circulation. Second is pressure immobilization should be used. Yes, pressure immobilization will prevent the systemic spread. Please remember, in case the snake, instead of elapid, it was a vasculotoxic snake. In case of vasculotoxic snake, we only use immobilization. We do not use pressure immobilization. Why? Because in case of a immobilization is to be used in all the snake bites, whether it is neurotoxic like elapid or vasculotoxic. But pressure immobilization is used only in neurotoxic, not in vasculotoxic, because in vasculotoxic, if we use pressure immobilization, whole of the venom will remain in the limb, and which has very high local toxic effects, and this may lead to amputation. So here, but in neurotoxic, yes, it can be used. Ptosis, yes, because it's a neurotoxic snake, paralysis can occur, and ptosis is one of the important features. So the answer here is 1, 2, and 3. Thank you very much.
So dear students, there is only one MCQ asked from ENT side, that is regarding the functions of the larynx. See, what are the functions of the larynx? First of all, fixation of the chest, yes. Phonation, yes. Respiration. As you all know, your larynx will be forming a part of your respiratory tract, and that will be responsible for the passage of air. So obviously for respiration and voice box, both the vocal cords are located in the larynx. So that is responsible for your voice production, phonation. And what is the main structure that aids in the swallowing of food? That is your pharynx. Okay, pharynx and as well as esophagus. So those are the structures that aids in the food passage through your digestive tract, right? So instead of this function, aids in swallowing of food will be done by pharynx. Pharynx is a structure that allows the passage of both air and food. Both will get crisscrossed in this area. So what is the another function? Fixation of the chest. Fixation of the chest means whenever you are climbing, whenever you are swimming, in order to fix your chest, okay, you have to close the glottis. Both the vocal cords are to be closed and the air has to be retained inside by your chest. Okay, so you cannot leak the air so that your grip will be lost. So you try whenever you try to climb a tree, you will be fixing your chest. So that will be done by closing the glottis, both the vocal cords, approximating both the vocal cords. So that is fixation of the chest. Another function of your larynx is the protection of lower airways. Protection of lower airways means your larynx will protect, because whenever a foreign body enters into the larynx is the first part of the respiratory tract, where whenever a foreign body enters and touches the mucosa of the larynx, immediately a cough reflex will be generated. So your larynx is also called as the protector of the lower airway. Okay, it barks at the sight of the foreign intruder. So that's it. Only one question from ENT. So with this, we'll move on to the next subject. Right? Bye.
Hello dear friends, in recently conducted UPSC 2023 ophthalmology question 1 had come. I am Dr. Gaurav Nagpal, your faculty for ophthalmology at Cerebellum. The question that had come was the upper limit of age for attainment of visual fixation and following is, so it was asking for the upper limit, the limit beyond which you will start doubting. So the upper limit would be 3 months. By 3 months, the visual fixation or following is completely developed. 1 month is the time period when the fixation starts to develop. 3 months is when the fixation is completely developed and child learns to follow whatever is being shown to them. By 6 months, the depth perception is there. By 9 months, the child starts to search for objects, starts to search or look for preferential looking is there. Okay, that is there. And by the age of 6 years, the vision becomes 6 by 6. Easy to remember, this I have told in my classes also. By the age of 6 years, 6 by 6 vision is attained. Okay, that is what is given in parcel. 3 months, the child follows moving object. Okay, by 6 months, the depth perception is there. I hope you have answered the correct question and you are able to succeed in your exam. All the best, dear students. Thank you.
Hello friends, UPSC Combined Medical Services Exam 2023 PSM Community Medicine MCQs, and I am your very own Dr. Vivek Jain, educator from CerebellumAcademy. Friends, first question, which of the following vaccines can be given to a pregnant woman? Let's go choice by choice. COVID vaccines, yes, they are permitted, both Covishield as well as Covaxin. Measles, mumps, rubella, they are live vaccines, so they should not be given. Hepatitis B vaccine is a recombinant subunit vaccine. It is safe to be given in pregnancy. Only live vaccines are contraindicated. And rabies vaccine is a killed vaccine, absolutely safe to be given in pregnancy. So answer to this question is choice number C, 1, 3 and 4. Next question friends, Gompertzian curve. This is used for tumor growth. What does it tell you? As the tumor increase in size, there is a deceleration in growth of the tumor. So deceleration in growth as size of the tumor increase. So you can see this is a S-shaped curve where it is slow growth at the start and again it is a slow growth at the end. So this is used for tumor sizes. Also it can be used for disease progression. It is also useful in a few bacterial studies also. In which of the following disease source of infection and reservoir are same? Friends, what is source? Source is the immediate thing, person, animal or anything from which we get the infection. And what is the reservoir? Which maintains the organism in the environment in absence of transmission. So let us look choice by choice. Hookworm. When we look at source, it is soil. And when we look at reservoir, it is man. When we look at cholera and typhoid, here in both, source is the feces which are infected, and they may be from a case or a carrier. Reservoir is man in both. So answer to this question is choice number C, tetanus. Why I am saying so? In tetanus, it is soil which is acting as source also and reservoir also. Which of the following statement is correct regarding chikungunya fever? Friends, let's go choice by choice. Choice number A, it is usually transmitted by culex. No, it is actually transmitted by Aedes aegypti. So like dengue, yellow fever, Rift Valley fever, Zika virus, chikungunya is also transmitted through Aedes. A safe and effective vaccine is available for use. Answer is no vaccine is available currently for chikungunya. Third, incubation period is 4 to 7 days. This is correct. Most of the literature mentions 3 to 7 or 4 to 7 days. And look at fourth choice or the fourth parameter. One of the prominent symptoms is arthropathy. This is correct. Arthropathy, fever. Arthropathy is mainly in the form of joint pains. Typical doubling up appearance. There is pigmentary rash or pigmentation along with rash also present. So answer to this question is choice number D. 3 and 4 are correct as we can see. First and second are not correct, and what examiner has asked is the correct one. So this also you have to read carefully in the question. Which of the following vector-borne diseases transmission chain is man, snail and man? Friends, answer to this question is yes, schistosomiasis. What happens in schistosomiasis? Cercariae, infective stage, enters man through skin. Adult worms are formed inside the body and eggs are shed in feces. These eggs, when they hatch, they lead to formation of miracidae. And these miracidia, they reach snails who release sporocyst, who further lead to release of circarian water, and the cycle is completed. Schistosomiasis. Which of the following mosquito-borne diseases are transmitted by Aedes? Friends, which are the mosquito-borne diseases through Aedes? It mainly includes in India dengue, hemorrhagic fever, chikungunya fever, Zika virus. When we look outside India, then Rift Valley fever is transmitted also through Aedes. Also, they can transmit filariasis, but outside India. So, looking at the choices, answer to this question is choice number C, 1, 3 and 4. If you look at West Nile fever, it is actually transmitted through culex. Species pipiens, recently reported from Caroline, India. Which one of the following is best defined as interval of time between receipt of infection and maximal infectivity? Friends, if you look at incubation period, it is entry of organism till first sign or symptom. If you look at serial interval, it is a interval or gap between primary case till secondary case. Latent period, this is actually a term used for non-communicable diseases. This is from onset of disease. Onset you can say is initiation of disease till it is diagnosed first in the body. So answer to this question is choice number A, generation time. This is entry of organism till maximal infectivity of that person to other people. Consider the following. Arrange the following in the order as per their sensitivity to heat. Most heat sensitive, to least heat sensitive. Friends, if you look, most heat sensitive vaccine is not BCG but reconstituted BCG. After that comes OPV, IPV. After that comes yellow fever, then BCG, and at the bottom of the list, least heat sensitive is hepatitis B. So now you have to read the question carefully and mark the sequence in correct order. Answer to this question is choice number D, 4, then 3, then 1, and then 2. We move forward. Question 9, ESI Act 1948 provides for certain benefits. Which of the following benefits or to dependents are given under the Act? So let's look at that. Dependents benefit. Yes, it is there. It is at 90% of wages. If it is temporary disablement, it will be given till recovery. If it is partial permanent or complete permanent, then it will be decided by the medical board. Funeral expenses, currently 15,000, are given to ESI scheme under Ministry of Labour. Maternity benefit is given at 100% wages. This is currently for 26 weeks or 6 months. Travel benefit is not given under ESI scheme of India. So answer to this question is choice number C. 1, 2 and 3 are included as benefit, or the dependents can get this benefit. Beside all this, we have sickness benefit. 70% wages for 91 days. Extended sickness benefit. 80% wages for 2 years. And enhanced sickness benefit. 100% wages for 7 days after vasectomy, 14 days after tubectomy. Which of the following vaccine best represent interventions that focus on cancer prevention? Hepatitis A, no such provision exists. Hepatitis B prevents, besides hepatitis B, against hepatocellular carcinoma. Haemophilus influenza B, no association with prevention of any cancer. Human papilloma virus vaccine, Cervarix, Gardasil 9, they prevent a woman against cervical cancer. So which of the following leads to prevention of cancer also? That is choice number C, 2 and 4. Consider the following statements. Statement 1, while calculating the number of expected pregnancies per year, correction factor 10% is added to the expected number. This is a correct statement. Look at second statement. All the pregnancies in the area may not be registered by the health worker. This is also correct. But is statement 2 the correct explanation of A? No. We add 10%, not because health workers are not able to record everything. We add 10% additional pregnancies because 10% is the pregnancy wastage in Indian situations. So statement 1 is correct, statement 2 is correct, but statement 2 is not the correct explanation of statement 1. Which food protein is considered best and used as a reference protein? Friends, when we look at quality of protein, egg has got highest quality. It has no comparison. In fact, its net protein utilization value, which is a marker of quality, is highest, 96. In comparison, soya bean has highest quantity of proteins. That is around 43%. But when you look at quality, soya bean NPU is only 55 as compared to X96, and reference protein of India was decided on the basis of its quality. This is the reason, not soya bean. Egg protein has been declared the reference protein of India, and this high quality is due to best balanced proportion of all 10 essential amino acids in egg. Consider the following disorders. Which of the following are part of iodine deficiency disorders? Friends, when we look iodine deficiency disorders, delayed motor milestones are present. Extrapyramidal spasticity is characteristic. Nyctalopia, no. What is nyctalopia? Night blindness. That is generally seen in vitamin A deficiency, xerophthalmia. Look at fourth point, that is hearing defect, that is also present. Now, why hearing defect is seen in iodine deficiency disorders? This is due to involvement of thyroid. Thyroid function is affected. So 1, 2 and 4 are correct. So answer to this question is choice number D, 1, 2 and 4. Which of the following are domains type of learning? Friends, there are 3 domains of learning. These are cognitive, which are associated with knowledge. Second is affective. This is associated with attitude. And third is psychomotor, which is associated with skills. So 3 domains of learning associated with 3 sets. This we have discussed in detail in the PSM videos of social sciences and health under Cerebellum app also. So if you look at this question, not a domain of learning is physiological. So answer to this question is 1, 2 and 4 are definitely domains of learning. Which of the following are beneficiaries of ICDS? Friends, ICDS has got 4 beneficiaries. One is 0 to 6-year children. Then we have 15 to 49-year non-pregnant, non-lactating reproductive age women. Then we have pregnant females, lactating females. And the fourth group of beneficiaries, 11 to 18-year adolescent girls. So look at this question, they are asking who are beneficiaries, who is not a beneficiary. So adolescent boys are not a beneficiary. Adolescent girls, pregnant female, children less than 6 years are. So answer to this question is choice number D. 2, 3 and 4 are included in beneficiaries of ICDS. Focal point of delivery, heart of ICDS is Anganwadi system, and this scheme is under Ministry of Women and Child Development, where protein supplementation is 1/2 and calorie supplementation is 1/3 of the daily requirement. Which of the following correctly represent 3 critical determinants of health facility to be declared as first referral unit? Friends, it includes availability of emergency obstetric surgical intervention. So surgery should be aware. Availability of blood storage facility. This should be present on a 24-hour basis. And yes, there should be newborn care also available. So answer to this question is 1, 3 and 4 are included. So choice number B in first referral unit, which is mostly an upgraded community health center in the country. Which of the following denotes the correct increasing order of minimum age at which vaccines are administered to a child as per national immunization schedule? Friends, if you look at these vaccines, BCG is given at birth. Japanese encephalitis vaccine, we give 2 doses, 9 months age, then second dose is 16 to 24 months age. Rotaviral vaccine, we give 3 doses at 6, 10, 14 weeks along with pentavalent vaccine, and TD vaccine is given at 10 and 16 years of age, then it is given in pregnancy to women also. So if you arrange in correct order, then first we give BCG, then rotavirus, then Japanese encephalitis, then TD. So answer is choice number B. Under the National Leprosy Eradication Program, ASHA has been entrusted to carry out which activities? ASHA has mainly 2 activities. Number 1 is to search for suspected cases of leprosy in their village and take them to PHC for diagnosis. In fact, friends, if you remember, I have discussed in the video also, ASHA has got 4 impact indicators: reduction of IMR, TB cases detected in the village in the year, leprosy cases detected in the village in the year, and the protein energy malnutrition rate. So leprosy case detection. And second is to give a follow-up for confirmed cases till the treatment is completed. So answer is choice number C, 1 and 4 only. NACO India works towards which of the following causes? National AIDS Control Organization is related to screening of high-risk cases. Public education, IEC activities towards prevention of HIV transmission, safe sex, condom promotion. treating HIV cases free of cost. If you look at answer to this question, it is choice number 134. Facilitating adoption of orphans is not related to HIV services under National AIDS Control Program or under National AIDS Control Organization. Cost of implementation of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is borne by. Friends, if you look at this Ayushman Bharat, it is a 100% centrally sponsored scheme. So people get free secondary tertiary level hospitalization if they are below poverty line, and they get an insurance of rupees 5 lakh per family per year free from Government of India. But when you look at its cost of implementation, then definitely it is divided between center and state. Now this is 100% and 0%. If you look at Union Territories of India, if you look in other parts of the country, it is 60:40, but it is 90:10 in hilly parts, that is Northeast, Jammu Kashmir, Uttarakhand and Himachal Pradesh in our country. So answer to this question is choice number C. Dashboard indicators used for monitoring of India's newborn action plan, which of them is a impact level indicator? Friends, under India newborn action plan, what do we want? We want to reduce newborn mortality and stillbirths, both to below 10 per 1000 live births, and this has to be achieved by the year 2030. Now friends, in this scheme, India Newborn Action Plan, there are a lot of dashboard indicators, but impact indicators include a list of indicators, specifically birth registration, stillbirth rate, early neonatal mortality rate, neonatal mortality rate, cause specific neonatal mortality, percentage neonatal mortality of under 5 mortality rate, and those who were admitted to NICU PICU, their survival rate at 1 year of age. So answer to this question is choice number B. Neonatal mortality rate is an impact indicator. Finally, we want to reduce neonatal mortality and stillbirth rate under India Newborn Action Plan to single digit by the year 2030. Health education models we remember by the mnemonic MMS. These are medical, motivation and social intervention. Choice number B, 1, 2 and 4 are included. Consider the following statements about correlation. Friends, what is correlation? It is relationship between two quantitative variables like height and weight. It is depicted through scatter diagram where we have a correlation coefficient R which lies between -1 to +1. If it is a positive correlation, it lies between 0 to 1. If you increase one variable, other will increase. +1 indicates perfectly positive correlation. If it lies between -1 to 0, negative correlation. If you increase one variable, other will decrease. And if R is 0, there is no correlation, absent correlation. Change in one variable will not affect the other. So let us look at it choice by choice. Correlation is done between independent variable x and dependent variable y. This is correct. It lies from -1 to infinity. No, it lies from -1 to +1, having three situations I have told you. positive correlation, negative correlation, absent correlation? No, rather I told you when it is +1, it is a perfectly positive linear correlation. So this is not a correct statement. And look at fourth statement, correlation does not prove causation. This is correct. For causation, you have to establish causality criteria like Hill's criteria of causal association. So correct statements are statement number 1 and 4. Correct answer will be choice number D. A water body was inspected for mosquito eggs. So we are looking at mosquito eggs. And it was observed these are boat shaped eggs laid singly, not in clusters, and they have lateral floats. Boat shaped eggs with lateral floats are characteristic of? Yes, it is Anopheles mosquito. So malaria transmission, Anopheles culici faces rural area, Anopheles stephensi urban area. This we have to remember. National Health Policy target of 90-90-90. Friends, when we look at this 90-90-90, what is this? That 90% of people living with HIV must know their status, that they are HIV positive. Of those 90% who are HIV positive must have access to treatment, and 90% of those getting treatment must have effective viral load suppression. So answer to this question is choice number D. 2 and 4 are included in 90-90-90. This 90-90-90 initiative by UNAIDS was supposed to be achieved till 2020. Now it has been upgraded to become 95-95-95 by 2024. It remains same. 95% of people living with HIV must know their status. 95% of positives must have access to treatment, and 95% of those on treatment must have effective viral load suppression. Question number 26. Sample registration system is an important source. 6 months there is an independent survey. So someone comes to our house, collect data on infant mortality, maternal mortality, neonatal mortality, birth rate, death rate, growth rate, under 5 mortality also. And every 6 months a supervisor comes and checks this data collected by enumerator. So this is a dual record data system. 2 times data is collected. In fact, it makes SRS most accurate data collection system in the country. SRS is undertaken once every 6 months in the country. Crossover type of study design. Friends, what is this? Crossover type of study. There are 2 groups in a study. Study is continuing. After some time, study subjects in both the groups crossover. So if someone was giving someone was getting intervention in the first group, later it will go into second group, and those in the second group will come into the first group to receive that intervention. So they are crossing over from one group to another. This you have to remember. It is not useful if drug cures the disease. If drug cures the disease, you will not get the time for crossover. Also, if the disease radically changes during the course of the treatment, then also it will not help crossing over, because you will not be able to evaluate your results. So answer to this question is 1 and 3. Crossover results or crossover studies are not applicable or valid. It is useful if the drug is effective during all stages of the disease. Yes. Average number of children a woman would have if she were to pass through her reproductive years, bearing children at the same rates as the woman now in each age group. This is TFR, total fertility rate. In simple words, it is total children born to a woman in her entire reproductive lifespan, also known as completed family size. In contrast, gross reproduction rate is total number of girl children born to a woman in her entire reproductive lifespan. Net reproduction rate, NRR, This is total number of girl children born to a woman in her entire productive lifespan, taking into account their mortality. How many girl children died? After that, how many are remaining net alive? So total children TFR, total girl children GRR, total girl children minus death, net reproduction rate. Which among the following is correct about yellow fever vaccination requirements? Friends, yellow fever vaccine we use is live attenuated lyophilized vaccine, which is reconstituted with cold physiological saline. Its strain is 17D. 6 years ago, its period of validity was changed from 10 days to 10 years earlier to now it has become the certificate of validity of yellow fever vaccine. International travelers require it. It becomes valid 10 days after taking the vaccine and it remains valid lifelong. In fact, it was recommended those who have taken the vaccine prior to 2016 need not take a booster. So answer to this question is choice number A. First statement is correct. Validity has been changed from 10 years till lifelong. Second statement, lifelong applies automatically to the existing as well as the new certificates. Validity becomes 4 days. No, validity becomes it becomes valid after 10 days and booster is not required. Regarding active immunization against typhoid fever, consider the statements and mark the statement which are correct. So friends, let's read all the statements. Statement number 1, typhoid polysaccharide vaccine is injectable and can be given subcutaneously or intramuscular. This is correct. So when we look at Typhim VI, VI is the polysaccharide and it is given intramuscular or subcutaneous. A single dose is sufficient. So read second choice, 2 doses. No, only a single dose is sufficient. Look at choice or statement number 3, typhoid oral TY21A. This is given on 3 days. If you look at oral vaccine Typh oral, it is given in 3 doses on day 1, 3 and 5. So look at statement number 3, it is given on 0, 3, 7 days. This is wrong. Look at statement number 4, protective immunity occurs immediately. This is wrong, friends. Protective immunity actually starts minimum 4 weeks after receiving the typhoid vaccine. So answer to this question is choice number A. Which of the following statement are correct regarding MON2 test for tuberculosis? Friends, it's an immunity status test. Let's go by statement. First statement, it entails giving 1 tuberculin unit of PPD in 0.1 intradermal. This is correct, friends. First strength, 1 TU in 0.1 ml is given intradermally on flexor aspect of left forearm. Second statement, injection should be given with bevel facing downward. No, friends. Bevel should always be facing upwards. When placed correctly, injection should give a wheel of 1 to 2 millimeter in diameter. This is wrong, friends. Wheel we require is 6 to 10 millimeter in diameter. And statement 4, injection should be given with a tuberculin syringe. This is correct. Reading is taken after 72 hours in ideal situation. We measure the horizontal maximum diameter of induration in that reading. Less than 6 is negative, more than 9 millimeter is positive, 6 to 9 is equivocal. Also remember the strain used is RT23 with tween 80. So correct answer is choice number B. Statement number 1 and 4 are correct. Which of the following types of ventilation best fits? Let's read the statement. A system of ventilation in which fresh air is blown into the room. So exhaust air is pushing out the older air. If you open the opposite door or window, fresh air will come in. Ventilation opposite to that, it is pushing fresh air in the room so that from older air can go out of the opposite door or window. So displaces the vitiated air. This is plenum ventilation. So friends, again to summarize, when you look at exhaust ventilation, it pushes older air out of the room. Open the opposite door or window, fresh air will come in. Whereas when we look at plenum ventilation, It pushes fresh air in the room. Open opposite door or window, older air will go out. Nalgonda technique developed by National Environmental Engineering Research Institute. This institute located in Nagpur. And what is this Nalgonda technique used for? This is used for defluoridation of water. And what is the sequence of chemical addition in Nalgonda technique? It is lab. So that is, first we add lime, then alum, and finally bleaching powder. So answer to this question is choice number B, fluorine. Smoking is considered a modifiable risk factor for coronary heart disease. Consider the following statement with regard to possible mechanisms. See, when we look at smoking as a risk factor for coronary heart disease, it has three possible mechanisms. Look at choice number A, nicotine stimulation of adrenergic drive raises the blood pressure, myocardial oxygen demand and myocardial oxygen demand. This is correct. It increases carbon monoxide and induces atherogenesis. This is also correct. Plaque formation occurs. It leads to fall in protective high density lipoprotein. This is also correct. It reduces A lipoprotein B plasma level. This is wrong. So answer to this question is choice number C, 1, 2 and 3. Expected outcome of government's initiative Suman. Friends, what is Suman? This is Surakshit Matritva Ashvasan. This scheme was launched by Government of India 10th October 2019, where main aim is to lead to zero maternal and newborn deaths in the country. And this is possible through three different packages provision in the scheme. One is basic package, another is BIMONC package, basic emergency obstetric and newborn care, and CMONC package, comprehensive emergency obstetric newborn care package. So answer to this question is choice number A, zero preventable maternal and newborn deaths. Water contamination with high content of which chemical can lead to methemoglobinemia? Answer is nitrates. Although friends, recent studies shows this is more of a cofactor in development of methemoglobinemia. Otherwise, nitrates recommended level is less than 45 milligram per liter in drinking water. And if it is found, it is an indicator of remote contamination of drinking water. Which of the following statement is correct regarding KFD? Kaisanur forest disease. So friends, let's go choice by choice. Choice A says it is commonly seen in northeastern states. No, it is seen in 5 districts of Karnataka. Kaisanur forest. So 5 districts of Karnataka including Shimoga district reports Kaisanur forest disease every time. Monkey act as reservoir. This is correct. KFD is also known as monkey disease for the same reason. Statement 3, transmission is due to tick bite. This is also correct. In fact, it is heart tick, Haemophilus spinigera, which leads to transmission of Kaisanur forest disease. Statement 4, inactivated vaccine is available for its prevention. This is true. It is available, but it is not much benefit from this vaccine. So it is not commonly used, but it is available. So answer to this question is choice number D. Second, third and fourth statement are correct. Question 38, which events could be caused or precipitated by an active component of vaccine? Friends, we are looking at FIs. Adverse events following immunization. So let us go choice by choice. Choice, first statement, anaphylaxis after measles vaccine. This is correct. Majority of vaccines can lead to anaphylaxis. Majority of vaccines can lead to hypersensitivity. Most common culprit is hepatitis B, but measles can also lead to that. Encephalopathy after DPT vaccine. Pertussis is neurotoxic. Encephalopathy, seizures, active epilepsy, it cannot be given. It may also lead to hypotensive, hyporesponsive episode. Persistent crying, these are all are associated with neurotoxic component pertussis of DPT. Adenitis following BCG vaccine. Yes, lymphadenopathy, especially cervical, is possible after BCG vaccine. Gastroenteritis follow MMR vaccine. No, gastroenteritis is not a related adverse event following immunization with MMR vaccine. So answer to this question is choice number A, 1, 2 and 3. An 11-month-old unimmunized child comes for immunization. Which vaccines can be given? Friends, we have discussed in detailed immunization limits according to National Immunization Schedule for each vaccine in the video Vaccines and Cold Chain. So let us look at 11-month-old unimmunized child. Which vaccines you can give? You can give BCG, although it is preferable within first 15 days of birth, OPV, DPT, Hep B, HIV. We can also give, see, BCG is permitted up to 1 year, OPV up to 5 years, DPT up to 7 years, hepatitis B up to 1 year, HIV up to 6 years. We can also give rotaviral vaccine permitted up to 1 year of age, fractionated IPV permitted up to 1 year of age, pneumococcal conjugate vaccine permitted up to 1 year of age, measles or MR given up till 5 years of age, vitamin A 5 years of age, Japanese encephalitis given up to 15 years of age can also be given till. So best possible combination, if you look at all the choices, the nearest closest answer is choice number D, although BCG could also be included in this particular list. Which of the following treatment for a pregnant lady who has been exposed to a patient of chicken pox? Friends, if you want to prevent chicken pox in pregnancy, ideal situation is prior to pregnancy, prior to planned pregnancy, a woman should be given the vaccine, varicella vaccine. But now she has been exposed to virus during pregnancy. Now you have to manage it. So we use varicella zoster immunoglobulin. Ideally, it should be used within 72 hours of exposure, but can be given up till 96 hours also. Acyclovir, this is also given 800 milligram TDS for 7 days, or valcyclovir 1 gram TDS could also be given. So answer to this question is choice number C, 1 and 3 only are correct. Varicella zoster vaccine and prednisolone is not required once a pregnant female has been exposed to a case of chickenpox. Question number 41. Vaccine associated poliomyelitis chiefly seen with. Friends, VAP, vaccine associated paralytic polio, occur due to all three: P1, P2, P3. But it is the P3 which leads to more than 60% of the cases, most common cause. Rest of the cases are caused by P2 and very few are by P1. So best possible answer to this question is choice number, because examiner is saying chiefly, answer is choice number C, OPV3 only. Friends, thank you so much from my side, Dr. Vivek Jain's side, and whole team of Cerebellum. I wish you all the best for a grand success in this examination.
Hey everyone, welcome back. I'm Dr. Dilip, your medicine faculty at CerebellumAcademy, and we're going to have a quick and a fast review of all the medicine questions asked in the recent UPSC CMS 2023 paper. We have around 40 questions. Let us don't take much of a time and let us try to finish off in 20 to 30 minutes. And question number 1, which of the following are recommended for the management of tumor lysis syndrome? Option 2, intravenous fluids. Absolutely correct, because you need to give fluids minimum at a dose of 3 liters per meter square per day to flush out all the monosodium urate as well as the calcium phosphate and even the hyperxanthine crystals, and you don't want them to accumulate in the urine, right? So that's the right statement, one of the very important treatments. And option 3, that is rasburicase, is also correct. It's a recombinant uricase, and we use rasburicase as a treatment of established, or otherwise called as clinical tumor lysis syndrome, plus at the same time it's also used as prophylaxis of high-risk patients with tumor lysis syndrome. Febuxostat is also correct, and allopurinol, even though it's a first line, febuxostat, which is also xanthine oxidase inhibitor, can be used as an alternative to allopurinol in case if you can't use allopurinol. The wrong option is actually the urinary alkalinization. That is because in the current guidelines, they clearly mention that urinary alkalinization, even though it can increase the excretion of monosodium urate crystals, it can actually increase the precipitation of certain crystals like calcium phosphate and even hypoxanthine. That's the reason why urinary alkalinization is something that is not recommended and should not be done for the treatment of tumor lysis syndromes. Right answer for this question is going to be option D, because 2, 3, and 4 is correct. Coming to question number 2, focal seizures may be associated with which of the following? So this is actually a kind of a straight question from Harrison. You have a separate paragraph in Harrison under focal seizures where they mentioned the 3 additional features of focal seizures. In that point number 1 is Jacksonian march, which means based on the motor homunculus, the seizure starts at a particular place, like for example the fingers, and it can march along the forearm, arm, and then back into other parts of the body. So this is what we call as Jacksonian march. And patients can develop weakness of the affected area after the seizure has disappeared. That's what we call as postictal Todd's palsy or Todd's paralysis. And number 3, in some situations, the focal seizures may continue for days and even weeks together. So that's what we call as epilepsia partialis continua. So all 3 are correct. So I'm going to go for option D. So 1, 2, 3 are correct. Coming to question number 3, typical absence seizures are characterized by option A, abrupt 3 Hz spike and slow wave discharges on EEG. Absolutely correct. In fact, it's one of the characteristic findings of typical absence. Option B, postictal confusion in children. Definitely wrong. In fact, postictal state is not seen in patients with typical absence seizures. All you're going to have is just a momentary lapse of consciousness. That's all. And option C, multifocal structural abnormalities in brain. That's also wrong, because by definition, in a typical absence, MRI should be normal. There should not be any structural abnormalities. Option D, less responsive to anti-epileptic drugs compared to atypical absence seizures. This is also wrong. In fact, it's the other way around. Atypical absence seizures are basically not going to respond that much to anti-epileptic drugs, but typical absence seizures are one of the easier seizures to treat in practice. So that's wrong. The right answer for that question is option A. Question number 4, which of the following are contraindications of thrombolysis in acute ischemic stroke? So first option, recent head injury in the last 3 months. It's an absolute contraindication, clearly mentioned in Harrison. Recent MI in the last 1 month is also mentioned in Harrison. But I don't know why this has been mentioned in the 21st edition also, because according to the recent guidelines of ACCH or any other guideline you see for management of acute ischemic stroke, recent MI has been removed as a part of the contraindication list. So it's basically not a contraindication according to most guidelines in the world, but Harrison for some reason still continues to mention that recent MI is a contraindication. Let us go for it as well. And GI bleeding in the last 3 weeks is definitely a contraindication, clearly mentioned, and according to the guidelines also, GI bleeding in the last 3 weeks is a contraindication. Option 3, hypertension more than 150/100. Hypertension is a contraindication, but the cutoff mentioned here is basically wrong. So if the BP is more than 185/110 millimeters of mercury, then it is considered to be a contraindication for thrombolysis in the setting of acute ischemic stroke, not more than 150/100. So I'm going to go for option B, because 1, 2, and 4 are correct. Coming to question number 5, a 45-year-old male present with polyuria, polydipsia, and polyphagia. For the last 3 months, his fasting blood glucose is 106 milligrams per deciliter and random is 220. Which of the following statements is correct regarding his diagnosis? So first of all, we need to know what is the definition of diabetes mellitus. What are the cutoffs for diagnosing diabetes mellitus according to WHO? Fasting blood sugar should be more than or equal to 126 milligrams per deciliter. Postprandial blood sugar, so that is otherwise called as 2-hour 70-gram OGTT values. It should be more than or equal to 200 milligrams per deciliter. HbA1c should be more than or equal to 6.5%. Final criteria, random blood sugar should be more than or equal to 200 plus classic symptoms of diabetes like polydipsia, polyuria, and polyphagia. So our patient is having a random blood glucose of more than 200. Along with that, He's having classic symptoms of diabetes, so he has definitive diagnosis of diabetes mellitus. There is no doubt about that. Right answer for this question is going to be option B. Coming to sixth question, a 50-year lady who's a known case of rheumatoid arthritis, presents with obesity, moon phases, abdominal strain, and hypertension. Overnight dexamethasone suppression test shows serum cortisol of more than 50 nanomoles per liter, which means serum cortisol is very high despite dexamethasone suppression. ACTH is less than 1.1. Adrenal imaging and brain CT MRI imaging studies are unremarkable. The likely diagnosis. So here the right answer is option D, that is adrenal adenoma. So you might think that for rheumatoid arthritis patients may be using steroids, so it could be an exogenous glucocorticoid use. Remember, if it's exogenous glucocorticoid use, the endogenous serum cortisol should be suppressed. It should not be higher. So that's not the right answer. In case if it's a Cushing disease, it's a ACTH dependent condition, right? So your ACTH must be high, not less than 1.1 like what is mentioned here. If it's ectopic ACTH secreting tumor like small cell lung cancer or carcinoid, again your ACTH levels will be higher because it's a ACTH dependent Cushing. So definitely, so this is not the right answer. So only thing that fits into a diagnosis is adrenal adenoma. So we're going to have high cortisol but a suppressed ACTH. As simple as that. So right answer for this question is option D, adrenal adenoma. Coming to question number 7. A 27-year-old lady underwent thyroidectomy for thyroid cancer. Post-operatively, she started developing muscle cramps, perioral and peripheral paresthesia and carpopedal spasm. Which one of the following interventions will be appropriate for this patient? This is basically a very easy question because this patient is suffering from a post-thyroid surgery, transient hypoparathyroidism. Usually hypoparathyroidism after a thyroid surgery will be transient because of the local edema. It's very rare in the current practice to see a permanent hypoparathyroidism. But generally this is kind of a transient hypoparathyroidism because of edema of the parathyroid glands, and there will be hypocalcemia, and patients are having a classic manifestation of hypocalcemia. So right answer is going to be option C, that is measuring serum ionized calcium, and you have to administer IV calcium gluconate as appropriate. Coming to question number 8, which one of the following is an example of hypogonadotropic hypogonadism? Easy one, it is Kallmann syndrome. Kallmann syndrome is an isolated gonadotropin deficiency. There could be associated GnRH deficiency, but nevertheless, the main problem is low FSH in LH, and that is going to result in reduced productions of sex hormones like testosterone and estrogen, depending on whether it's a male or a female. So basically, this is a hypogonadotropic hypogonadism, and patients are also going to have hyposmia or anosmia. Other three conditions, Klinefelter syndrome, Turner syndrome, cryptorganism, are basically gonadal causes. So they're going to produce hypergonadotropic hypogonadism, and in these conditions, the FSH and LH will be higher. The right answer for this question is option A. Coming to question number 9, which one of the following is a cause of relative erythrocytosis? The right answer for this question is a straightforward diuretics, because you know the reason for relative erythrocytosis is hemoconcentration. That is nothing but reduced plasma volume. Anything that reduces plasma volume or shrinks the plasma volume is going to cause a relative erythrocytosis. So diuretics in that regards is definitely going to shrink the plasma volume, and that is going to cause a relative erythrocytosis. Other conditions mentioned here are going to increase the erythropoietin production, and that is going to produce a kind of absolute erythrocytosis and not relative erythrocytosis. The right answer for this question, yes, rightly it's going to be option D. Question number 10. A 60-year-old diabetic female presents with acute myocardial infarction. ECG changes include ST elevation of more than 1 mm in lead AVR. The likely localization of thrombosis is in. So this is something that we have discussed time and again in many of our lectures. If you see ST elevation in AVR, that definitely indicates a left main coronary artery problem or a left main stem problem, or sometimes rarely it can be a proximal LAD lesion. So right answer for this question is a straightforward option D again. Coming to question number 11. Thick ventricular wall with normal diastolic function. So again, this is a straight line from Harrison. This is basically a physiologic change that is seen in patients who are heavy athletes and endurance trainees. It's nothing but athlete's heart. Other conditions mentioned here are basically pathological conditions, not physiological conditions. So definitely you're going to have moderate to severe diastolic dysfunction in these conditions. You will not be having normal diastolic function. Coming to question number 12, in which of the following cases does paradoxical splitting, that is reverse splitting of second heart sound, is going to occur? So reverse splitting of second heart sound is going to occur in the setting of severe left ventricular outflow tract obstruction, like in severe aortic stenosis, which is a kind of fixed LVOT obstruction. and it can also be seen in hypertrophic obstructive cardiomyopathy, which is a kind of a dynamic LVOT obstruction. Another important cause of reverse splitting is left bundle branch block, but there are some conditions that can mimic left bundle branch block, like for example, RV pacing. Right bundle branch block is basically going to produce only wide split because of delayed P2. And that is because of slow conduction and depolarization of the right ventricle. Right answer for this question is going to be option C, because 1, 3 and 4 is correct, 2 is wrong. Coming to question number 13. A patient with peripheral edema has the following findings on clinical examination. A soft systolic murmur at the lower left sternal border with raised JVP showing a prominent CV wave. That's CV fusion, which means they are saying that X descent is gone. The murmur increases in intensity on deep inspiration. So, which is basically nothing but de Carvalho's effect or de Carvalho's sign. The most likely valvular abnormality you would have guessed by now, it's a straightforward tricuspid regurgitation. Mitral murmurs will be heard usually in the apex, not in the left lower sternal border, and these murmurs are going to get augmented with expiration and not inspiration. Ventricular septal defect, even though the murmur will be heard in the left lower sternal border, typically you're gonna have the murmur increased with expiration and not with inspiration. So this also does not fit into the diagnosis. The right answer for this question is going to be option C, that is tricuspid regurgitation. Coming to question number 14, that is Kussmaul sign is a clinical feature of straightforward constrictive pericarditis. In exam, whenever they mention pulsus paradoxus, always think about tamponade or acute exacerbation of bronchial asthma COPD. Whenever they talk about Kussmaul sign, you have to always think about constrictive pericarditis. This is a kind of a unwritten rule in exams. It's a very, very easy question. Answer is option A. Coming to question number 15. A patient has a cardiac murmur that is best heard at the right second intercostal space, which means they are talking about right upper sternal border. It increases with expiration. Also, the murmur reduces intensity during sustained hand grip, but increases in intensity on inhalation of amyl nitrate. The likely lesion is, right answer is basically aortic stenosis. That's the right answer. So, because the murmur is heard better in the right upper sternal border. Whereas hypertrophic obstructive cardiomyopathy murmur will be heard better in the left lower sternal border, not in the right upper sternal border. Plus, at the same time, respiratory variations with regards to HOCM murmur is something that we don't see. Even though other dynamic auscultation findings do correlate with HOCM murmur, the location of the murmur and that classic increase in murmur with expiration usually do not correlate with the HOCM murmur. So HOCM murmur also is going to increase with decreasing afterload, like inhalation of amyl nitrate, and HOCM murmur is also going to decrease with increase in afterload, like what you're doing via sustained hand grip, where you're going to increase the afterload. In that situation, the murmur intensity is going to decrease. So this is applicable for both HOCM murmur as well as aortic stenosis murmur. But the increase in intensity with expiration and the right upper sternal border location is going to go only with aortic stenosis and not with HOCM. Other two options you can easily rule out. So that's not going to be a big deal. So question number 16, in the modified Duke's criteria for infected endocarditis, which one of the following is not a major criteria? So imaging findings like new partial prosthetic valve dehiscence, positive blood cultures, and other imaging evidence like new valvular regurgitation or even presence of vegetations are basically major criteria. But option C, rod spots, is kind of minor criteria because it comes under immunological phenomenon. You know, immunological vascular phenomenon are going to come under minor criteria, and you have 4 immunological phenomenon. One is going to be rod spot, second is Osler's nodes, third is glomerulonephritis, and fourth is going to be rheumatoid factor positivity. So right answer for this question is option C. Coming to question number 17, Osborne waves in ECG show prolonged repolarization with a distinct convex elevation of the J point. These waves are associated with very simple systemic hypothermia. Whenever the patient is having moderate to severe hypothermia, you are going to notice this Osborne waves, even though very rarely seen in mild hypothermia, but it's a characteristic waveform seen in moderate to severe cases of hypothermia. Plus, at the same time, similar looking waves can also be seen in an important electrolyte disturbance called as hypercalcemia. Even that can be asked in exam, so keep that in mind. Coming to question number 18, a decline in total lung capacity less than 80% of patients' predictive value is indicative of restrictive lung disease. Remember, the gold standard for the diagnosis of restrictive lung disease is a TLC of less than 80%. In fact, this is the very definition of restrictive lung disease. So this is a very easy one. Right answer is option A. Coming to question number 19, A 20-year-old male is suspected of having HOCM, that is hypertrophic obstructive cardiomyopathy. Which of the following statements are likely to be true on his examination? Maneuvers that decrease preload will cause murmur to intensify. This is a right statement. Arrows always move in the opposite direction when it comes to load and HOCM, murmur and obstruction. Maneuvers that decrease LV afterload will cause a decrease in the intensity of the murmur. It's a wrong statement because the murmur has to increase, because obstruction will increase with decreasing afterload. Murmur of HOCM becomes softer, that is decreasing with passive leg raising. Passive leg raising is going to increase the preload, we know that. So that's the right answer. So option 4 states murmur of HOCM becomes louder, which means it's increasing with squatting. Squatting is going to increase the preload. In fact, squatting is a very powerful murmur that decreases the murmur, not increases the murmur. So this is a wrong statement. Right answer for this question is option A, 1 and 3 is correct. Coming to question number 20, easy one. GnRH deficiency with hyposmia is typically seen in Kallmann syndrome. We have discussed that already. Coming to question number 21, which one of the following statements is correct with regard to peptic ulcer prophylaxis? Stress ulceration during critical illness is uncommon, is a wrong statement because stress ulcer is very, very common in the ICUs. In fact, the incidence is estimated to be as high as more than 50 to 70%. Ulcer prophylaxis should be discontinued once central feeding is established is also wrong statement. Remember, there are only two most important indications of stress ulcer prophylaxis we call it as SUP. One is being on a mechanical ventilator for more than 48 hours. Number 2, evidence of coagulopathy, like for example, thrombocytopenia, like platelet count of less than 50,000 or high INR. So if these indications are there, you're going to continue stress ulcer prophylaxis despite the fact whether the enteral feeding is established or not, even though enteral feeding is kind of protective by making the stomach secretions alkaline, but still it's not the only thing that you're going to do in the setting of ICU and stress ulcer. So that's the reason why you have to continue stress ulcer prophylaxis as long as the risk factors are there. So this is the wrong statement. Option C, PPAs are effective at reducing the incidence of GI bleeding due to stress ulcers. Absolutely correct. So in fact, PPAs are the drug of choice and they are the most effective treatment for stress ulcer prophylaxis. Option D, PPAs when used with antibiotics decrease the risk of Clostridium difficile infection is a wrong statement as well. That is because PPAs, if it's used injudiciously, can result in increased risk of Clostridium difficile infection. Plus, they can also increase the risk of hospital-acquired pneumonia. That's why the right answer for this question is one and only option C. Coming to question number 22, which of the following drugs can cause granulomatous liver injury? So this is kind of a tough question because this question is exactly from a Harrison table under drug-induced liver injury. But one option you can easily rule out is option 4, acetaminophen, because this is going to produce centrilobular necrosis. We know that. Centrilobular necrosis. So just by rule of exclusion, you can say other 3 must be correct because your options contain like combination of 3. So that's why I can say 1, 2, 3 is correct. And if you look at Harrison table, there I mentioned that carbamazepine, allopurinol, diltiazem does cause liver injury via granulomatous injury. So right answer for this question is option A, 1, 2, 3 are correct. Coming to question number 23, a 56-year-old male, chronic heavy smoker present with breathlessness on examination, pulse 96 BP, 112/70, and a pansystolic murmur is showing Carvalho's sign, that is nothing but murmur getting louder on deep inspiration. Which of the following findings will be on his jugular venous pressure? It's very simple. The patient is actually having a tricuspid regurgitation. TR, you know that X descent is going to be attenuated or absent, and you're going to have a large V wave, and C and V will fuse. That's called as CV fusion, which is going to clinically manifest as earlobe pulsations called as Lance's sign. So the right answer for this question is option C. The V wave and C wave are going to merge. Coming to question number 24, the investigation of choice for early follow-up in patients treated for anti-H. pylori drugs is, again, this is a straight line from Harrison. If you look at the table of what all the investigations that you can use for diagnosing H. pylori infection and for monitoring the efficacy of therapy, there I mentioned that urea breath test or urease breath test is kind of a classic investigation of choice for early follow-up of patients who have been treated for anti-H. pylori drugs. So this is a kind of a test for eradication. So rapid urease test is an endoscopy based test. You can use it as a test for eradication. And stool H. pylori antigen test also can be used as a test for eradication of H. pylori, but for early follow-up, urease breath test is better. But serology for H. pylori cannot be used as a test of eradication. Even that can be asked in exams. Coming to question number 25, the most common non-pancreatic or extra-pancreatic site of gastrinoma in the setting of Zolling-Ellison syndrome is basically duodenum. Again, this is straight line from Harrison. It has mentioned that 60 to 100% of the time the extra-pancreatic site of carcinoma is going to be the duodenum. Other sites also have been mentioned, but these are rare sites. And interestingly, the extra pancreatic carcinomas tend to be non-malignant predominantly compared to pancreatic gastrinomas. Coming to question number 26, the most common cause of shock in severe acute pancreatitis is very simple. This is because of fluid exudation into the retroperitoneal space, resulting in a kind of hypovolemic shock, which is nothing but a third space loss. The right answer for this question is option A. Coming to question number 27, a 14-year-old boy came with chronic diarrhea and malnutrition. The physician suspected celiac disease. Which of the following are correct in his diagnostic workup? Presence of IgA anti-endomysial antibody. It's a correct statement. In fact, according to many guidelines, they say that this is the most specific investigation for celiac disease. And option 2, reduced height of villi on intestinal biopsy is also correct, because villus atrophy is one of the classic findings in biopsy. And option 3 states increased lymphocytes in lamina propria in small intestinal biopsy. That is also correct. And option D states absence of anti-TG IgA in the serum is wrong, because anti-TG IgA by far is the most sensitive investigation for the diagnosis of celiac disease. On top of that, it's very specific also, and this is basically the test that we do in daily day-to-day clinical practice. That's why that's definitely wrong. So I can say the right answer is going to be option A. 1, 2, 3 are correct. 4 is definitely wrong. Coming to question number 28, which of the following statements are correct for obesity? Option 1, adiponectin levels are reduced in obesity. That's correct. So there are two things that will be reduced in obesity. One is adiponectin and second is ghrelin. One thing will be increased in obesity, that is leptin levels. That can be asked in exams as well. Option 2, orlistat is a reversible inhibitor of lipase used in the treatment of obesity. This is also correct. It's a slowly reversible inhibitor of lipase. And option C states liraglutide used for type 2 diabetes management can cause weight gain and not recommended in obese patients in type 2 diabetes mellitus. This is a wrong statement because it's going to produce weight loss, and it's recommended in patients who are obese and having type 2 diabetes. In fact, it's an approved independent weight loss drug as well, which can be used even without diabetes. Option 4, bariatric surgery is recommended in obese patients with a BMI of more than 30 is wrong because the cutoff mentioned here is wrong. So indication of bariatric surgery is BMI of more than 40 or BMI of more than 35 with significant comorbidities like diabetes, hypertension and so on. So the right answer for this question is option B, because 1 and 2 is correct. Coming to question number 29, HIV associated neurocognitive disorder, that is HAND, includes which of the following? Again, this is a straight question from a paragraph in Harrison on HIV associated neurocognitive disorder, where they have mentioned clearly that the patient can present with asymptomatic neurocognitive disorder, or they can have minor neurocognitive disorder, or they can have a frank major problem that is nothing but HIV associated dementia, where the patient may be even dependent on others for the day-to-day life. So the right answer for this question is option D, because all three are correct. Coming to question number 30, consider the following statements with regards to cysticercosis. It may present as personality change, correct. It may, definitely yes, but the most common presenting feature is going to be seizures. That's how they're going to present. The most common extraneural sites for cysticercosis is going to be subcutaneous tissue and the muscle. So if you find any subcutaneous nodule, you can exercise for histology. That's going to definitely confirm that you are having cysticercosis or not. Option 3, cerebral signs commonly do not occur until the larvae die 5 to 20 years later. This is also correct, because if the cysts are viable, usually they don't elicit any inflammatory reaction. But if the cysts are dead, they're going to produce a lot of degenerative changes, and that's going to trigger inflammation. That's where the patient generally manifests. Option 4, praziquantel can be given for 10 days. This is also correct. In fact, the first line drug is albendazole, but alternative is going to be praziquantel and can be given for 10 days. That's correct. Which of the following statements given above are correct? I can say that option D is correct because all 4 is basically correct. Coming to question number 31, consider the following statements with regards to jaundice. Option 1, presence of scleral icterus indicates serum bilirubin level of at least 3. Absolutely correct. And again, this is a question from one of the paragraphs of Harrison. They have asked line by line. So whenever the bilirubin goes beyond 3 milligrams per deciliter, you tend to manifest as yellowish discoloration of sclera. That's correct. If the examiner suspects scleral icterus, second site to examine is underneath the tongue. Absolutely correct. Straight line from Harrison. In long-standing jaundice, skin become green sometimes due to reduction of bilirubin to biliverdin. Again, a straight line from Harrison, correct. Sclera have particular affinity for bilirubin due to its high elastin content. Again, correct. Right answer is going to be option D. All 4 options are correct. Coming to question number 32, again a straight line from Harrison. Carotenoderma due to excessive amounts of keratin containing fruits and vegetable ingestion can be distinguished from jaundice by sparing of which of the following? It's been clearly mentioned in Harrison that carotenoderma can cause generalized yellowish discoloration of the body elsewhere, but not sclera. Sclera will be typically spared in carotenoderma, but whereas in jaundice, it will be definitely affected. The right answer for this question is option D. Coming to question number 33, Mayer's-Tammy test is used in which one of the following clinical conditions? It's a kind of a 4-tube test where I'm going to collect urine in 4 different tubes, 4 different samples. First sample will represent the urethral sample. Second sample will be the midstream sample representing the bladder sample. And the third sample will be collected after prostatic massage. That's called as EPS, expressed prostatic secretions. And finally, you're going to collect the final sample in the 4th tube. And in that, if it's a bacterial prostatitis, your third sample is going to be usually positive because that's the EPS sample, expressed prostatic secretion sample. So basically, this is an outdated test, but I can easily answer that it's used for recurrent urinary tract infection in men. Coming to question number 34, which of the following are typical physical findings in pericardial effusion? They're asking about tamponade, I believe. So raised JVP definitely is a part of Beck's triad, jugular venous distension, hypotension, and you will see muffled heart sounds, of course. Oliguria can occur because of hypotension and shock, but what you don't see is water hammer pulse. In fact, the pulse will be weak and thready, and you may notice something called as pulsus paradoxus, not water hammer pulse. What is pulsus paradoxus? Fall in the systolic blood pressure by more than 10 millimeters of mercury during inspiration is what we call as pulsus paradoxus. That is seen typically in cardiac tamponade and conditions like acute exacerbation of bronchial asthma and COPD. The right answer for this question is going to be option A, 1, 2 and 3 going to be correct. Coming to question number 36, I think there is a numbering issue, 35th is missing, but nevertheless, so 36 question, which of the following conditions can produce a third heart sound and auscultation? Young age is a very important physiological cause of third heart sound because of hyperdynamic circulation. Pregnancy can produce third heart sound again because of hyperdynamic circulation. Left ventricular failure is a very important pathological cause of third heart sound. Mitral stenosis nevertheless will not produce third heart sound because LV is going to be small, it's not going to have sufficient volume, and of course in mitral stenosis, in a pure and true mitral stenosis, you are not going to have LV failure at all. The right answer for this question is going to be option A, 1, 2, 3 are correct. Coming to question number 37, consider the following statements regarding radiation enteritis and proctocolitis. Option 1, diarrhea in acute phase should be treated with codeine or loperamide. Absolutely correct. Surgery is the treatment of choice and involves resection of injury in the spine. Is wrong because surgery will be done only in selected patients. In fact, surgery will be done only if there are some complications like stricture, obstruction, or probably fistula formation. Option 3, sucralfate enemas and hyperbaric oxygen are effective treatments even though controversial and not available routinely. Like for example, hyperbaric oxygen is not there in India in many places. You can use it, and to be honest, sucralfate enemas are considered as one of the first line treatments in patients with radiation proctocolitis. Option 3 is definitely correct. And option 4, small bowel strictures and rectovaginal fistula can develop as chronic complications. That's also kind of a right statement. So I can say 1, 3 and 4 is correct. So the right answer for this question is option D. Coming to question number 38, consider the following statements with reference to trans fatty acids. Option 1, they are geometrical isomers of cis unsaturated fatty acids. That's correct. Though atherogenic, being unsaturated, they are less so than saturated fatty acids is definitely wrong. To be honest, this is one of the worst form of fats that you can ever consume. So never ever consume trans fatty acids in your life as much as possible. And some countries even imposed a ban on products that contain trans fatty acids because they are highly atherogenic. I would say like certain saturated fats are much better compared to trans fatty acids. Trans fatty acids are like no way it's going to be good, it's going to be definitely bad. Option 3, it takes years for trans fatty acids to be flushed from the body. To an extent, it's a kind of a right statement, and that is based on the turnover of adipose tissue. The half-life of fat in adipose tissue is going to be around like 1 to 2 years, so that's why they have mentioned that. But this is a kind of a old notion from the old textbooks. So in the modern era, we believe that all the fats, including trans fatty acids, are metabolized in the same way. So there's no much difference. And option 4, they lower both LDL and HDL cholesterol in the body is a wrong statement. They increase LDL and they increase triglycerides, and they're going to lower HDL. They're worse forms of fatty acids, trust me. So the option 4 is wrong. So right answer for this question is option B, because 1 and 3 are correct. Coming to question number 39, which one of the following is a cause of exudative ascites? Congestive cardiac failure, transudate, portal vein thrombosis causes portal hypertension, transudate, nephrotic syndrome, you know, it's a classic transudate. Peritoneal malignancy is basically an exudative cause of ascites. Pancreatic ascites, peritoneal malignancy, tuberculosis, secondary bacterial peritoneum, these are all causes of exudative ascites, not transudative ascites. Coming to question number 40, which of the following drugs are useful in the treatment of Listeria monocytogenes infection? The one thing that you can easily rule out is ceftriaxone, because cephalosporins have no activity against Listeria monocytogenes. So other three are basically correct. Ampicillin is considered to be the drug of choice. On top of that, you can add gentamicin if you want for synergy. And in patients who are penicillin allergic, you can probably use cotrimoxazole, that is trimethoprim sulfamethoxazole combination. Right answer for this question is going to be option B. 2, 3, 4 are correct. Coming to question number 41, ischemia reperfusion syndrome is characterized by, it's simple, because of ischemia you are going to have hypoxia, and that is going to some way trigger free radical formation. Reperfusion is going to augment the free radical formation. There will be a mismatch between nitric oxide production and free radical production, where the balance will be more towards the free radical mediated damage, and that is going to in turn activate the inflammation. Simple one. So this is basically the mechanism in ischemia reperfusion syndrome, and the right answer is option A for this question. And thank you very much. Wishing you all the very best.
Hello students, I am Dr. Amrit Nasta, your surgery faculty, and let us quickly discuss the surgery questions that appeared in this UPSC exam. As such, they were fairly straightforward, most of them. So let's quickly go through each. So this was one of the recall questions that was received. A Sengstaken Blakemore tube or an SB tube is used in the management of poisoning, variceal bleed, asphyxia, or tension pneumothorax. This is a straightforward question. Answer is variceal bleed. SB tube, remember, is triple lumen and it is used for balloon tamponade. It is used to provide a balloon tamponade when you have variceal bleed in a patient of portal hypertension. This is not the treatment of choice. Of course, the first treatment, the treatment of choice is going to be endoscopic variceal banding. Right, so this was the question. This is how it looks, but this, if you see, this is not triple lumen. This has 4 channels. So this is 4 lumen or 4 channels. So if there are 4 lumen, it is called Minnesota tube. So you can expect this question to come next time. That is Minnesota tube. So that was the question. Let's move on. This is a standard question. Most common benign tumor of the liver. Liver is a very common site for a lot of tumors. Most common benign tumor is hemangioma. Most common malignant tumor is metastasis. Okay, remember metastasis from colorectal primary. So a colorectal cancer can metastasize to liver. That is the most common metastatic liver as well. Okay, that is the most common metastatic or malignant liver as well, but primary is going to be hemangioma. All right, this was a little tricky one. A young male was operated for DU perforation. He had peritonitis. He recovered well for 5 days. So for 5 days he was fine. Then he developed high fever. He had chills. He had toxemia symptoms, maybe tachycardia. He developed right shoulder tip pain, leading to hiccups. What is the most likely diagnosis? Now, this is the kind of question you have to think properly. DU perforation closure was done. Things were fine. Something went wrong after surgery, after 4 or 5 days. Means this is a post-operative complication. Okay, so the complication is post-operative. Now, what post-operative complication can happen after a DU perforation? There can be a leak. If there is a leak, and if there is peritonitis, the person should have rigidity, which is not given in the question. What have they given? He has right shoulder tip pain. He has hiccups. That means diaphragm is irritated. That means it is a subphrenic abscess. There is no reason for a liver abscess to happen. Surgical site infection would not cause diaphragmatic irritation, toxemia. There will be local symptoms. The best answer here will be right subphrenic abscess, which can happen if there was some residual collection. Let's move on. In seed bite syndrome or seed bite injury to the abdomen, the most common site of bleeding leading to hemoperitoneum is, this is a PYQ. This has been asked before in a lot of exams. Answer is mesentery of small bowel. So most common injury is mesentery of small bowel in seat belt syndrome. Right, let's move on. Which of the following statements is correct regarding EFAST? EFAST stands for extended fast in trauma. So when I say extended fast, normally when I do fast, I am screening for 4 regions. One is epigastrium, And in epigastrium, I look at the pericardium or cardiac tamponade. Apart from that, I look at right and left flanks or paracolic areas, and I look at pelvis. Now, when I do E, the extension, I also look at the two thoracic cavities, left and right. So, which one of the following they have asked is correct? Technique to assess free fluid in abdominal cavity alone? No. Thorax also. Technique to assess free fluid in abdomen, thorax, pericardium? This is the best answer. Okay, the others also obviously are wrong. Right, let's move on. Okay, 45-year-old patient. He comes with history of recurrent urinary tract infection. Normally, males should not get urinary tract infection. He says urine is frothy. It has bubbles. Frothy urine or urine having bubbles. This has a name. This is called pneumaturia. Pneum means air. Pneumaturia means air in urine. Obviously, there is no reason for there to be air in urine. Where will it come from? It is also called as champagne urine. Now, why would I have pneumaturia or champagne urine? This is seen when I have a sigmoid diverticular perforation which erodes into the bladder. So that is going to be seen in colovesical fistula. So what will happen is the air from sigmoid goes into the bladder, giving you the pneumaturia. This is a complication of sigmoid diverticular perforation. Okay, let's move on. Okay, this is a standard question. A 5-year-old child, male child, comes with a left-sided scrotal swelling. There is no cough impulse. The swelling does not reduce on compression or lying down. But there is a definitive history that the swelling is absent in the morning, increases during the day, which means the swelling disappears when the child sleeps. So it disappears during sleep. And slowly during the day. So when he wakes up, there is no swelling. And during the day, as the child is up and about, the swelling returns. So obviously, a swelling which disappears and reappears, that means it's showing what is called as reducibility. So this kind of a phenomena, it's a gradual reducibility of swelling. And gradual reducibility in a child for an inguinoscrotal swelling means it's a congenital hydrocele. So let's be very clear, the swelling that the child is having is a congenital hydrocele. Congenital hydrocele, the fluid will slowly come out during the day, and when the child sleeps, it will slowly go back. It does not go back immediately like a congenital hernia because the opening is very small. So fluid will slowly come and slowly go back. So what they are asking you is, how are you going to treat it? If the child was less than 2 years, you would have said wait till 2 years. At 2 years, you treat it. But since the child is already 5 years old, the treatment is going to be herniotomy. Okay, treatment of congenital hydrocele is herniotomy. It's not sac eversion. Sac eversion is for vaginal hydroceles. Vaginal means which are purely scrotal, not congenital. For tunica vaginalis hydrocele. So for those hydrocele, you can do eversion. But for congenital hydrocele, as well as for congenital hernia, the treatment is herniotomy. Hernioplasty is not going to be put in a child who is 5 years old. Hernioplasty is for adults. Okay. 25-year-old gentleman means a young male has dragging pain in the scrotum. There is a bag of worm type of feel. It disappears when he lies down. What is the first line treatment option? Okay, so dragging pain, that means the young man is having a varicocele. In a varicocele, there is a dilated pampiform plexus of veins. So what is the usual first line treatment? The answer is going to be percutaneous ablation. Okay, if this doesn't work, then the next treatment is going to be excision of pampiform plexus of veins. Okay, that is the next answer. So surgery will be done, but of course this is done when it is of a significant degree or if it is associated with infertility. First degree varicoceles need not be operated on. Okay, a malnourished 60-year-old man underwent emergency surgery for strangulated sigmoid volvulus. That means sigmoid colectomy was done. Post-operative period was stormy. Maybe he had paralytic ileus, maybe he had leak or something. But yeah, he developed a painful calf swelling in the right lower limb. What has happened? So if you say it is edema of renal failure, it should be bilateral. If you say cardiac failure, it should be bilateral. So pedal edema of failure or even hypoproteinemia should be bilateral. Here it is isolated and it is painful calf swelling. Simple question, deep vein thrombosis. This would have happened because he may not have walked around because he had a stormy course. So post-operative patient, high-risk patient undergoing pelvic surgery is likely to develop DVT. Okay, especially if he's elderly and he's not having much activity, if he's not walking around after surgery, he may develop DVT. Okay. Which of the following statements regarding thyroglossal duct cysts are true? This is straightforward, standard question, thyroglossal duct cyst. So you have the foramen cecum and the base of the tongue, which grows into the thyroglossal duct, which will eventually form the thyroid gland, and then it will atrophy. Once it atrophies, nothing is left. If it remains in some part remains patent, you will get a thyroglossal cyst like this. It is due to a remnant of the thyroglossal duct forming a cyst. Now, where is it seen? It is seen in midline of the neck. This is true. It moves up on swallowing, but not on tongue protrusion. This is false. It moves up because it is attached to the foramen cecum. It is treated by cyst trunk operation. This is also true. Maybe the only functioning thyroid tissue is also true. So the best answer here is going to be 1, 3, and 4. Okay. Easy thing was 2 is not there in the answer. So these 3 options went out because 2 is incorrect. Easy. Right. Okay. This is more medicine than surgery, but it's still easy. Classical clinical presentation. They have asked you classical, means they have asked you what is Beck's triad. Beck's triad is what is seen in cardiac tamponade, muffled heart sounds, hypotension, collapsed neck swings. Tachycardia is not necessarily a feature. So answer is going to be 2, 3, and 4. That is Beck's triad. This is again a yes and no question. Either you know it or you don't. Masuka staging is used for staging thymomas. Okay, thymomas are mediastinal tumors arising from the thymus gland. Okay, they are mediastinal tumors arising from the thymus. Okay, nice question. See, you see, they always ask you these kind of general surgery questions, and students often make mistakes in general surgery. They are very good with GIT, they are very good with Uro, but general surgery is what kills them. That should not happen. Which of the following are the common complications associated with enteral nutrition? Enteral means you are giving tube feeds, either nasogastric tube or nasojejunal tube or PEG tube, or you have done a surgical gastrostomy or jejunostomy. So these are what are ways in which you can do enteral nutrition. What can go wrong? Tube displacement can go wrong. Diarrhea, constipation, of course, can happen. If you are giving very high calorie feeds, high osmotic feeds, you can get diarrhea. Electrolyte imbalances can happen. So predisposition to systemic sepsis, this is usually a feature of parenteral nutrition. This is seen in TPN, not really in enteral nutrition. So option 3 should not be there. Answer is B. Okay, answer is B. You're seeing how easy, if you know one option correctly, you can easily get the answer. A 60-year-old tobacco chewer and a BD smoker comes with restricted mouth opening, means he has trismus. Occasional spitting of blood mixed with saliva, maybe poor oral hygiene, or maybe hemoptysis, don't know. Oral examination revealed a white plaque. So smoker, tobacco chewer, white plaque in oral cavity which cannot be rubbed off is going to be leukoplakia. Erythroplakia is red and velvety. Oral candidiasis is going to be seen in immunocompromised, uncontrolled diabetics, HIV positive patients. Speculate leukoplakia is a mixture of white and red both. Here they are saying white plaque, go for leukoplakia. This is a more pathology question than surgery. collar stud abscess, it is seen in the neck. It is seen in a patient of tubercular lymphadenitis. Okay, tubercular lymphadenitis in the neck. It's a complication of tubercular cervical lymphadenitis, that is collar stud abscess. This is a little tricky question. It's not given clearly in the books, but I will tell you the most logical answer here. What have they asked you? Best cosmetic result following breast reconstruction. Okay, they have asked you best. Now, when we talk about reconstructive surgery, there are simpler things in life, like you have those grafts, skin grafts, then you have flaps. And in flaps, there are different types. You have local flaps, you have pedicle flaps, and you have free flaps. Now remember the rule of reconstructive surgery. Free flaps are the most complex, difficult to construct reconstruction. They are the ones which give the best outcome. Best outcome in terms of cosmesis and functionality comes from free flaps. Okay, so all these synthetic grafts or synthetic implants can never match normal tissue. So acellular matrix flap, silicone implants are out. They are very easy to construct, but they are not as good as a flap. And in flap, free flap is the best. So between LD is a pedicle flap. TRAM can be pedicle, can be free, can be either. So the best answer is going to be tram flap. If tram is not there, there is an even better answer. If they ask you overall best outcome, answer is going to be DIEP flap. Okay, it is a muscle sparing tram flap. It is a free flap. It is muscle sparing. So the the transverse abdominis muscle is not cut. Okay, so it's a rectus abdominis. The muscle is not cut. It is sparing the muscle. Only the skin and the subcut are taken. So it is a muscle sparing. Rectus abdominis sparing DIEP, which is actually the best answer for that question. Okay, which of the following are correct regarding trichobezoar? Name should give you some clue. Tricho means hair. Bezoar means lump or ball of hair. So is it a hair ball in the stomach? Yes. It is seen in psychiatric patients. Yes. People who eat their own hair, they pluck it and they eat it. So when you see them, they will have very less hair on the scalp. They are actually eaten the hair. They are young psychiatric patients. Common complications are bleeding, perforation, obstruction. Usually it is obstruction. So yes. Treated with PPI, I know the treatment is going to be surgery. The treatment is going to be surgery. You have to do surgery and you have to remove the ball of hair. So easiest answer here 1, 2, 3. 4 should not be there, right? PPI is not going to dissolve the hair. Okay. Following statements with regard to colorectal carcinoma are correct. This is a very standard. Again, this is more pathology than surgery. Left-sided cancers present with bleeding. Okay, let me give you a little idea about this one. So what happens? Usually, cancers on the right side are cauliflower-like. Usually, they are exophytic because there the stools are not yet formed. So there is liquid stools in the colon, so the tumor can grow in the lumen. On the other hand, on the left side, you get a more apple core or napkin ring type of tumors, infiltrating tumors like this. They are not going to be cauliflower-like. They'll grow in the wall and constrict the wall. So left-sided tumors can present with bleeding or change in bowel habits is true. Right-sided can present with bleeding or iron deficiency anemia. This is true. Right-sided colorectal cancer are more common. This is false. Most common site is sigmoid and rectum. So rectosigmoid are the most common sites. Rectum is 37% overall and sigmoid is 21% overall. So 60% of cancers, colorectal cancers, are coming in this little area over here, rectosigmoid. And between these, rectum. So of course, left-sided no, right-sided are more common. So the third option should not be there. Answer is 1, 2, and 4. Colonoscopy, of course, is going to be the investigation of choice, goes without saying. Okay, so this is the last one. While managing esophageal perforations, which of the following favors non-operative management? Now, esophageal perforation is a little tricky topic, so I'll just tell you the thumb rules in esophageal perforation. Now, you know, esophagus is spread over 3 cavities. There is a part which is in the neck, there is a part in the thorax, there is a part in the abdomen. Why does esophagus perforate? It can perforate following trauma, endoscopy. It can perforate by itself if there is a tumor or there is something called as Borav syndrome. Now, in which ones do you operate always? The most important indication is where it is perforated here, intra-abdominal. If it perforates in the abdomen, person can get peritonitis. So abdominal perforation should always be operated. Or if it has perforated in Boerhaave syndrome. If there is Boerhaave syndrome, there is a very big rent over here and a lot of content spill into the mediastinum. High septic load. That is Boerhaave syndrome. Okay, so these two are the main, and of course the third is unstable patient. Any perforation where the person became unstable. So these are where you are going to always operate. So where are you going to manage non-operatively? Perforation of abdominal esophagus. Flexible endoscope, yes, it's a sterile perforation. You may observe him, not operate him. Small septic load, you will observe. In the mediastinum, you may or you may not. But abdominal esophagus, you are going to explore. So best answer is going to be 1, 2, 3. What I'm trying to say is, these kind of questions were very common sense based, where if you knew a little bit, you could get the answer. They were not very hi-fi, and that's how your preparation should be when you are studying surgery. Don't run behind hi-fi things, run behind basic things, but do them again and again. All the best, guys. Thank you. Now let's solve the last 2 remaining questions from this exam. Which of the following are seen in normal pressure hydrocephalus? As I've told you, these kind of questions, even if you know one option is the odd one out, it's very easy to solve. So is it hearing loss, gait disturbance, incontinence, cognitive decline? If you know, there is something called as Hakim's triad of normal pressure hydrocephalus, which contains gait disturbance, incontinence, and cognitive decline, not hearing loss. Okay, it is not hearing loss. Hearing loss is missing. So the best answer is going to be 2, 3, and 4. Okay, best answer is going to be 2, 3, and 4. And the last one, the best position to palpate minimal enlargement of spleen. Now understand, spleen should be becomes palpable only when it is enlarged at least 2.5 times. Otherwise, it may not be palpable even if you have splenomegaly. So very small degrees of splenomegaly are going to be appreciated on palpation. In which of these positions? The best answer here is going to be right lateral decubitus. So in right lateral decubitus, the spleen will fall forward and downward. So it becomes a lot easier to palpate a minimally enlarged spleen. If they ask you best technique of splenomegaly clinically, best technique, answer is going to be percussion. Okay, so percussion of spleen is more sensitive than palpation, and of course even better is going to be ultrasound, but ultrasound is not clinical, right? So these are the questions from the UPSC exam. I hope you are able to understand the kind of questions that are asked, and I gave you some tips and tricks on future when you are solving these kind of questions. Thank you very much and all the best.
Hi everybody, I am Dr. Rena Chawla, your faculty for Obs and Gynae, and in this session we'll be discussing the UPSC 2023 OBG MCQs. Okay, so the paper had a lot of basic questions, nothing was very difficult, and there was a lot of choose the multiple choice questions. Okay, so let's discuss the questions. We'll be discussing it very briefly. Okay, and where we need to spend some time, I'll be spending some time. The first question is the daily requirement of iron during the second half of pregnancy is, and the correct answer here is 6 milligram per day. So remember, in pregnancy, the iron requirement, okay, what you need to remember is the iron requirement is around 1000 milligram per day. Okay, and this boils down to maximum requirement in the second and the third trimester, which is around 4 to 6 milligram per day. Okay, some books says more than 6 milligram per day. Okay, and in the first trimester, the requirement is much less. It's around 2 milligram per day. Okay, so this is what the iron requirement is in pregnancy. The second question is carbohydrate metabolism in normal pregnancy shows. Okay, does it show fasting hypoglycemia? Does it show postprandial hypoglycemia? Is there increased sensitivity of insulin receptors in the mother, or is there decreased plasma glucagon levels? The correct answer is there is a mild or a slight fasting hypoglycemia seen in pregnancy. So when we talk about pregnancy, remember pregnancy is a diabetogenic state, okay, and there are certain changes in pregnancy which enable the fetus to receive more glucose, okay. It has been found that there is slight fasting hypoglycemia though, okay, and there is slight postprandial hyperglycemia. Also, the sensitivity of insulin receptors decreases, okay, and plasma glucagon levels increase, okay. So remember, the fasting, there is slight hypoglycemia, not hyperglycemia, okay. A typical case of iron deficiency anemia in pregnancy which will show which of the following. Okay, so there is a question of iron deficiency anemia, whether it's in pregnancy or otherwise also the findings would be the same. Okay, so would you find a hemoglobin less than 10 grams? Yes, because the definition of anemia in pregnancy is a hemoglobin less than 11 grams. So definitely a hemoglobin less than 10 grams will be there. PCV less than 30%? Yes, will be there. Okay, hematocrit, the hematocrit will be less. Will the MCHC be more than 30% of the MCHC would be reduced? So remember, the MCHC will be reduced. The MCV, the MCH and the MCHC all will be reduced. Okay, and on the peripheral blood smear, you will see microcytic hypochromic anemia. So 1, 2 and 4 are the correct options. Okay. Which of the following are the clinical features of molar pregnancy? So lots of questions like this were there. Okay, so it's like they had gone into basic things, but they asked a bit more detail. That's how the paper was. Okay, so history of amenorrhea and vaginal bleeding will be there in molar pregnancy. Yes, of course. So whenever there's amenorrhea and vaginal bleeding, you need to think of three things: either it's an abortion or an ectopic pregnancy, or it is a molar pregnancy. Okay, patient has excessive vomiting. Yes, again. Okay, so molar pregnancy, there are high levels of beta HCG. Okay, and this triggers the vomiting center. So molar pregnancy, multiple pregnancy, there is excessive vomiting. Is there a history of expulsion of grape-like vesicles? This is also true. So all the 3 points are true. Okay, these are more likely in complete mole. Okay, rather than a partial mole, but it's not mentioned which mole, they just mentioned molar pregnancy. Okay, which of the following are characteristics of true labor pain? So they've asked a question on true labor pain. Does the intensity and duration of contraction increase progressively? Yes. Okay, intensity increases, duration increases, and it becomes more frequent. Okay, is there progressive effacement and dilatation of the cervix? Yes. Okay, so there is cervical changes as the contractions, it's true labor, so the contractions will lead to cervical changes. Is there formation of a bag of four waters? Yes, again, because as the uterus contracts, what is happening is the amniotic cavity in which the baby is in. Okay, so this is the baby. What happens is the amniotic fluid over here starts pooling here below. Okay, and it helps in cervical dilatation. This is called the bag of four waters. Okay, and this is seen in whenever when there are true uterine contractions. Okay, so this is also true. Pain is confined to the lower abdomen and groin. So it's not confined to the lower abdomen and groin. It actually starts at the back and then it comes in front. Okay, so it's also associated with backache. So this would not be a very good option to mark. And you have to choose the best of three. So the best of three would be 1, 2 and 3 look to be the best correct answers. What are the parts of AMTSL, active management of third stage of labor? And this is a question which comes in every exam. It is so important. Okay, so AMTSL is basically prevention of postpartum hemorrhage. What does it include? It includes, first is administration of an oxytocic. Okay, and the best oxytocic is oxytocin 10 international units. Okay, and then also it includes delayed cord clamping and controlled cord traction. Okay, so these are the main components. So let's read the options. Injection oxytocin 10 units IM within 1 minute of delivery of baby. This is correct. Injection oxytocin at the birth of first twin pregnancy. So this is wrong. Okay. So in twin pregnancy, we do AMT cell after both the babies are born, not after delivery of one twin, because if we give the 10 units IM, the uterus will contract over the second baby, the cervix will close, and such vigorous contractions, the second twin's placenta will separate, leading to abruption. So this is wrong, this is correct, and this is correct. So the correct answer should be 1, 2, and 4. Which of the following are correct regarding acute mastitis? Now, what is acute mastitis? It is usually seen in the puerperium. It is basically infection of the breast, okay, and it is seen quite commonly. It is usually seen around the 2nd to 3rd week following delivery, okay. So let's read the option. It usually occurs in the first 2 to 4 weeks postpartum is correct. Microscopic examination shows leukocyte count more than 10 to the power 6 and bacterial count more than 10 to the power 3. Now this is also correct, okay. So because the normal, if you examine breast milk under the microscope, the normal leukocyte count should be less than 10 to the power 6 and the normal bacterial count should be less than 10 to the power 3. Anything more than this indicates that there is an infection in the breast milk. Okay, so this is also correct. Common organisms are bacteroids, E. coli and Klebsiella. Is this correct? No, the most common organisms are Staphylococcus aureus, group B, hemolytic Streptococcus. So Staphylococcus and Streptococcus are more the most common organisms. These are very rare to be found in mastitis, okay. The source of infection is the infant's throat and nose, and this is also correct. So this is where the bacteria harboring the infant's nose and throat comes, and because of improper latching or cracked nipples or some lesion on the breast, the infection settles in, especially if she's predisposed to infection, if she's anemic, if she has some immunodeficient state, okay, this would lead to mastitis. So the correct options here look like 1, 2 and 4. So 1, 2 and 4 are the correct options, okay. As per the classification of obstetric anal sphincter injury, a tear of more than 50% is of which degree? Okay, so this is an easy question. Okay, so we know a first degree tear is when only the skin or only the mucosa is involved. Okay, a second degree tear is when the skin plus the muscle plus the mucosa is involved, okay, like an episiotomy. Third degree tear is when the tear is extended till the external or internal anal sphincter. This you can divide as 3A, 3B and 3C. 3 is when less than 50% of the external anal sphincter has been involved. 3B is more than 50% of the external anal sphincter has been involved. And 3C is when the internal anal sphincter has been involved. And 4th degree tear is when the anal mucosa has also been torn. Okay, so here they've asked more than 50% of ES. This would be a 3B kind of tear. Okay. What are the causes of lactation failure after delivery? Okay, so lactation failure means that there is less breast milk or there is no breast milk being produced. Why does this happen? So what happens when there is lactogenesis? There is a signal going from the breast. So when the baby suckles at the breast, that signal goes to the brain, and that releases prolactin and oxytocin. Okay, prolactin causes production of milk and oxytocin causes letdown. The myoepithelial cells contract and breast milk is let down. Now, what can lead to lactation failure? Okay, so if the baby is not suckling, there's no message going to the brain. Okay, so infrequent suckling is one cause. Okay, depression or anxiety also cause lactation failure. Okay, prolactin inhibition, of course, if there's any drugs you're giving or there's any reason why prolactin not being secreted, for example, Sheehan syndrome, where there's pituitary apoplexy, all these cause lactation failure. Okay, so all three are the correct options. Both 1, 2 and 3, all of them cause lactation failure. Which of the following is the distinguishing feature to differentiate Gartner's cyst from cystocele? Okay, now what is Gartner's? First, let's discuss what is Gartner's cyst. Now, Gartner's cyst is basically a remnant. The Gartner's duct actually is a remnant of the Wolffian duct. That is the male duct, right? But after the male duct disappears when the female is developing in utero, what happens is some remnants get left behind, and one of the remnants is a Gartner's duct, and if that group becomes a cyst, it becomes what's called a Gartner's cyst. Now, Gartner's cyst is basically found or seen in the vagina. Okay, it is a vaginal cyst, typically occurring in the anterolateral part of the vagina, the patient will complain of a vaginal swelling or maybe discomfort, especially during intercourse. Okay, and when you examine her, you will find a soft, fluctuant, cystic swelling. Okay, this is how it appears. Okay, and how do you treat this? The best treatment is to excise it, especially if it is very troublesome. Okay, now it is very often confused with other masses, vaginal masses, and one is a cystocele. Now, a cystocele is basically, what is a cystocele? It is descent of the bladder through the anterior vaginal wall. Okay, so the location is pretty much similar. Both are in the anterior vaginal wall. A cystocele, because the bladder if it descends down, will descend through the anterior vaginal wall. A Gartner cyst also will be the anterior lateral vaginal wall. So how do you differentiate between the two? Now remember, cystocele will increase in size on the patient, the patient strains. When we ask her to cough or bed on you, the bulge will increase. So there's a marked cough impulse, not in Gartner's, but in a cystocele. Okay, so this is wrong. The margins are ill-defined. Now here in Gartner's, the margins are very well defined. It's a proper cyst. Okay, whereas in cystocele, the margins are ill-defined. So this is also wrong. There is no impulse on coughing on cystocele. We've just discussed this. When the woman coughs, a cystocele will become very, very obvious. And a Gartner's cyst is not reducible. And this is the correct answer. You can't reduce it. It's a cyst. It's a firm-looking, fluctuant cyst. It is not going to disappear if you push it back. Okay, whereas a cystocele, if you push it back, will go back inside, especially if it's a large cystocele. Okay, so this is the correct answer. So remember, cystocele, because it's a type of a prolapse, it will increase in size when she strains. It can be reduced. Okay, and it is ill-defined, but it's through the anterior vaginal wall. Whereas a Gartner cyst is a typical cyst. It's very, very well defined. Okay, surgical treatment by ventrosuspension of the uterus is used for which condition? Now, if you've never read this, this is something which is not commonly asked. Okay, but this is one of those questions which you can easily answer by exclusion or by just guesswork. Okay, what is ventrosuspension? You're suspending the uterus, right? And ventro means ventrally. That means towards the anterior abdominal wall. Dorsally is posterior, ventral is anterior, right? So why would you want to suspend the uterus to the anterior vaginal wall? Okay, let's see the options. So pelvic organ prolapse. So in pelvic organ prolapse, you want to correct the prolapse, especially if she's a young woman not wanting a hysterectomy. There are sling surgeries, yes. Okay, but they are different. Okay, so the sling surgeries are different from what we call as ventrosuspension. Many of the sling surgeries are to the common ones, in fact, are to the back of the posterior part, that is to the sacrum. Some anterior fixations are known, some anterior sling surgeries are known, but they're not very common and they're not called ventrosuspension. This is one option which you might get a little confused. Okay, but you have a very good option right next to it. Retroversion of the uterus. That means a retroverted uterus is a uterus. Like this is the bladder. Okay, this is the rectum. Okay, normally the uterus is anteverted and anteflex. This is how the uterus is. But sometimes in around 15% of women, you'll find a retroverted uterus. Sometimes there's an etiology. A very common etiology is if there is endometriosis, especially in the pouch of Douglas, it pulls the uterus back. But many times there is no known reason why there is retroverted uterus, and many times patients are comfortable, but sometimes they are symptomatic. That means they have backache, they have pelvic discomfort, they have dyspareunia because of the ulta, the opposite, the uterus going in the opposite direction. Okay, in such women you can consider ventrosuspension. So the round ligaments, okay, are brought anteriorly. They are brought to the anterior abdominal wall, and that lifts the uterus up and brings it and makes it anteverted. Okay, so this is where ventrosuspension is used. Rupture of uterus, it's not used. Okay, and vault prolapse. Vault prolapse means the uterus is removed. Vault prolapse is post-hysterectomy. The vault has prolapsed out. And what is the surgery of choice here? Here you do a sacrocolpopexy. That means you are suspending the colpos, the vagina, to the sacrum. Okay, so here they've asked suspension of the uterus. Of course, it can't be a vault prolapse because here the uterus is not even there. So just by exclusion, you can easily tell that this is retroversion of the uterus. Okay, next question. A 29-year-old woman with 3 months amenorrhea presents to the OPD with complaints of something coming out of her vagina. On examination, she is found to have single live pregnancy with second-degree uterine prolapse. Which one of the following is the best management plan for her? Okay, so for such a patient, so she's basically prolapse with pregnancy. Now, a woman who's having a uterovaginal prolapse and she conceives, the main difficulties in the first trimester or up till maybe early second trimester. Okay, so what you need to do is you need to reduce this prolapse. Okay, because once she enters the second trimester and then the third trimester, the growing baby in the uterus will pull the uterus up. Okay, and the prolapse will get self-corrected. But till that time, okay, that happens, okay, you need to keep the uterus reduced, and the best way to do that is by putting a pessary. Okay, so pessary is the treatment of choice for first and second trimester prolapses. Okay, so pessary is the treatment of choice. Reassurance to some extent will help, but it won't treat the problem. You will of course never do a cervical amputation. Cerclage is not required because women with prolapse, the problem is not cervical insufficiency. There is some deficiency in the supports of the uterus leading to the prolapse, and you can't correct that during pregnancy. You just have to treat it. You have to keep it reduced so it doesn't get it doesn't lead to an ulcer on the dependent part, or it doesn't get incarcerated. So it has to be kept in the reduced position. Okay, during delivery of HIV infected women, which the following are recommended? Okay, now this was a bit of a question which was a little confusing. Okay, because they've not given any guidelines, they've not said NACO or WHO or anything. Okay, but let's see this and let's see which makes more sense. Okay, the first is zidovudin is given at the onset of labor. Now this is very old. This is what was done 10, 15, 20 years back. Now the treatment has changed. Now what we give is we give lamivudine, and we used to give efavirenz, but now we give dolutegravir. Okay, so this is the new. This is NACO 2021 says that if the woman comes in pregnancy and is diagnosed to have HIV for the first time, or she comes in labor and she's undiagnosed but you diagnosed her to have HIV during labor, give tenofovir plus lamivudine plus dolutegravir. Okay, and this is what 2021 NACO says. So zidovudine is given if you have nothing else. Okay, so you won't say this is wrong, but it's neither right. So let's see the other options first. Okay, elective cesarean delivery reduces the risk of vertical transmission. Now, if this statement is just put out there, it is correct. Elective cesarean section does reduce the risk of vertical transmission. But is it recommended by the NACO? No. By the WHO? No. But by ACG and RCOG? Yes. Okay, because in situations where the benefits outweigh the risks, okay, where it is commercially feasible, it is better to do a cesarean section because it reduces the risk of vertical transmission. So if you just put this as a fact, this is correct. Okay, but if you ask, is it recommended in India? National recommendations? No. So again, a question mark. Is this right or wrong? Okay. Amniotomy and oxytocin augmentation should be done. So women in labor with HIV, it should not be done. So number 3 is definitely wrong. Why should it not be done? Why? Because it is any interventional procedure during labor should be preferably avoided. Doing an amniotomy is doing an artificial rupture of membranes. By doing that, you're exposing the fetus. The fetus is nicely in its amniotic sac. You don't want the fetus to be exposed to maternal fluids. By doing an ARM, you're increasing the risk of transmission to the fetus. So avoid, and this is what NACO says, avoid an ARM, okay? Avoid instrumental delivery, avoid episiotomy, avoid prolonged labor, avoid prolonged rupture of membranes. Okay, so this is definitely correct. Okay, sorry, this is definitely wrong. This should not be there. This we're very sure. ART should be given to all neonates. Okay, and this is correct. Okay, so we know that 4 is definitely correct. 3 is definitely wrong. 1 and 2 are plus minus. So let's go to the options and see what they say. Do we have any such option which says this? Okay, so we know that 3 should not be there. Okay, so 3, 3, 3, this eliminates our options. Okay, so the best option here is 1, 2 and 4. That means 1 and 2 they have taken as correct. Although by NACO 2021, this is not true. Okay, and if we go by recommendations, elective cesarean section is not done. It's done only for obstetric indication. But if you just put this statement out there, it is a correct statement. So this again, by eliminating choices, you get the answer. Okay. So this is what NACO, I just put this here because NACO 2021 says that if a pregnant or a breastfeeding woman comes with HIV, okay, the newer one is now tenofovir plus lamivudine plus dolutegravir, okay, that is the TLD regime, okay, and it is to be given once daily. It's a fixed dose combination of 300 milligram tenofovir, 300 milligram of lamivudine, and 50 milligram of dolutegravir, okay, including women exposed to single dose nevirapine in the past. And pregnant women should also be educated about the benefits and risks of DTG. Why have they written this? Because DTG in some studies has been found to be associated with increased incidence of neural tube defects. Okay, but now more studies say no, the risk is not there, but the woman has to be informed that there is a slight chance of neural tube defects as per some studies. Okay, so this is why this is written. Okay. Which of the following can be a complication in the baby due to post-maturity of pregnancy? So, easy question. Meconium aspiration definitely can be there because as the baby becomes post-mature, the chance of passing meconium in utero increases. The baby can aspirate the meconium. Hypoglycemia? Yes, because the post-term or post-mature infants, once they're out, they are more prone to developing sudden episodes of hypoglycemia. Intraventricular hemorrhage? No, this is a complication seen in pretermers. Even hypoglycemia is seen in pretermers also. But IVH is not seen in post-term pregnancy. Polycythemia is definitely seen in post-mature babies. So 1, 2 and 4 is the correct option. Okay. Intrahepatic cholestasis of pregnancy presents with which of the following features? Okay, so IHCP presents with pruritus after 28 weeks, especially in the palms and soles. Yes, this is the characteristic presentation. Bilirubin levels more than 5? No, typically bilirubin levels are low, less than 5 milligram percent. Typical, very typical of IHCP, not very high levels, not very obvious jaundice. Okay. Raised bile acids, yes, features subsided in 2 weeks postpartum, also correct. So here the correct options are 1, 3 and 4. Okay. Which of the following are correct regarding chaya? What is chaya? Chaya is something called ormeloxifene, which is a selective estrogen receptor modulator. What is its main use in our country is as a contraceptive, and the name of the contraceptive is chaya. It was earlier known as Saheli or centchroman. It's an indigenously invented drug by the CDRI Lucknow. Okay, so what should you know about this? It is a SERM which has potent anti-estrogenic and weak estrogenic property. It is very strong. It's an anti-estrogen. Okay, and it is a non-steroidal product. Okay, but it has very strong anti-estrogenic properties. It has a relatively good efficacy with a failure rate of 1 to 4 per 100 woman years. This is also true. How does it act? Now, the main doubt is here is what is the mechanism of action? Since it is an anti-estrogen, what does it do? It prevents implantation. It makes the endometrium very, very thin, and hence the zygote can't get implanted. And this is the mechanism of action. Okay, so the correct option here is 1, 2 and 4. 3 is wrong. It doesn't work by inhibiting ovulation. What else do you know? It's available as 30 milligram tablet. For the first 3 months, you give it twice weekly, and then you give it once a week till whenever. Okay, so this is about centchroman. Which of the following is a prerequisite for endometrial ablation? What is endometrial ablation? You're basically destroying the endometrium. You can do it by resecting it off completely or by doing a thermal ablation, but it is not a procedure which is not really done these days. Okay. Still, if you want to do it, why do you want to do it in women who have menorrhagia, who have heavy menstrual bleeding in the absence of any structural problem? So if you have a fibroid sitting here, there's no point doing this. Okay, the cause is the fibroid. Okay, so a fibroid is a condition where you won't want to do it. You also won't want to do it if a woman wants to conceive later on, because if you're destroying the endometrium permanently, how would she conceive? So this is also not a prerequisite. Okay. And in large size uteruses, again, will not do this. You will do it only in women who wants to preserve a uterus. She says, doctor, I don't want a hysterectomy. Give me a better option. Then in these women, you can consider a endometrial ablation. Which of the following day of menstrual cycle is best for endometrial sampling to diagnose ovulation? Okay. So when we talk about ovulation, there are different tests of ovulation. One of them is endometrial sampling. Okay, and this sampling is done in the secretory or post ovulatory phase. So secretory phase, especially after day 21. Okay, why? Because this is the time when progesterone is at its peak, so you will have significant endometrial findings. And if there's a disparity between the endometrial finding and the day of her cycle, you can find out whether she is ovulating or not. For example, at day 21, you expect a secretory endometrium. But if you find this proliferative or ovulatory, you know there's a discrepancy. Okay, and then you know whether she's ovulating or not. Okay. A 27-year-old female married for 3 years, regularly cohabitating with her husband, presents to the gynae OPD with complaints of inability to conceive for 2 years. So she has infertility. During clinical evaluation, an HSG was done. A hysterosalpingography was done, which revealed irregular outline of the uterine cavity. So the uterine cavity is not clear, and rigid fallopian tubes with nodulations. You have rigid tubes with nodulations, okay, on the HSG. So what do you think this is? This is very classically a picture of genital tuberculosis. So genital tuberculosis causes Asherman syndrome, okay, which is also following DNCs can also happen. What is Asherman's? This intrauterine adhesions. How will that appear on the HSG? There will be an irregular outline of the cavity. And the tubes, so typically on HSG, the tubes appear as rigid, what is called as lead pipe appearance of the tubes, because the genital tuberculosis mainly affects the tubes. It causes salpingitis. And on an HSG, it appears as lead pipe. Also, the other features also tobacco pouch appearance, Maltese cross appearance. Okay, these are all names given to the appearance of the tubes in genital tuberculosis. Okay. Prophylactic oophorectomy is recommended in high-risk women with which of the following? So they've mentioned high-risk women with what? So carrying BRCA1 or BRCA2 gene, yes, you'll definitely do a prophylactic oophorectomy. You'll remove the ovaries because she's high risk, plus she's having BRCA1 and BRCA2. Okay, and otherwise also if she had BRCA1, BRCA2, you will remove because the risk of breast cancer and ovarian cancer are very, very high. Family history of breast, colon, ovarian cancer. So they've mentioned high-risk women with a family history of breast, colon, ovarian cancer. You would consider removing the ovaries, especially after 35 or after she is done with her childbearing function. Okay, if it was only family history, then probably would kept them on screening. But they mentioned she is high risk with a family history of breast, colon, ovarian cancer. This is again a little plus minus, but I would go for removing the ovaries. Okay, especially if her childbearing function is complete. Patients having tubo-ovarian abscess. Now, this is a very weird indication to put here, because prophylactic oophorectomy, the term itself suggests that you're removing the normal-looking ovaries. A tubo-ovarian abscess can be managed medically with antibiotics. It can be managed by drainage. You don't have to remove the ovaries. Okay, so it doesn't look like a proper option. So here I would go with 1 and 2 only, not 3. Why not 3? Because an abscess does not necessarily mean that you remove it, and that's number 1. Number 2, oophorectomy, the word prophylactic oophorectomy is done for normal looking ovaries, not a ovarian abscess. Okay. Which of the following are examples of LARC? LARC क्या होता है? Long acting reversible contraception. ठीक है? तो लार्क में क्या क्या आता है? लार्क में रिमेंबर 3 चीजें आते हैं. फर्स्ट इज इंजेक्टेबल contraceptives like Antara, that is depometroxyprogesterone acetate. Second thing are implants, okay, like Implanon, and third is intrauterine devices. Okay, so you can remember it by the 3 I's. And these are all long acting, yes, and they are reversible. When you stop the use, fertility gradually comes back to normal. So which of the following is an example? So copper T288 definitely is. Implant definitely is. LNG IUS definitely is. Okay, so all 3, 1, 2 and 3 are all examples of long acting reversible contraception. How many times in a year does withdrawal bleeding occur in extended continuous regime of COC? Now, what is this extended continuous regime? So it's available by the name seasonal. Okay, what does it have? So normally when we have a regular combined oral contraceptive pills are 21-day tablets. You give for 21 days and give a 7-day break. 3 weeks on, 1 week off. Okay, seasonal has 84 days of tablets. Okay, so 84 means 12 weeks you're giving it. Okay, and then you're giving a 1 week gap. Okay, so you're giving it 12 weeks, giving a 1 week gap, then giving for 12 weeks, giving a 1 week gap. Okay, so the woman will bleed for how many times during a year? That's what they're asking. So if you're giving it for 12 weeks, that means 3 months, and then giving a 1 week gap, then 3 months giving a 1 week gap. So she will bleed in 12 months. How many times will she bleed? She'll bleed 4 times in 12 months. Okay, so this is seasonal extended continuous regime of combined OCP. Bilateral total salpingectomy. What is salpingectomy? Salpingectomy is removing these tubes. Okay, so you're removing the tubes. Okay, what will this do? This procedure reduce the risk of what? Okay, now if you're removing the tubes, the correct answer here is it will reduce the risk of epithelial ovarian cancer. Okay, why? Because one etiology of, this is the ovary, one etiology of ovarian cancer is that toxic material from below, from the uterus, from the cervix, from the vagina, from outside extraneously can ascend upward, go in the tube and harm the ovary. But if you're removing the tube, okay, there's no way something from the outside can reach the ovary, and hence it is known to reduce the risk of epithelial ovarian cancer. Tongue bite occurs in eclampsia. This is very simple. Okay, so in eclampsia, we know first of all, what is eclampsia? It is preeclampsia with seizures. So you have a premonitory phase where the woman has an aura feeling, the imminent symptoms are there. She has headache, blurring of vision, and then she will have a seizure. So that's the premonitory phase, where it's like the phase of aura where she knows that she's going to have a seizure. Then you have the tonic phase, which is a spastic. Okay, the tonic phase is the spastic phase where the whole body goes into spasm. Okay, the eyeballs become fixed. Her hands are clenched. Okay, so that's the tonic phase. Then comes the clonic phase. Clonic phase is when she has the seizure. Okay, where she has the flexion extension of the hands. So the clonic phase, there is the voluntary muscles undergo contraction and relaxation, and this is where the biting of the tongue happens. So in the clonic stage, so tonic stage lasts for around 30 seconds. The clonic stage lasts for 1 to 4 minutes. Okay, and then comes the post-ictal stage when she's in a state of confusion and drowsiness and she's not aware of what's happening. That is the post-ictal phase. So you have premonitory, tonic, clonic is when the actual seizures happen, when the tongue bite will happen, and then the post-ictal phase. Indication for removal of intrauterine devices includes which of the following? Okay, so if the device perforates the uterus, you will remove it. Okay, if she conceives pregnancy with IUD in situ, and you will remove the intrauterine device. Otherwise, the risk of complications increases. 1 year after menopause, yes. So after she reaches menopause, 1 year after that, we remove the intrauterine device. Persistent migraine. So migraine is not an indication for removal of the device. Remember, combined OC pills are not given women who have a migraine, but IUD has no relation with migraine. So 1, 2 and 3 here are the best options for this question. Which of the following are the absolute contraindications for the use of combined oral contraceptive pill? Okay, severe hypertension. Yes, severe hypertension, we do not give the combined OC pill. Pregnancy, of course, if she's conceived, why would you give the pill? Diabetes with, or if you have a doubt of pregnancy, you will first exclude it. Diabetes with retinopathy, again, you will not give the combined OC pill. Gallbladder disease, remember, is not an absolute contraindication. It is definitely a contraindication, but it's more of a relative contraindication, not an absolute contraindication. So the best options here would be 1, 2, and 3. Okay, for this question. A 27-year-old recently married woman comes to family planning clinic requesting for long-term reversible contraception. So same question has come in 2 forms. She's asking for a LARC. I know the LARC are the 3 eyes. Okay, so combined OC pill is not a LARC. So LARC basically means where the frequency of use is more than 1 month. That means 1 month se zyada you're giving it. She's not having to take something every day or every week. That's why a COC she has to take every day is out. Okay, diaphragm she has to use with every act of intercourse. No, it's out. Next pronoun is what? It is the implant. So implant is an example of a LARC. Chaya is again not a LARC because Chaya she has to take in the beginning twice a week and then once a week. So none of these fit the criteria of taking it more than the frequency of more than a month. Okay, which of the following is an indication for cold knife conization. So what is a conization? So this is the cervix. Okay, this is the external os, this is the internal os. Okay, and a conization is when you are removing a cone of tissue like this. Cold knife means what? Cold knife means using a simple scalpel. Okay, now when do we do a conization? Remember, if you have CIN 2 or 3 diagnosed on colposcopy biopsy, what do? We do a large loop excision of the transformation zone, what is also called as loop excisional procedure, right? So for CIN 2-3, this is the treatment of choice, but this is basically excising the transformation zone, and that would involving taking out this amount of tissue. Okay, so only this much tissue is excised in a LEEP or a LLETZ. Cone, you can see more tissue is coming out. So when will you want to do a cone biopsy? A cone biopsy is preferred if there is inconsistent finding of colpocytology and rectal biopsy. For example, if the cytology, that is the pap smear, showed HSIL, okay, but the the biopsy, colposcopy biopsy is showing only CIN1. With HSIL, you will expect a higher grade lesion, or opposite also. The cytology shows LSIL, but the biopsy shows CIN3. Okay, that means there is a disparity between the pap smear and the biopsy. Then a cone is better than a LETZ. That means you want to remove more tissue. You don't want to remain in doubt. You want to remove more tissue. Or if when you're doing an endocervical curettage, ECC, that means you're taking, whenever we do a colposcopy, we also take sample from the endocervix. And if this shows positive for pre-malignant or malignant cells, a cone biopsy is better. Or if there is on biopsy, there is micro-invasive lesion on the biopsy. Okay, that means stage 1A1. Okay, then also a cone biopsy. If she's a young woman, a cone biopsy is an option. Okay, so here in these inconsistent findings, you will definitely take a cone biopsy. Negative mein nahi loge, you will take in positive endocervical curettage, and you will take in early stages, you might want to do a cone biopsy. Okay, Nabothian follicle is a normal finding. It is nothing worrying. It is not indicative of taking a cone biopsy. Which of the following statements are correct regarding female sterilization? Okay, so correct statements we have to find. It can be done 24 to 48 hours following delivery. Yes, it can. It should be done after 24 hours within 7 days if you're doing postpartum ligation. Ideal time for interval ligation is the luteal phase preceding menstruation. No, this is wrong. Okay, it is the proliferative phase. That means immediately after her period, post-menstrual is when we do this procedure. It can be combined with MTP. Yes, it can be combined with MTP. It is a preventive measure against serous ovarian cancer. We just read this. Yes, it is a preventive measure. Okay, so either doing a salpingectomy or blocking the tube itself, just doing a tubal ligation is a protective measure for ovarian cancer. So 1, 3 and 4 are the correct options. Okay. The most popular technique of tubal ligation. Easy question. What the government of India recommends is the Pomeroy's method. Okay, so Pomeroy's method is the best way, the most, and is the recommended way for tubal ligation. To reduce the risk of endural tube defects in the baby, the following are recommended. Folate supplements 1 month before conception to 3 months after. Folate from confirmation pregnancy till the end of first trimester. Zinc supplements. So we do know we give folate supplements, right? And ideally we should start 3 months before conception, but at least 1 month before should be started and continued for 3 months thereafter. So this is the correct option. Okay. So the next question is, secondary arrest of dilatation during the process of labor may be due to which of the following factors? Poor uterine contractions. Is it because of cessation of cervical dilatation despite strong uterine contractions? Okay, or is it disproportionate malpresentation? So the best answer here would be 1, that is uterine inertia, and 3, that is disproportionate malpresentation or CPD or some problem in the passage in passenger. Point number 2 doesn't really point towards the reason, it's just a statement. So here the best option would be 1 and 3 only. The next question is, you all know the first stage of labor is from the onset of true labor pain, okay, till the full dilatation of the cervix. Stage 2 is from full dilatation of the cervix till delivery of the fetus. Stage 3 is delivery of the fetus till delivery of the placenta. And stage 4 is 1 hour of observation postpartum. The last question is, VVF is classified as complicated if it has which of the following features? Now remember, these are the differentiating features. A complicated VVF is more than 3 centimeter. If it is mid-vaginal and if it's in the trigonal area, remember these are not good factors, they are complicated. If she has a history of a pelvic malignancy, if prior radiation is present, that becomes a complicated fistula, and if the vaginal length is shortened. So all these are bad or complicated VVFs, and here, so the best answer here would be 1 is a complicated, okay, this is complicated and this is complicated. So 1, 3 and 4 is the best answer to this question.
Hello everyone, welcome to Pediatrics by Dr. Anand. A beautiful evening to all the amazing people. My name is Dr. Anand. We're going to talk about UPSC Recall Questions 2023. Before starting any segment, we always have a beautiful quote, and the beautiful quote for today will be, if plan A does not work, if the plan A does not work, the alphabet has 25 more letters. Very beautiful. If the plan A doesn't work, the alphabet has 25 more letters. If the plan A doesn't work, you can use plan B, plan C, plan D, plan E. Please remember, change the plan, but not the goal. There are beautiful people who change the goal only. Don't change the goal, please. Change the plan, not the goal. Okay, goal has to be amazing. You have to buy a BMW, you have to buy a Leela apartment, but you can change the plan if it doesn't work. Okay, use your brains a little bit. Question number 1, clinical features of an infant with fetal growth retardation at birth, including which of the following? Physical features, give an old man look. Is this line true or false? This line is very well true. It's very important. They give a features of old man look, like typical IUGR babies, intrauterine growth restriction. They are similar to the severe acute malnutrition baby. My HOD used to say the SAM baby basically, has a old man faces. Same also IUGR baby also have a old man faces. So this part is true. Next we have babies alert, reflexes are normal. There is presence of weight deficit. Thick fat accumulates around the shoulder of the baby. So thick fat accumulates around the shoulder of the baby. No, that's not there is no connection of having thick fat accumulated in an IUGR baby. It's not like that. They do have a old man faces. They are very well alert and their reflexes are pretty fine, and there is a presence of weight deficit. That is why I'm saying intrauterine growth restriction. Intrauterine, when you were pregnant, your baby's growth was restricted. So naturally the baby you are expecting 2.5 to 4 kg, that you won't have that baby. You will have a 2 kg, 1.7 kg baby, 1.5 kg baby. So yes, there is a presence of weight deficit. Babies otherwise fine, alert, reflexes are normal, and the baby will give you a old man faces. Old man faces. So that's why option number A, like the 1, 2 and 3 are pretty well correct. Okay, next important question. A child develops stranger anxiety at what age of life? Very common milestones question. Milestones is a bread and butter for pediatrician, and they always ask question for milestones. So stranger anxiety, I'm very anxious to go to meet the strangers. If you have a baby on your lap, if you give to someone else, he will be he'll be anxious to meeting on stranger. Maybe a positive anxiety, maybe a negative anxiety, but he will show to a stranger anxiety comes by 6 to 7 months. OP guy beautifully have written 6 to 7 months. Okay. Consider the following statements with respect to developmental milestones at 9 months of age. Another milestone question for UPSC. So 9 months of age, what comes? That's the question. At this age, child develops immature pincer grasp. If I'm holding something with the thumb and index finger, that is known as immature pincer grasp, which comes by 9 months. But please remember, holding a pen, it's not the immature pincer grasp, a small pebble. और in Hindi we say मतलब टॉफी पकड़ लेता है, अंगूर पकड़ लेता है बच्चा आपका. Can your baby hold a grape? A simple thing. So he will hold a grape like this only, like this, like with the thumb and index finger. That is very this one is known as mature pencil grasp. Mature pencil grasp actually comes by 12 months. But if I'm holding something with thumb and assisted fingers, that is known as immature pencil grasp, that comes by 9 months. I'll repeat again. This one, thumb and index, that is a proper holding something with thumb and index finger is a mature pincer grasp, comes by 9 months. Here the question is immature pincer grasp. If I'm holding something with thumb, index finger and assisted fingers, that is known as immature pincer grasp, comes by 9 months. So this part is true. At this age, child can say bisyllables. Yes, a baby can say bye by 9 months, and a baby can say bisyllables like mama, baba, papa by 9 months. So this also is very well true. So the best answer for this question is 1, 2 and 3 all are correct. That happens by 9 months of life. Just remember, immature pincer grasp comes by 9 months and mature pincer grasp comes by 12 months. What are the upper age limit by which a child should start walking alone and be able to speak single words? Another milestone question. So many questions on milestones. So if you have done milestones, your 3-4 questions are automatically correct. What is the upper age limit? Upper age limit for walking alone. So baby can walk alone by 15 months and a baby can run by 18 months. A baby can walk alone by 15 months and baby can run by 18 months. So walk alone. So walk alone 15 months and 15 months. So option 2 or 3 are correct, right? 15 months, 15 months. Because a baby will run by 18 months. So walk alone to 15. This B and C sounds good. But we have another option. A baby is able to speak single words. When can a baby speak single words? According to OP Guide 9th edition, remember it's written over here, 1 to 2 word with meaning, single words, 1 to 2 word with meaning comes by 12 months. 1 to 2 word with meaning comes by 12 months. So the best answer for this question will be option number 3, like 15. This is the maximum upper age limit. See, you have to choose the closest best option. Okay, the perfect answer would be walking alone by 15 months and able to speak single words by 12 months, right? But we have to see the closest best option, and the closest best option over here is very important, 15 months and 15 months. So that is why this is the best answer. Okay dear, next question. A child presents to the emergency following ingestion of around 20 ml of kerosene oil about 40 minutes back. The child appears stable. Which one of the following measures should be done for the management of the baby? For any corrosive intakes, gastric lavage is totally contraindicated, that you already know. Intravenous steroids, why do you want to give a steroid in this case? There is no connection of giving steroids in such poisonings. Okay, you have to wait and watch, you have to monitor the symptoms of the baby. If the baby is hemodynamically stable for 24 to 48 hours, and discharge the patient. You must always admit the child. Okay, in general I'm telling you, kerosene oil ingestion, admit the child, take a put a MLC, take a MLC number, medical legal case number should be there, it should be properly registered. For 24 to 48 hours you admit the child and then you discharge the child. That's how the proper protocol works. In this case, I would like to do a radiography for this patient, because for kerosene oil he has taken as at a follow-up he might develop a stricture, might develop kind of some constriction, some erosion in the esophagus or stomach, something like that. So radiography sounds a good option in this case. Okay, the very next question, very important, we have the event related to vaccination which can be contraindicated for the next vaccination of the similar identical type is. So basically the event related to vaccination which can be contraindicated for the next vaccination. What will happen today, that like if something happens, it is contraindicated to give the next vaccine again. So very important, DPT, that is very important. DPT is very notorious. Okay, DPT and specifically pertussis is very notorious. Why? Because usually the patient throws seizures. DPT is the only vaccine, and P basically pertussis. It's very common to have seizures because of pertussis in a baby, and if someone got a seizure after DPT vaccine, you have to to totally not give the vaccine in the next follow-up. That is the main thing. So the best answer for this question will be encephalopathy following a DPT vaccine. If the baby got a DPT vaccine, he got an encephalopathy or kind of a seizures like that. So in the next DPT follow-up dose, you will not give the DPT follow-up dose. That's what it's contraindicated now if the baby has developed seizures or encephalopathy. That's the best answer. Which one of the following can be used for developmental screening for use in community to identify children 0 to 6 years with developmental delay? Now this is a very smart question. It can definitely come in NEET and next exams pattern for sure, because this is a very new question. 0 to 6 year of life, simple question, simple answer. 0 to 6 year of life, which is the best developmental screening tool. Okay, these all are the answer. Denver development, ages and stages, Fartak's Baroda, Trivandrum developmental screening chart. So please remember 0 to 6 year of life. So remember one thing, this ages and stages questionnaire, it's used for 1 month to 5.5 years. Ages and stages used for 1 month to 5.5-year-old baby. If I want to judge that baby, the developmental assessment, I will be using the ages and stages questionnaire. Number 1. This is a very important question because this little hi-fi question, so you must know. As far as Fartak's Baroda is concerned, you do it up to 30 months of life. 30 means around 2.5 years. So around, if the baby is around till 2.5 years of life, Fartak Baroda is a good choice to do a developmental screening. Ages and stages questionnaire is done till 5 years of life. So 2.5 years, then 5 years. Till 2.5 years, Fartak's Baroda. Till 5 years, if you want to judge the baby, ages and stages questionnaire. But my question is 0 to 6 year of life. Till 6 year of life, what developmental screening tool will be very nice in this case? So remember, 0 to 6 year of life, we have this TDSC. TDSC is Trivandrum Developmental Screening Chart. Trivandrum Developmental Screening Chart. So that will be helpful in 0 to 6 year of life. That you should know. Okay. So remember, what did we understand? So very important. Fartak and Baroda test is done till 2.5 year of life. I can use this Fartak and Baroda for the developmental screening. Very importantly, till 3 year of life, there is a test known as CAT. CAT is Clinical Adaptive Test. Clinical Adaptive Test is a test where till 3.5 year of life, it can be used for the developmental. Till 3 year of life, it can be used for the developmental assessment of the baby. Okay. Whereas just now I told you very importantly, this ages and stages questionnaire, this is used till 5.5 years of life. And last but not the least, this Trivandrum Wala test that is used for the developmental assessment can be used till 6 year of life. So Trivandrum Wala is the best answer. Very beautiful quote. It says, learn from the past, live in the present, and plan for the future. That's very beautiful actually. Learn from the past, live in the present, plan for the future. You just reciprocate some words, it's difficult. If you say learn from the future, sounds wrong. If you say plan the past, sounds wrong. Learn from the past, live in the present, and plan for the future. Very nice. According to the WHO clinical criteria, which of the following clinical signs are indicative of severe pneumonia or very severe disease in children 2 months to 5 years? So we all know what is pneumonia and what is severe pneumonia. If the baby has if the baby has fast breathing with or without chest indrawing, that is known as pneumonia. If the baby has fast breathing with or without chest indrawing, is known as pneumonia. If there are danger signs, that is known as very severe pneumonia. What are the danger signs? Stridor in a calm child is a danger sign. Convulsion is a danger sign. Not having feeding, shock-like state, all these are danger signs. And fast breathing with or without chest indrawing is pneumonia. So the best answer for this question will be everything is correct. Everything is correct. Okay. One student was saying me that only stridor was written. Stridor in a calm child was not written. If the stridor in a calm child, like this, only stridor is written, then definitely this is a wrong option and 1, 2, 3 are correct. These all are the recall question. Okay. I did not make the question paper. Someone had sent the recall question. So you accordingly plan up, understand the concept. A full-term baby born with a birth weight of 2 kg comes for well baby visit at 2 months of life. Which of the following nutritional supplements would you advise? Simple question. A 2 kg baby. Usually if the baby is less than 2.5 kg, no, actually extra we add iron and calcium. Actually, if I tell you simple words, if the baby is more than 2.5 kg, so you give vitamin D till 1 year of life. Every newborn baby, you, me, we all were born more than 2.5 kg, means normal baby. Every day you give vitamin D till 1 year of life, and vitamin D you give till 1 year of life. Till 3 months of age, wrong answer. 3 months of age, wrong answer. Okay, this part is done. And yeah, so the best answer for this question, very important, will be vitamin D. You give vitamin D orally, 200 IU per day up to 1 year of age. Like, see, I tell you something very clearly. This is the recall question. Okay, if the baby is more than 2.5 kg, means normal baby, you give vitamin D till 1 year of life. Okay, if the baby is less than 2.5 kg, vitamin D for sure you will give. At the same time, you will give iron and calcium. You add iron and calcium. When the baby was 2 to 6 weeks of life, means around 2 months of age, so you add iron and calcium in this case. So the best answer for this question will be iron orally 2 mg per kg till 1 year of life. So you usually add iron for the low birth weight baby because their demand is more. So you add iron and calcium is given in OPK. Okay, that you should know. So the best answer will be D. Okay, but again, it's a recall question. If the child was more than 2.5 kg, the child was a healthy baby. Healthy baby, you don't give iron, calcium, nothing. Healthy baby, you give vitamin D only. Are you understanding? More healthy, matlab normal baby. This baby is less than 2.5 kg. Vitamin D for sure you will give, but at the same time you will give iron also and you will give calcium also. So the best answer for this question will be actually not option number B, it will be option number D. Okay. Which of the following are common problems in baby with IUGR delivered at term gestation? If the baby is having intrauterine growth is restricted, frankly speaking, anything can happen to the baby. The baby can have hypoglycemia, and if the baby has hypoglycemia and hypocalcemia, they occurs together. Usually, if you're expecting a low RBS in a baby, RBS means random blood sugar, you will be expecting low calcium also. So they both run together. And at the same time, like, yeah, so that's what these two, if you think, they are usually more prone for IUGR babies have more issues with this. So that's why 2 and 3 are correct. Okay. Which one of the following statement is correct regarding the normal newborn's growth? Okay, normal newborn growth. Okay, if I choose this one, weight loss may be 12 to 15% of birth weight in the initial 2 weeks of life. This is a wrong statement. Just remember, we all know a term baby loses 8 to 10% of body fat. A term baby loses 8 to 10% of body weight or body fat by the first week of life. And by the 7th to 10th day, it regains the weight. Beginning 1 week of life, there will be a dip in the weight because of the extracellular renal losses and everything. And after 8th day, 9th day, 10th day onwards, you will have a weight gain. The baby will start regaining the weight. So birth weight is regained by 7 to 10 days of age, that you should know. For developmental assessment of a baby, grasp is best assessed by offering the child by doing what? Again, a milestone question. 5 questions only from milestones. For developmental assessment of a baby, grasp is best assessed by offering the child what? The grasp the first you have, very importantly, a palmar grasp. Then you have a radial grasp. Okay. Like if I'm using if I'm holding something with this, it's a radial grasp. If I'm holding something with using the full palm, that's a palmar grasp. The whole story starts with using a red cube. I can only hold something if you give me a cube. Pellets and all that, this is done for pincer grasp. Just now I told you, can your baby hold a grape? So holding a pebble, holding a stone, holding a kancha, holding a grape, all these are small pellets. So used for immature or mature pincer grasp. So red cube, proper cube is the best answer because I have to hold. Proper grasp is done with a cube. Oh, this OPK has written grasp is best assessed by offering a red cube to the child. So red cube, proper cube, that's what. Last question. A baby is delivered at 34 weeks of gestation, found to be apneic at birth. After performing the initial steps of resuscitation, the baby is still apneic. The next step should be what? Simple, nice question. Okay, baby was delivered, he found apneic. Means if the baby means what is apnea? Well, basic simple words, baby was not breathing or baby was not crying. If the baby was not breathing or crying, you do initial steps. You do the initial steps. And the initial steps are what? Initial steps are PSSR. We position the baby. I have to make the baby cry. No, the baby has not cried, right? We need to make the baby cry. How will you make the baby cry? By positioning the baby and then suctioning the baby. Position as in putting the baby in little little extension of the neck so that I can suction the baby properly. Then I will stimulate the baby like by rubbing the back, and I will reposition the baby, because rubbing the back I need to put the baby in the left lateral, then I will put the baby normal in supine, reposition. So because I have to make the baby cry, so this I have already done. After performing this initial steps, baby still not crying, still apering. Now what will you do? Now, if proper protocol wise, you check the heart rate, of the baby. Okay, if I say chest compressions, no, you don't directly start off chest compression, it's too much. If the heart rate is usually less than 60, then you do chest compression plus bag and mask ventilation. Okay, so only saying chest compression has no proper linking of the answer. Tactile stimulation, no, I have already done this stimulation. Tactile I have already done, so why will I do it again? Baby not breathing, no, I have to do something. So in this case, I will start the bag and mask ventilation, positive pressure ventilation. And positive pressure ventilation is usually start with the basic one as in with 21% oxygen. 21% oxygen as in, like, I'm not connecting the extra tube, the oxygen, the chamber, like there's an inlet where I will put the oxygen pipe, and then I will give a proper 100% oxygen to the baby through the bag and mask. But I will start off with basic, and basic is you do give a positive pressure ventilation using a 21% oxygen, but again the closest best answer being 30%. You have to use your brains. Okay, it's I always say in my classes, the questions will not come copy paste. 21%, matlab 21% only should come. No, closest best answer. No, use your brains. That's it. Okay, so the best answer will be start bag and mask. And for starting bag and mask, it's just a simple bag and mask without attaching the oxygen pipe behind the bag and mask. Okay, if you're attaching the oxygen pipe, means you're giving 100% of oxygen. In the beginning, you won't do that. Okay, if the baby was not crying, not breathing again, then you would have connected the tube. That's why. Okay, done. So B is the best answer. A child requires detailed developmental evaluation if the DQ is less than what? Very good question. Normally you and me, we have DQ of 100. Okay, you and me, we have DQ of 100, developmental quotient of 100. So a child needs to be having a developmental evaluation if the DQ is less than 70. Okay, for IQ also it is same, intelligent quotient also it is same, and DQ also is the same. Means if the child has DQ or IQ less than 70 or touching 70, below 70, then definitely what you called you need some developmental evaluation, that why the baby's DQ is not normal. Normal DQ is 100. Why this baby's DQ is, something is wrong with this baby, no? So I need to have a developmental evaluation. That's the whole thing. That's it. True about salmon patch. So we have done in our classes multiple times. Salmon patch, number one, it can be present at the nape of the neck. So nape of the neck is the right answer. It is common in children. Yes, it's one of the condition in the newborn which looks abnormal but is normal. It is a hemangioma. Yeah, these are very small capillary hemangiomas. These small dots are there. No, these can you see that? Let me zoom it for you. Oh, so nice. I can zoom well. So these all are dot wala. These all are capillary hemangiomas, and it's normal. Nothing to be done. Needs surgical excision? No, it's not right. So the best answer is A plus B plus C is correct. Which one of the following is true about vitamin D deficiency in children? Vitamin D deficiency in children, yes, craniotapes you do get if you press a baby's skull. So you will have a ping pong ball appearance. There will be dip in the skull. If this is the skull, I will press your skull like that softly. There will be a dip. There will be a dip like that, like a ping pong ball appearance. So that happens. That is known as craniotapes. Happens in a case of rickets. Because of extramedullary hematopoiesis, there will be a bossing of the frontal and parietal bones. Why there is bossing? Because of the extramedullary hematopoiesis. My body is not able to make vitamin D and iron. So apart from my bone marrow, the extramedullary, main medullary hematopoiesis is the bone marrow, but now extramedullary sites will activate for the hematopoiesis, and the sites are frontal bone, sternum, and other things like that. And the patient will have kind of floppiness and muscle hypotonia. So A and B and C are correct. Shrinkage of the epiphysis at the lower end of radius, no. Shrinkage, nothing happens. There is cupping, fraying, and splaying, as we all done. So there will be a cupping and fraying and splaying appearance, if you know. So that happens in a case of so that's why the best answer will be A1 plus 2 plus C3 is correct. Hello everyone, welcome to Pediatrics by Dr. Anand. So two more questions were there for the UPSC exam. So I thought of sharing it with you. So the question is, typical absence seizures are characterized by what? Typical absence seizures are characterized by what? Abrupt 3 Hz spike and slow wave discharge on EEG, post-ictal confusion in children, multifocal structural abnormalities of brain, and less responsive to anticonvulsant as compared to the atypical absence seizures. So what is true? Typical absence seizures are characterized by what? If I talk about option number B, post-ictal confusion in children, post-ictal confusion in children is not present in the case of typical absence seizures. The other type of seizures like GTCS, generalized tonic-clonic seizure, they all have kind of a confusion. See, post-ictal means after the episode, after the seizure. Post-ictal, pre-ictal means before the episode of seizure. Okay, that's what. So post-ictal, after the episode of seizure, in a case of absence seizures, there is no confusion. The child is normal, he's just talking like this after that. Whereas in GTC as another condition, there is confusion. The best answer for this question will be option number A, abrupt 3 Hz spike and slow wave discharges on EEG. That's the best answer for typical absence seizures that you should know. Option number D says that they are less responsive to anticonvulsant as compared to atypical absence seizure. No, it's not like that. They are pretty well responsive to anticonvulsant. So this question, the best answer is option number A. And one more question we had, if on amniocentesis the alpha fetoprotein is found to be elevated in the amniotic fluid, which defect or disorders is fetus most likely to harbor? So we have cardiac septal defects, neural tube defects, Duchenne muscular dystrophy, and galactosemias. So remember one thing, the sensitive and specific marker, you know that, right? The specific marker for what we call the neural tube defect is acetylcholinesterase, and the sensitive marker is alpha fetoprotein. So in a case of neural tube defects, the marker which are important are the acetylcholinesterase and alpha fetoprotein. So alpha fetoprotein is one of the sensitive marker which elevates in a case of neural tube defect. So that is why the best answer for this question is that will be neural tube defect. That's what, because it's connected to alpha fetoprotein. Okay, that's what you should know. So that's it. These are the important 2 extra questions I thought of sharing for for UPSC Recall 2023. Thank you so much. Life is beautiful. Be happy. Keep enjoying every moment of life, because this will never come back. Thank you so much and take care.
Hello students, myself Dr. Madani Srinivas, your dermatology faculty in this wonderful Cerebellum Academy app. So in this video, we are going to see the UPSC dermatology MCQs which are asked in 2023. So this is the first question which is related to the salmon patch, which is also called as nevus simplex, which is a birthmark. So you need to identify the true statements related to salmon patch. Yes, the usual set is nape of the neck and it is commonly seen in the children. Option 2 and 3 are right. So the first option, that is it is hemangioma, also can be considered true, though this, strictly speaking, this is a capillary malformation, but yes, previously it was considered as a hemangioma. So yes, we can consider the option 1 to be right. So answer is 1, 2, 3, that is option A. So please remember option 4, that is it needs surgical excision, is absolutely wrong. Why? Because at the most for salmon patch, the treatment which we are going to advise the patients is PDL, which stands for pulsed dye laser. Pulsed dye laser, but not surgical excision. So few points related to the salmon patch. So salmon patch is a birthmark, and you can see it is also known as nevus simplex, and particularly salmon patch present over the nape of the neck is called as stork bite. And yes, it is present at birth and it may fade over time, but it does not need any treatment. At the most, we can use PDL, pulsed dye laser. And I hope you all do remember very important syndrome, Stouch-Weber syndrome, which is again important for your pediatrics. So we can say dermatology and pediatrics integration. So this is a clinical image of the nevus simplex, where you are able to see specifically this side, nape of the neck. It is referred to as stork bites. So the answer is option A. The next question is related to Klippel-Trenaunay syndrome. And you can see the options which are true are yes. Yes, it is associated with cutaneous nevus and varicose veins and soft tissue hypertrophy. So 1, 3, 4 are correct. So the correct answer is going to be option C. Subcutaneous lipomas are not characteristic of Klippel-Trenaunay syndrome. So now let us look at few features of Klippel-Trenaunay syndrome. Klippel-Trenaunay syndrome, it is going to have cutaneous nevus or port wine stain as one of its features, which is again a type of birthmark. Don't know, the examiner of UPSC somehow are very much attracted to birthmarks. They have asked so many questions. The two questions on dermatology are related to some kind of a birthmark. Okay, so this is also again capillary malformation, just like our salmon patch. And the next one is varicose veins. So you all know varicose veins in your surgery. So soft tissue hypertrophy can also be present, where you can see there will be abnormal growth of muscles, fat and skin. Not only that, even bone also was observed to be having abnormal hypertrophy. So this is going to be the clinical picture of Klippel-Trenaunay syndrome, showing dark red purple demarcated capillary stain, as you can see here in these images. And also if you observe very carefully, then you can also see the varicose veins in this image. And in this picture, the option the B image, you can see that there is associated enlargement of the lower extremity when compared to the uninvolved limb. So this is an uninvolved normal limb and this is an involved limb. You can see that there is some kind of a hypertrophy. So these are the three features which we can see. The answer is option C. Option C. So cutaneous nevus, varicose veins and soft tissue hypertrophy. Okay, I hope this explanation was helpful. So thank you so much. Happy learning dermatology. Bye bye.
Hello and welcome to the discussion of the UPSC PYQs of anesthesia. We have some very simple questions, so we'll quickly go through them. The first one is about cauda equina syndrome and its presentation. So what is cauda equina syndrome? As you all know, this is the spinal cord and the nerve roots that come from the end of the spinal cord. They are referred to as cauda equina, okay, or the tail of the horse. Now, these nerve roots are mainly the lumbar and the sacral nerve roots. So if there is any sort of compression on these nerve roots because of a tumor or hematoma or abscess in the spinal cord, then it can cause something called as cauda equina syndrome. Okay. Now, if you're compressing the lumbar nerve roots, you can get back pain, you can get motor weakness in the lower extremities. And if you're compressing the sacral nerve roots, you can get saddle anesthesia, which is nothing but numbness in the area of the perineum. Or you can also get rectal and urinary symptoms like retention. Okay, so in cauda equina syndrome, we get all of these 1, 2, 3, and 4. So that will be the answer. The second question was, which one of the following drugs is a long-acting local anesthetic agent? So if you see, the longest acting local anesthetic agent is Debucane, which is not given in the options. After that, next we have intermediate to long-acting agents. In this, we have two agents, that is bupivacaine and ropivacaine, out of which bupivacaine acts for a longer period of time than ropivacaine. So my answer here will be bupivacaine. Your lignocaine and prilocaine both are short-acting agents. All right. So the next question is, a patient with head injury with a Glasgow Coma scale of 10 is classified as mild, minor, moderate, or severe injury. So over here, again, you need to know the classification. So we have GCS score of 3 to 8 will be severe head injury. GCS score of 9 to 12 will be moderate head injury. And GCS score of 13 to 15 will be mild injury. Okay. So here, since the GCS score is 10, the answer will be moderate injury. Next, which of the following are features of post-lumbar puncture headache? So, post-lumbar puncture or post-dural puncture headache, what is the cause of it? It happens after lumbar puncture for collection of CSF, or it happens after giving spinal anesthesia, in which you have used a very big needle and created a hole in the dura mater. So, CSF will leak out of this hole in the dura mater. And because of loss of CSF from the cranial cavity, the brain tends to sag down, the cranial nerves are pulled down, and because of the traction, you start getting a headache. The second reason for the headache is the vasodilation that happens in the cranial cavity whenever the CSF is lost. Okay, so those are the two reasons of the headache. This headache is occipitofrontal, fronto-occipital in nature. So option 1 is correct. This headache increases when you're sitting or standing because as per gravity, there is loss of more CSF in this position as compared to when lying down. Okay, so 1 and 3 are true. Option 2, the headache does not depend on the time of the day, so it is not worse on waking, improves during the day. It has nothing to do with the time of the day or circadian rhythm. Okay, so option 2 is not true. What is the treatment for postdural puncture headache? Gold standard is epidural blood patch. So answer for this will be option 1 and 3 are correct. So option C is the correct answer. 1 and 3 statements are correct. So those are the questions that we have from anesthesia. I hope you got all of them correct. Thank you so much.
Hi friends. So now we are going to be discussing the UPSC question which was asked from radiology. There's only one question that we have to discuss. So this question asks, what is the Mickey Mouse sign that has been described during the B mode duplex ultrasound? What does it comprise of? So the correct answer here is going to be C. So C is the junction. This is the saphenofemoral junction, which is basically going to be showing you the Mickey Mouse sign. So it's at the saphenofemoral junction where the great saphenous vein combines with the common femoral vein, and there is the artery which is also lying along with it. So together the three vessels look like the Mickey Mouse sign, right? So this, let's say, is the artery. This is the vein into which you have the great saphenous vein which is entering. So together it looks kind of like a Mickey Mouse, and hence the Mickey Mouse sign. So this is a repeat question from NEET as well, and hence I'm sure all of you must have gotten it correct. Thank you so much. That was the only thing from radio that was asked. Thank you. So now let's look at this microbiology question. Consider the following statements with regard to coccidiomycosis. It's a primary systemic mycosis caused by dimorphic fungi Coccidividis immitis and Coccidioides possidacea. So these are the two species, almost unpronounceable species that you want to know, which is a correct statement. So coccidio is one of the dimorphic endemic fungi that we know. The mnemonic HSBC bank that we've discussed, right? So all of those are dimorphic fungi. So this is a true statement. It usually will affect the lungs, and it can also have a joint involvement, right? So these are the two things that it tends to affect. So primary pulmonary coccidiomycosis has cough, fever, chest pain, arthritis, which is correct. And progressive can have constitutional symptoms and features of lobar pneumonia, which is also correct. Pretty non-specific statements, So it can have lobar form as well and bronchopneumonia interstitial form as well. The fourth statement now, coccidiomycosis meningitis is a mild disease. So this is definitely wrong. Any fungus, if it invades systemically, if it goes into the CSF, it is always going to be a very, very serious disease. So fourth can't be a correct statement. So just on that basis, even if you're not sure of the other statements, very logical enough that 4 is figuring in, 3 of the options. So it has to be A, which is the correct answer. Even if you're not sure of maybe statement 2 or 3, if you know that it is dimorphic fungus, the moment you figure out that 1 is correct and 4 is not correct, your answer is there in front of you. So that's the advantage of UPSC exam where, guesswork really helps. Let's look at this PSM question. Which of the following are the 5 essential components of nurturing care? Pretty factual question, which you need to know, at least a few components. So health and nutrition are definite components, right? So you can see that 1 and 2 figure in these two lists. And what you have to remember is breastfeeding is actually not a part of the nurturing care. So that way itself our answer becomes A. So the 5 components would be health, nutrition, responsive caregiving, early learning opportunities, and safety and security. So these are actually the 5 components that you have to provide a child with: health, nutrition, responsive caregiving, early learning opportunities, and safety and security. So this is what are the 5 components. So that's it for this discussion. Thank you.
All right. So let's discuss the questions that were asked in UPSC examination. Let's do it quickly. So the first question was, which of the following statements is correct as far as anorexia nervosa is concerned? The first statement is, illness is often precipitated by weight loss. Now, this is a correct statement. Intentional or unintentional weight loss can precipitate anorexia nervosa. It's a correct statement. Food avoidance is common. Of course, it's a correct statement. People are afraid of gaining weight, so they avoid eating. Body image is intact and there is no fear of weight gain. This is a wrong statement. We know that there are body image disturbances in patients with anorexia nervosa. And downy hair, lanugo may develop on back, forearm and cheek. Again, it is correct. When patients develop starvation, when there is a state of starvation, all these body changes may happen. So, statement 1, 2 and 4 are correct. So, our answer is option number B. Alright. This is a difficult question. Which of the following genetic causes are commonly associated with autism spectrum disorder? Students, please remember Fragile X syndrome and tuberous sclerosis. These are the two syndromes which are most commonly associated with autism spectrum disorder. 90% of the times, if they ask a question on syndromes, the answer would be one of these. Most common is Fragile X syndrome, and then there is tuberous sclerosis. Apart from these, there are other syndromes which are occasionally associated with autism spectrum disorder, and one of them is Angelman syndrome. So, Fragile X, tuberous sclerosis, Angelman syndrome. Williams syndrome is not so much associated with autism spectrum disorder. So, the better answer is 1, 2 and 3. Right? Which of the following is categorized as specific learning disability? So, it's not dysphoria. What is dysphoria? It's a mood state where the person is irritable. Dysthymia, we know, is a form of depression, mild depressive symptoms which continue for more than 2 years. Dystonia is a side effect in context of psychiatry, sudden contraction of a muscle. And dysgraphia is where the child has difficulty in writing. So the answer becomes dysgraphia, option A. I'm sorry, my pen is not working, but the answer is option A, dysgraphia. Dysgraphia. You also know of dyslexia, right? In dyslexia, the child has difficulty in reading. In dysgraphia, the child has difficulty in writing. So, dysgraphia is one of the specific learning disability. The answer is A. And finally, which of the following drugs help to maintain abstinence by reducing craving for alcohol? So, the two main drugs which help in maintaining abstinence are naltrexone and acamprosate. Acamprosate and naltrexone. So, the answer here is option B, acamprosate. So, these were the questions that were asked in the UPSC examination.
Hi friends, this is Dr. Apoor Mehra. Let's have a look at the question that came in orthopedics. The question says, which of the following abnormalities can occur from vitamin D deficiency in children? So, vitamin D deficiency in children is also called as rickets. Rickets will have normal to low calcium levels in the blood, decreased phosphate levels. Because there is a mineralization defect, so the bone tries to increase compensation, so alkaline phosphatase and serum PTH levels are high. Remember, the renal rickets is the only rickets where the phosphate levels are high, otherwise in all other rickets the phosphate levels are low. Rickets being the mineralization defects. The earliest feature is ping pong skull, also called as craniotapes. That's the first feature. Prominence of the bony ends is also seen, and muscles are weak because calcium and phosphate vitamin D are required for the muscle action. The important radiological feature in rickets that you see is that at the bony ends there is cupping. So the bony ends, they look like cupping. The bony ends are splayed, so they are widened. So the bony ends or the metaphyseal ends has a cup shape, widened, and the ends, they look out, called as flaring. So there is cupping, splaying and flaring, which is a part of rickets. So rickets has cup, splay and flare. So widening is rickets, cup shaped, widened and flare out. What is not affected in rickets is the epiphysis. Epiphysis is normal in rickets. The epiphyseal margins becomes dense, radiodense in scurvy, but they are never affected in rickets. So remember, epiphysis paired. That's why fourth is wrong here. So the answer is 1, 2 and 3 being correct. That's all I wanted to speak about this question. Thank you very much.